Good afternoon. Welcome to the Health and Government Operations Committee. We appreciate you being with us today, and we have a lot of bills on the agenda, so I will tell you in a minute the order. First, I would like to welcome everyone and our members. Thank you so much for being on time. The staff, thank you for helping us in council today. Thank you very much, Lisa, Ms. Lisa Simpson. Is the council for these bills. I am your chairman, Jocelyn Pena-Milnick, joined by my wonderful vice chair, Delegate Bonnie Collison to my left. I kindly ask for your patience if we encounter any technical or streaming issues during the hearing. Sometimes it happens, so just be patient. Please set your electronic devices to vibrate. I'm going to do that right now so that I'm not embarrassed. Although I embarrassed myself yesterday with it. If you have to have a conversation, please step outside. As a reminder, there's no food or drink allowed in the gallery because then staff has to clean it up. You will see us drink because we're here for hours and we have to stay hydrated. Otherwise, there will be no hearings tomorrow because we will all be sick and dehydrated. For each bill, we're going to hear from the bill sponsor and the sponsor panel, followed by an all in-person witnesses. So it goes this way: favorable with amendment, and unfavorable, and I will call different panels. Then all virtual witnesses, because we have witnesses that are virtual as well, will be favorable with amendment, and unfavorable. In this committee, the bill sponsor testimony is not limited. While all witnesses have 2 minutes to provide testimony, and you'll see that there is a timer that is displayed on the screen and a sound will play when your time has expired. Although we don't time you, don't abuse it, please, because then I have to cut your testimony, okay, and interrupt you. And I don't like to be rude. So please be conscious of that. For our committee, who has been doing an amazing job, please adhere to our usual committee rules of 1 question and 1 answer, and please keep your questions brief. Members of the public will be able to view the live stream of these hearings on the Maryland General Assembly website and on YouTube. Okay, someone is embarrassed, just kidding. Today, we will hear the bills in the following order. And I say that, but I will have to, the Secretary of Health is testifying in the Senate and here. So when she comes in, I have to call the bill that she's here to testify so that she can go back. So I would like you to be patient with me as I try to accommodate our witnesses and our members who you'll see them coming in and out. It doesn't mean that they're being disrespectful, is that they have hearings in other committees, but we have access to the recording and we read everything and we watch everything. So thank you for understanding that. So the bill hearings will start. We're going to start with House Bill 171. Delegate Gayton, will you please come up? Delegate Gayton, come up with your panel, please, while I call the other bills. House Bill 381, followed by 378, followed by House Bill 570, followed by House Bill 628, House Bill 400, House Bill 728, and House Bill 340. Again, I may have to switch it around, but this is the order for now at 109. Okay, good afternoon. Do you have a panel?
I have a virtual witness.
Okay, wonderful. How are you today?
I am doing great. Thank you, Madam Chair, and thank you, members of the Health and Government Operations Committee. It's great to be here. So many friends on this committee.
Thank you.
So, may I begin?
Absolutely.
Okay, I want to thank you today for your consideration of House Bill 171. I am Delegate Michelle Guyton from District 42B in Baltimore County. This bill adds a veterinarian to the Maryland Board of Pharmacy. Why, you are asking? Well, let me tell you. It's important to have veterinary representation on the Board of Pharmacy because there's an increase now in veterinary-related pharmaceutical bills across the country and regulations from the FDA and DEA that are impacting veterinarian access to appropriate medications for their animal patients. Okay, whether it's access to life-saving compounding drugs that's become much more difficult for them in the past few months, or legislation in neighboring states like West Virginia, which began regulating drugs like xylazine. We need to be prepared in Maryland for this ongoing and changing conversation. It's also important to have veterinarians who are actually working in the trenches with the animals as part of the conversation, because pharmacists are often unfamiliar with medical dosages for animals and the usage of the commonly prescribed drugs in the animal kingdom. Right. In some instances, they're unable to fill the prescriptions because they exceed human dosages, but you don't need human dosages when you're treating a horse or an elephant at the zoo. Right. Many pharmacies don't even compound their own drugs, and they send them out, and they don't have the expertise required to compound medications for animals. So the Journal of American Pharmacists Association themselves in November of 2021 published a report that showed that there were problematic numbers of errors in veterinary prescriptions that are filled in community pharmacies. So they even recognize this to be a problem. And one of the reasons for that is that according to the National Center for Biotechnology information, 9 out of 10 pharmacists reported no training in veterinary pharmacy. So you heard a departmental bill earlier this year, I believe it was 57, asking to add veterinarians to the prescription drug monitoring program, in which the testimony, which was presented by the Deputy Secretary of Public Health, said, and I quote, "When any practitioner can prescribe a controlled substance, they are essentially functioning as a pharmacist." So, and yet there is no veterinary representation on the Board of Pharmacy. And because of all these issues are problems for our local pharmacies and for our animals and pets, I asked for a favorable consideration and report on House Bill 171.
Thank you, Delegate Guyton. I'm going to call the virtual witness. Will you be so kind and bring them up? Thank you. And then we'll open it up for questions, Delegate, okay?
Thank you, Madam Chair.
You're welcome. Good afternoon. Do I have Dr. Jane Brunt? Will you be so kind and start your testimony? Are you there?
And now I'm unmuted. Thank you very much.
That will help. It's okay. I do the same thing. You think we will get it after all this time?
For sure. Thank you. Well, thank you, Chair Pena-Melnick, Vice Chair Cullison, and members of the Health and Government Operations Committee. My name is Dr. Jane Brunt, and as a practicing veterinarian and member of the Maryland Veterinary Medical Association, I'm pleased to personally support the passage of House Bill 171 to include a veterinarian on the State Board of Pharmacy. And Delegate Guyton said it well with the question, why should a veterinarian be on the State Board of Pharmacy? And my answers are pretty straightforward. First, our veterinary education included at least one semester in pharmacology, and some veterinarians go on to become board certified specialists in veterinary pharmacology. And we all have medical degrees and hold licenses, registrations, and certificates that allow us to prescribe medications. Furthermore, veterinarians prescribe medications judiciously for the animals under our lawful care, and the inclusion of a veterinarian on the State Board of Pharmacy is an important step in enhancing patient care, protecting the public, and even our environment. In fact, the FDA has a Center for Veterinary Medicine, which, along with the USDA, allow for vaccines and various medications to be improved and licensed in animals. One example showing the benefit to including a veterinarian on the pharmacy board is in feline medicine and the commonly prescribed systemic corticosteroid prednisolone. Not prednisone, a precursor that requires metabolism in the liver. Well, cats lack the ability to do so and can have adverse effects as a result. Related to that, I had a client who was a physician write his own prescription for his own cat for prednisone because prednisolone was more costly. It was dispensed by the pharmacist, who also did not know the mechanism by which it became bioavailable. Other experiences by veterinarians include pharmacists refusing to fill prescriptions, claiming that they'd written the incorrect dosage. I personally have a great relationship and multiple relationships with corporate and independent pharmacists, where we've been able to discuss what an animal patient needs and reach a good outcome. I hope the same will be true of the relationships on the State Board of Pharmacy, and encourage you to lead to a positive outcome when HB 171 is enacted. Thank you.
And thank you for being here and taking the time to come in front of us.
Important.
Delegate Guyton, at this time, I'm going to open it up for questions for the committee. Are there any questions for the delegate and her panel? I see Delegate Chisholm, followed by Delegate Johnson, and followed by Delegate Morgan and Delegate Kaiser.
And thank you, Della, for bringing this bill. I just have a question, since you're there. There's a letter in here from the Maryland Pharmacists Association, just an informational letter, but it states that there are currently 4 seats on the Board of Pharmacy that have a viable pathway for veterinary pharmacists to serve, 2 seats for pharmacists that primarily serves in the independent pharmacy setting, and 2 seats for the pharmacist at large. Being that that is the current case, do we have any veterans that have followed that pathway? And have we had any veterinarians that have, not veterans, veterinarians that have?
You're like me yesterday. I couldn't say that word. I couldn't even remember it today. It has something to do with heredity.
Heredity.
Yes. Heredity.
And has there been a major push from the veterinarian community that they'd like a seat at the table, but haven't been able to? Because it seems to me like there's already a pathway, but they're obviously not following it.
Yeah, I thank you a lot for that question, because I did not address that in my testimony. I should say that I have the word vet written through my testimony, and every time I come across it, I have to think about what I'm saying. But if you also look at the letter from the actual Board of Pharmacy that you have in opposition to this, they say that they would never consider a veterinarian as a member of the Board of Pharmacy, which just completely is the opposite of what the association is telling me is possible. And so because of I don't know if they had applied and not been chosen, to be honest, because we don't have that information. But I do know that this has become an increasingly problematic situation for them more recently than it has been in the past, and that's why they're pushing now. But I think leaving it up from my conversations with these groups, and I have had them, I try to do my homework. The veterinary, again, same thing. The Pharmacy Association says, yeah, okay, they can apply. The actual Board of Pharmacy says, no way will we allow them to serve. So that's the problem we're looking at here.
Yeah. Sure.
And we did hear a bill on the MDP, and it seemed to me like the veterinarians really didn't want to be involved and lumped in together because it caused a lot of undue burden to them. And maybe, I guess my point is, from your conversations with them, are they trying to get onto the board and just haven't been able to, or have you not had that conversation?
No, they just testified, the veterinarian association then just testified that they did want to be a part of this conversation. It has been very difficult for them to be acknowledged and part of it up until this time. So this is not necessarily the first and best way to remedy that situation, but at this moment, it seems to be the only way that has been suggested. And I've asked the Board of Pharmacy to suggest another way, and so far they have not.
You're welcome. Delegate Johnson, followed by Delegate Kaiser.
Thank you, Madam Chair, and thanks for the bill. I really like this bill because it's definitely needed. I mean, more pharmacies are filling more pet prescriptions. The doses and stuff are very confusing. So do you see if we added a veterinarian to the board, it could even be more of an educational piece too with the rest of the board?
Yeah, thank you for that question. I really appreciate that, particularly since I know that you are an actual pharmacist. So you understand the complexity behind this. So I appreciate that. Certainly, because I think as I mentioned, veterinarians, and as Dr. Blunt mentioned, veterinarians are trained in pharmacy, in veterinary pharmacy. Pharmacists are not trained in veterinary pharmacy. So for them to have to shift that responsibility in so many cases, like your own pharmacy, to compound those more complex drugs, in many cases, through no fault of their own, their training does not teach them that, and they don't know what they're doing in that arena. So yes, it would be a good opportunity for learning.
You're welcome.
Yeah.
Delegate Kaiser.
Thank you, Madam Chair. I had hello, Delegate Guyton. I had a similar question to Delegate Chisholm. And I was looking not just at the Maryland Pharmacists Association letter of information, which is actually a letter of opposition, which they misnamed, but also the Board of Pharmacy's concern, just saying that they have multiple ways for people to express their concerns, including just writing a letter or something else. How would you respond to that?
Thank you, Delegate Kaiser. I would respectfully respond to that, honestly, by saying many of us also tell our constituents that, especially when they don't agree with us. And sometimes that works to their favor and sometimes it doesn't. So I'm not sure that just telling a whole group of people who are functionally affected by this really important concern to write a letter is an appropriate response.
Thank you. Vice Chair Collison.
Thank you, Madam Chair.
You're welcome.
And thank you as a pet owner. So first of all, the letter that we have in our system from the Board of Pharmacy is not the letter that goes with your bill. It's the letter that goes with my bill. So, right. One of them does? Okay. I hadn't seen the
Well, they
other
do
one.
have a letter.
Right. So,
Okay.
there's a way you would be able to not expand the board, but take one of those existing seats. So if expansion is the issue, that they're worried that the board will get too large, there are 4 potential seats. There are 4 potential seats,
Yeah.
one of which could be assigned to a vet. Are you aware of other boards that have assigned seats for different categories of professional?
Yes, thank you for that, Delegate Collison, Vice Chair Collison. Absolutely, they do. My experience on the Board of Education is yes, there are assigned seats, for instance, to the teachers union, to a teacher for specific, and this is also through, I think, many of the other boards. So that is not unusual. And I'm not as concerned about the expanding the numbers from 13 to 14, I believe it is. But just having that voice on the pharmacy board that is respected.
Haven't seen the Board of Pharmacy's
Well,
letter. So what
Yeah,
is
they
their-
really don't like it.
Well,
Yeah.
Do-
I'll
do
just
they
put it
give-
out there.
Do they give a specific objection?
Yes, ma'am.
What is
I
this?
mean, if you'd like for me to tell you what it is.
Just if you can do it in one sentence, what's the?
Because it really does contradict the other letter that you have of information, which might actually be opposition. That letter states, excuse me. Yes. Let's see.
I just gave it to the delegate
Sure. Oh, thank you. Thank you.
and it deals with expansion.
The information that we have,
We got it. It
Oh,
deals with
okay. I'm sorry.
expansion.
right. I think the thing that did stand out to us, though, that was in opposition to the the Pharmacy Association, was that they made the point that they wouldn't allow someone on a board where they could not also be a part of their board. That's in another letter that they have written, which doesn't make any sense to me. And that they also did not consider them pharmacists. So, I mean, I think that's the big crux of it right there.
Thank you very much. Any other questions?
I just felt.
Seeing none, thank you very much. May I ask, is the Board of Pharmacy in the audience today? Is there someone from the Board of Pharmacy? I know that they did not sign up to give testimony orally, but you did submit testimony, written testimony. Anyone from the Department of Health? All right, I don't see anyone here. So this is, what I would like to do is we will contact them and see if we can get in writing that they will, the next slot that is available, that it will go to a veterinarian. And then we can withdraw the bill. Because there's no need for the bill if they can agree and give it in writing that they will do it. Especially when I read their letter and it says that the veterinarians actually have the same education as a regular pharmacist. And I believe that adding a veterinarian brings a different perspective as well. So we
Right.
handle it from our end.
Okay,
If you could just be in touch with our office and let's see if we can get that done.
absolutely. Thank you, Madam Chair.
Thank
Thank you,
you.
HGO Committee.
And this actually will conclude the bill hearing on House Bill 171. Next, we're going to move on to House Bill 381. Delegate Hill, will you be so kind and bring your panel, State Board of Examiners in Optometry, Criminal History Records Checks. Good afternoon, Delegate.
Afternoon, Madam Chair, and I believe the witness is virtual for the board. Okay.
I'm so sorry.
Good afternoon, Madam Chair, Madam Vice Chair, colleagues. For the record, my name is Terry Hill, and not for the record, my name is still Terry Hill. And I'm here to present HB 381, State Board of Examiners of Optometry, Criminal History Records Check. This bill is pretty simple. It simply would allow the state board to require at the time of licensure that a criminal records check be carried out, which is consistent with what most, but not all, of our current health boards require. It also would allow the board to receive reports from the FBI's Wrap Back program. And I think in my written testimony, I said that they would get reports with respect to arrest, charges, and convictions. That is inaccurate. They would only get information about convictions. That being said, I have spoken to the Board of Optometry because I had some concerns. Those of us who have been here for a while will remember back in 2016, 2015, we were very concerned about the use of criminal background checks and how they seem to prevent people from getting jobs that they should otherwise be qualified for in a rather non-discriminatory manner. At that point, we passed legislation in most of our health boards now have language that states that when a criminal record is obtained, background check record is obtained, if there is a conviction, that the board must take into account a number of factors like the nature of the conviction, the number of years prior to the applying for license, and whether or not there is a nexus between the crime they were convicted of and their responsibilities as a licensee. So we want to make sure that we're using background checks appropriately so that someone with a conviction, for instance, for car theft is not prevented from, in this case, from dispensing glasses or making a prescription for glasses because there really is no nexus there. So the board has agreed to an amendment to add that language that has been promulgated in the state professional licensure medical boards since 2016, almost verbatim, that talks about the types of things that the board should keep into consideration in determining whether a prior conviction should be used to prevent someone from receiving a license. And with that, I ask for a favorable report and note that the fiscal note is 0 and there is no opposition.
And you worked it out.
Worked it all out.
All right. Are there any questions for the delegate that worked it out? Seeing none, thank you very much. We're going to go on to favorable with amendment. It is virtual. Will you be so kind and pull them up? Thank you. Good afternoon. Are they there? Good afternoon. Will you be so kind and unmute yourself?
Okay.
Hi.
Hi.
How are
good af-
you?
I'm fine. I'm fine. Thank you so much for having me. Good afternoon, Madam Chair, Vice Chair, Delegate Hill and other delegates and everyone present. Oh,
We can hear you and see you perfectly.
okay, perfect. Thank you.
Okay. Go ahead, you can continue.
Okay. My name is Dr. Kelechi Mezu Nabwe, and I'm here on behalf of the Maryland State Board of Examiners in Optometry to support House Bill 381 with amendments. The reason the board is bringing this bill is because it allows us to continue our mandated responsibilities of protecting the citizens in Maryland. And as Delegate Hill explained, this bill would be on a case-by-case basis when a criminal check comes for an applicant for licensure with the board. We will be able to consider one-on-one what is going on, what they were convicted for, and the decisions will be made based on that. There are currently 15 health boards that require licenses to complete a criminal background check. Our board recognizes its role to protect the health of the public and safety of consumers through the licensure for optometrists who want to practice optometry in Maryland. I am asking for a favorable reading on this bill because if we can pass this bill, House Bill 381, it would allow the board the ability to protect the public properly because we would be able to investigate an applicant, look at the criminal history, and we would be able to ask applicants to do a criminal record check only when they are applying for licensure. And that's it. Thank you very much. And I'm happy to answer any questions.
Sure, and for coming and being with us. Are there any questions for the doctor? Seeing none, thank you so much. We hope you have a great day. This bill will be assigned to subcommittee, and you're welcome to come to the subcommittee as well. All right, and Delegate Hill can inform you when that would take place. This actually concludes the bill hearing on House Bill 381. Next, we're going to go to House Bill 378, Delegate Gazzoni, State Board of State Board of Dietetic Practice, Dietitian, Nutritionist, Licensure Requirements, Dietetic Practice. Finally got it right. Go ahead. Good afternoon. How are you?
Good afternoon. I'm fine, thanks. And I've struggled with the dietetic word too, particularly when I'm trying to spell it. So good afternoon, Madam Chair, Madam Vice Chair, and members of the Health and Government Operations Committee. I'm Delegate Pam Gazzoni, and I represent Howard County's District 13. I'm here in support of House Bill 378, which alters the educational requirements to be a licensed dietitian. The bill also amends the statute to reflect the names of both the Dietetic and Nutritionist associations. HB 378 will modify the State Board of Dietetics practice statute to reflect updated requirements to sit for the national examination for dietitians. Going forward, the Commission on Dietetic Registration degree will require, registration degree requirements will change from a baccalaureate degree to a graduate degree. A sponsor amendment has been submitted, and I actually have it, to address concerns raised regarding already licensed dietitians who do not have a graduate degree. As I think the panel will share, the board worked closely on the amendments with the Maryland Academy of Nutritionists and Dietitians to ensure concerns about grandfathering were remediated and in the amended language of the bill. With the amendments, the requirements for licensure going forward are clear, and I respectfully request a favorable report on HB 378.
Thank you for bringing this bill. Who's going to be next?
Good afternoon. My name is Marie Savage, and I'm the Director of the Maryland Board of Dietetic Practice. And we're here today in support of House Bill 378 with the amendments. As of January 1st, 2024, the Commission on Dietetic Registration did change their degree requirement from a bachelor's degree to a master's degree. Therefore, the board needs to change our law to be reflective of that change. We realized that the commission recently came out and said that they're going to grandfather anyone who's currently registered dietitian who has applied to sit for the exam. So we wanted the amendment to reflect that there is a grandfathering provision in our law. The other amendments deal with a technical change. The Association for the Nutritionists, the American Nutritionist Association, changed their name, and the Board for the Certification of Nutrition Specialists also had a name change. So we wanted our law to be reflective of those changes. I'm here to answer any questions you may have.
Thank you.
you.
Next, please.
Hi, I'm Lauren Weber. I'm a registered dietitian. I also sit on the Board of Dietetic Practice. I am in support of the bill with amendments, and I don't really have anything to add to what Marie has already said or our delegate, but I am here for questions.
And we love that testimony. Those are me too. We
Ditto.
love them so much. So next we have two virtual witnesses as well that are part of the panel. So will you be so kind and bring them up? Two? Thank you. Let me know when they're up. And thank you for your patience, okay? Thank you. Good afternoon. Let me know when they're up. Ms. Snow, Rebecca Snow, will you be so kind and get started? And welcome to the Health and Government Operations Committee.
Hi, I'm Rebecca Snow. I'm the board chair of the Maryland. Good afternoon. I'm the board chair of the Maryland Board of Dietetic Practice.
I think, will you be so kind and turn off your YouTube channel? Because it gives feedback and then we can take your testimony.
I apologize.
It's okay, it happens.
Yeah. I'm here to support House Bill 378 with amendments. I don't really have anything else to add. And the bill with amendments supports changes to our two national credentialing bodies, the American Nutrition Association and the Academy of Nutrition Dietetics. So I'm happy to answer any questions. Thank you.
Again, we love the Me Too. Thank you very much. Thanks for being here. Will you please there's another Jessica? Jessica Keel, is she on? Yes, hi, how are you?
I'm very well. Great to see you again.
Nice to
Thank
see
you for
you.
coming to our advocacy day yesterday and talking to the dietitians yesterday. We really
It was
appreciated
fun.
that. Yeah, we enjoyed it a lot too. I had a beautifully eloquent speech prepared, but Marie did such a great job presenting the amendments as did Delegate Gazone, that I'm just going to go ahead and say me too. I represent the Maryland Academy of Nutrition and Dietetics. I'm our public policy coordinator, and we're very much in agreement with supporting this bill with amendments as were outlined by Marie and the Board of Dietetic Practice.
You get an extra apple for saying Me Too. So are there any questions for this panel? Seeing none, thank you so much. Thank you for all you do, okay? We appreciate you. And this actually concludes the bill hearing on House Bill 378. Next, we have House Bill 570, Delegate Kipke. Health maintenance organizations payments to non-participating providers reimbursement rate. Delegate Kipke, will you be so kind and bring your panel if you have one? And I believe I have here Barbara Brocado, Reginald Brown, Daniel Shattuck,
Hey.
and Ms. Kaufman, if she's here. Donna Kaufman.
Thank you, Madam Chairman, and good afternoon, members of committee. House Bill 570 seeks to establish some leverage in the HMO arena for providers who actually want to be a network. Currently, the system does not have a meaningful incentive for HMOs to create a sufficient provider network because their cost for non-participating providers is capped at a very low rate. So to do nothing certainly benefits their position, but unfortunately does not benefit our constituents who happen to participate in an HMO. I want to draw your attention to several written testimonies that's in our file, one from the Legal Action Center and the other from the Maryland Community Health System. I think their testimony is the best testimony in support of this because they are the individuals who are advocating for our constituents, the people who are living with, gaining access to their health needs through their HMO policy. Certainly providers want to be in network, and this bill seeks to provide them with a little bit of leverage so that they are actually having fair negotiations with the carriers. So with that, I urge the committee a favorable vote. And I thank you for your time.
Delegate Kipke, who would you like to go next?
We'll just go to my right.
All right, wonderful. Good afternoon, Mr. Brown. How are you?
I'm doing well, thank you. Good afternoon.
You can get started.
Good afternoon, Madam Chair and Committee. I'm Dr. Reginald Brown. I'm here as part of the Board of Maryland ASAP and representing 500 physicians and advanced practice practitioners for our group U.S. Acute Care Solutions. U.S. Acute Care Solutions, my mission is simple: to care for patients. As a general practice, we've tried to remain in network prior to the No Surprises Act, and we felt we were in good position to continue those partnerships going forward. However, some of the insurance companies have stepped away from the table and forced us out of network. As a general practice, we do not balance bill. We serve as the front line for your patients or for your constituents in Maryland, in our local emergency departments, and we're the safety net for all of our healthcare here in Maryland. We're partnering with everybody in this legislature to attack the wait times in the emergency departments, but staffing is critical to that. And we know there have been challenges in staffing for not only the physicians, but our nursing staff as well. This bill supports the emergency staff as well as other hospital partners and specialists. So we urge you to support House Bill 570. Thank you for your time.
And thank you, Dr. Brown, for your testimony. Next, please.
Madam Chair, members of the committee, Barbara Brocato, here in support of House Bill 570 and on behalf of U.S. Acute Care, Maryland Society of Anesthesiologists, Maryland Psychological Association, American Physical Therapists Association of Maryland. The state of Maryland has a long history in passing laws to work toward reasonable rates. Maryland's physician reimbursement is in the lowest 5% in the country. There are huge recruitment and retention problems in this state. We have shortages across the board. And let me tell the committee, we in Maryland have a formula that works. After many, many years, in 2010, this legislature passed a formula in the PPO market, and this bill is modeled after that formula. That formula has a date certain, which was January 1, 2010, and the formula is that the provider is paid the greater of 140% of the average contractual rate, or what they were being paid January 1, 2010 with the medical economic inflationary factor. The out-of-network rate at the time of the passage of that bill was 36% for hospital-based physicians. After 10 years, that 36% in 2017 was down to 3.6%. It worked. The current HMO law has no provision from lowering the HMO rates to providers year after year. This law creates a date certain benchmark that will help improve things. We have a law that works. This law's passed, this bill's patterned after it. Glad to answer any questions. Thank you, Madam Chair and Committee.
Look at that timing. Wow, that's a pro. Go ahead.
Thank you very much, Madam Chair. Members of the committee, my name is Dana Kaufman. I'm here on behalf of the Maryland chapter of American College of Emergency Physicians, and for MedChi, we support this legislation. As was said earlier, the physicians, just like all the other businesses that you have heard, are having not only just hiring issues for their, not just their physicians, but for their staff. They have issues with inflation, dealing with medical surpluses. And what this bill is trying to do is set a level playing field for the rate of negotiations. The bill does two things, and I don't want to overlook the second. Not only does it set a date certain, but it also adjusts for inflation. The current mechanism in the law does not adjust for inflation, and that is a very important aspect of this. I also want to reemphasize the fact that Maryland's law does not allow HMOs to balance bill. They have never been able to balance bill even before the introduction of the Federal No Surprises Act. So I just want to make that very clear that the bill is not about balance billing. It's about fair reimbursement. As Ms. Brocato said, Maryland, unfortunately, is well known for having very low physician payment rates. There was a study done by the Healthcare Institute a few years back, and it compared the commercial rates across the country to Medicare and where those rates fell. Maryland was third from the bottom. The only two states that were lower than us were Delaware and Alabama. That is not something that we should be proud of. We have laws for adequacy in network, but we also need to make sure that there are laws for payments. And that way, then this law doesn't take effect. If physicians can feel confident when they're in network, you don't need to have a law for non-participating out of network. So that's what this bill is trying to do. We urge your support. Thank you.
Thank you. I'm going to open it up for questions now. I see that Delegate Hill, Delegate Kaiser, Delegate Johnson, and Delegate Woods.
Chair.
My pleasure.
Ms. Kaufman, Medicare rates don't always go up, right? So we have Medicare rates that are coming down, coming down, coming down. Can you explain what that means under the current situation and how this bill would address that? So even though inflation goes up, rates are going down.
So the Medicare rates last year got cut 3%. And then it's anticipated, unfortunately, that Medicare rates will get cut another 2 to 3% this year. So this bill bases it, and hopefully I don't.
January 1, 2019.
Well, yes, but it's based on your rate from the preceding year of January 1st, 2019. So when I mentioned the Medicare, that was just a study to do a benchmark, but this bill doesn't base it on Medicare. It bases it on the preceding year of January 1st, 2019. And that date was chosen, it's my understanding, because of a date that is in the No Surprises Act. Again, HMOs, we can't balance bill, but the No Surprises Act for a rate that's already in that law. So frankly, I think it was done so to make it as a date that the insurers would be familiar with, but I think we're open to another date if they'd like to propose that as well.
Yes.
Thank you, Ms. Mercado. Does this protect providers from having, as Medicare goes down, that they get paid less and less and less as the cost of practicing Medicare goes higher and higher and higher in any way?
So I'm looking at the formula that's in law, because the formula in law is not based on Medicare. The formula in the HMO statute is 125% of the average rate in that the HMO paid, not on Medicare. And so without this bill, the payers can ratchet that commercial rate down and down and down, and there's no protection. That's why we need this change.
Delegate Kaiser.
Thank you, Madam Chair. Delegate Kipke, you've done something amazing. You've got the unions and the business community against this bill. I mean, they're together. In both their letters, they're worried about the costs to the employers and to the employees. And I was wondering if you could address that concern.
You want to do it?
Can I address that, Delegate Kaiser?
Whoever is the best person.
I am a little perplexed about the state employees' opposition, because this law applies to commercial plans. State employees are not subject to this law. The state may decide they want to comply with this law, but I think you'll see that there's no fiscal impact because this law does not apply to state employees.
You may have a follow-up.
Thank you, Madam Chair. That answered half my question. The Chamber of Commerce, the business community is also opposed, worrying that it impacts employers and employees, and they are not talking about state employees. So might you have an idea there?
I think if you read the letter from the Legal Action Center and the Maryland Community Health System, it will shed some light on additional issues. Of course, cost is extremely important to keep it affordable. But if you have a plan that doesn't provide you with any in-network providers, it's not really helping you either. And those two letters go into great detail as to the challenges in that arena.
Thank you. I have Delegate Johnson, followed by Delegate Woods.
Thank you, Madam Chair, and whoever's
Welcome.
best to answer. So I want to be clear, Is the state health insurance plan required to conform to Maryland insurance law?
No, Delegate Johnson, not by law, no. Thank you.
My pleasure. Delegate Woods.
Thank you, Madam Chair.
You're welcome.
I think this is for Ms. Provider, also. What was the impact on out-of-network services when the PPO law went into effect in 2010?
Well, you know, I'm going to tell you, but just because I have the opportunity. In 2010, we debated this issue in the PPO market for 3 years before we got a bill passed. When it passed in 2010, the CEO of the dominant carrier in the state of Maryland said, this law is going to result in me not having a single hospital-based provider in my network. And I think before the clock ran out in my earlier testimony, I was able to say, when the out-of-network rate before that law went into effect was 36%, which is a high out-of-network rate. There was so much opposition, there was a sunset put on it, and the Maryland Healthcare Commission was asked to do a study. When that study was done, 5 years out, that 30-some%, I don't know if it's 34, whatever, went down to 17. 5 years later, in 2017, they did a study and it went down to 3.6%. Yesterday, I called Ben Steffen to see if we had updated numbers. We didn't, he's going to get back to us. So we in this state solved a problem. We solved a problem that has been debated since 1988. And we're asking you to do the same in the HMO market.
My pleasure. Any other questions for the delegate and his panel? All right. Seeing none, thank you very much for being with us today.
Thank you.
Thank you.
Now we're going to call an unfavorable panel, and that is Ms. Tricia Swanson, Allison Taylor, and Matthew Celentano. Will you be so kind and come up and provide your testimony? Good afternoon.
Good afternoon.
You are in the hot seat. Okay, so who would like to be brave and start?
I'll start with the hot seat.
All right.
Good afternoon, Madam Chair and members of the committee. My name is Allison Taylor. I'm here on behalf of Kaiser Permanente, respectfully in opposition to Senate Bill 487. As you can see, many of the primary proponents of this bill are emergency physicians, and wanted to give some background to start with on some of the patient protections that are in place with respect to out-of-network emergency services. The Affordable Care Act requires health plans to provide members in-network rates for emergency services, regardless of whether their provider is in-network. And that's the right policy because you don't know for sure where you might end up in the emergency department, and so want to protect patients who might accidentally end up in a hospital where they're out of network. The No Surprises Act extended that by preventing emergency providers from balance billing members for the same policy objectives. We see this bill as a backdoor way around the No Surprises Act by taking the mandated out-of-network reimbursement rate back to before when that law passed. HMOs are already required to pay out-of-network ER physicians 25% above market rate, which can make it difficult to bring providers in-network. And this exacerbates that. I did want to speak to the question that was asked about the application of state law to the state employee health plan. I think it depends on whether the plan that the state picks is fully insured or self-insured. There is a fully insured option, which is the Kaiser plan, and so that is subject to state law. And I think in practice, even for the self-insured plans, the state of Maryland typically requires the same mandated benefits and compliance with state law. So respectfully request an unfavorable report. Thank you.
Great time. Let's see if the next person can do that as well. Who will be next?
I will follow that. Madam Chair, Madam Vice Chair, members of the committee. My name is Tricia Swanson, and I'm Director of Government Relations for Care First Blue Cross Blue Shield, here in respectful opposition. I won't repeat the remarks that my colleague made, but we're in full agreement with that. And I'll just add, from the operational perspective, as you heard, Care First has a concern around specifying it to a specific date. Right now, we take the annual rate of the given year prior and look at the average rate. And so tying it to a specific date for My Care First folks was concerning. But I heard in the proponents panel that they were willing to look at potentially changing that or looking at a different date, and certainly willing to talk to them to see where we can maybe come to a compromise. Thank you.
Thank you. We love that here. Who's next?
Madam Chair, members of the committee, Matt Celentano here today on behalf of the League of Life and Health Insurers in opposition to House Bill 570. We believe that this legislation would do nothing except raise costs for consumers with zero benefit to them. It won't improve care. It won't improve care coordination, and only increases rates emergency service providers can charge HMOs. As you all know, the whole point of an HMO product is that consumer accepts a narrow network with the same rich benefit structure you would get in a PPO product. This legislation sort of threatens that affordability choice. As you all know on the committee, the No Surprises Act in Congress was passed to prevent providers from balance billing consumers for services provided in in-network situation or out-of-network situations. This bill seems to want to undo that or reverse engineer that consumer protection law by indexing the reimbursement rates to 2019 prior to the enactment of the No Surprises Act. It's an end around on a significant piece of consumer protection legislation from Congress, trying to protect unknowing patients. And that impact of this legislation would result in higher bills for consumers, increased premiums, as well as disincentivizing provider groups to join HMO networks. I also want to reiterate what my colleague to the right, Allison, said about the state health plan. They generally follow the wise decisions that are made on this committee, and they do adopt the decisions that you all make. So for all those reasons, we would ask for an unfavorable report on House Bill 570. Thank you.
Are there any, thank you for being here today. We appreciate it. And you guys did quite well. Are there any questions for this panel? Seeing none, I do have a suggestion. I'd like you to meet with the sponsor, and I want you to look at some possible tweaks, perhaps the date or something. If you can sit down with him, I really would appreciate that, okay?
Always happy, Madam
Absolutely.
Chair.
Thank you very much.
Thank you.
Delegate Kipke, the ball is in your court. Thank you. This actually will conclude the bill hearing on House Bill 570. I am now going to call House Bill 728, Delegate Collison, Health Insurance Qualified Resident Enrollment Program Access to Care Act. Will you come up with your panel, please? And I believe that on your panel,
Ms. Ripken,
you have the HSCRC, Ms. Deborah Ripken. We have the Maryland Department of Health Secretary Laura Herrera Scott, the Maryland Health Benefit Exchange, Johanna Fabian Marks, the Maryland Health Benefit Exchange, Amelia Marcus, the Maryland Insurance Administration, Commissioner Kathleen Bahrain, and Ben Stephan from the MHCC. If you could bring some chairs up, be nice and cozy. We can get started.
thank you, Madam Chair. We're missing the Health Benefit Exchange, but hopefully she'll be here shortly.
Okay.
It's just Ms. Fabian Marks who will be
Okay.
here from the Health Care Exchange. So we will proceed. First of all, thank you, Madam Chair, honorable members of HGO and friends. Thank you for the opportunity to present House Bill 728, Health Insurance Qualified Resident Enrollment Program Access to Care Bill for the second year in a row. And I'm going to remind the body that we passed this bill out of the House last year.
Excuse me, she's right here. Joanna, will you please pull up a chair? Thank
Great.
you.
I passed this bill last year, 100 to 38 on the floor of the House. Unfortunately, we did not get a hearing in the Senate, so we were not able to move forward. We've done a lot of work on this bill since then, and we've talked with a lot of people, and we've tried to correct misinformation. And I am so honored to have this group of people in front of you today because they represent the best of Maryland healthcare providers and our networks and our and how we do our healthcare system here in Maryland, because they are all here in support of this bill to say why this is important for the state. It's not just important for individuals, and it is. That's number one. It is very important for families, very important for children in our who are in our state, but it is also important for us as a state. So,
may I interrupt for 1 second, please? If there is a chair next to you, can you raise your hand, please? Will you please come and sit wherever there's a chair? Go ahead and have a seat. I'm sorry. I know I'm directing. We do everything as a chair. Go ahead. Have a seat so that the door can be clear. Go ahead, have a seat, please move over, have a seat, raise your hand up, please. Come and have a seat. Thank you. Any other chairs, can you raise your hand? There's one right there. Please come and have a seat. Someone that's standing right in front of the door. Okay? Thank you. You cannot block the door, so you could get against the wall. Thank you. All right, sorry, delegate, go ahead.
Madam Chair, you would be masterful in a church on Sunday morning. Over the years, this committee and this legislative assembly has made a commitment to obtaining health care for all Marylanders. We've chipped away at it over the years since the beginning of the Affordable Care Act, or the implementation of the Affordable Care Act. We started with a robust health benefit exchange, which took our numbers down dramatically. And then but we saw we still had a large number of Marylanders who didn't have coverage. So we put other programs in place that help to keep premiums down in our state and cover more people. I've been doing the insurance subcommittee now for, I think, 5 years. And what I have learned is the more people you have in the insurance pool, the better the rates are. But we still have a group of people that are not covered. We still have about 350,000 Marylanders who are not covered. And a portion of those folks do not have legal residency status in in Maryland. And unfortunately, under the provisions of the Affordable Care Act, they also do not have access to our health benefit exchange. They don't even have access to purchasing, to buying with their earnings that they are making in our communities on the exchange. This bill, very, very simply, all this bill does is require the health benefit exchange to request a waiver to allow folks with, regardless of immigration status, access to our navigational programs and to purchase with their hard-earned money the plans that are available on the market. That is all this bill does. It does not cost the state a dime. The exchange has assured us that they can implement this program completely within their existing structures. So I talked a little bit about what the benefit to the consumers would be, to the families who do not currently have this access. If you have ever tried to buy commercial insurance, because that's what they tell us, you know, they can buy insurance on the commercial market. I have a master's degree. I can go on and I consider myself reasonably knowledgeable about insurance now. I can go on a website and I will honestly tell you, I do not understand it. I am not able to compare plans, and it would be particularly difficult to compare across carriers, right? So I can go in, I think Debbie told me one time that CareFirst has 100 different plans. If I were gonna be able to do this right, buying on the commercial market, I'd have to look at every single one of those 100 plans to figure out
which one is best for me? Imagine that English is not your first language. How much harder does that become? So what we have in Maryland with our health benefit exchange is a set of navigators that speak multiple different languages. I will let Ms. Fabian Marks tell us exactly how many, who can walk individuals through the comparison process across healthcare products to find what is right for their family and what they can afford at full price. That's the benefit to the family. But let's talk about what the benefit to the state is. Zero cost. I'm going to just keep saying it. Zero cost. These individuals would be paying unsubsidized premiums into the plans on the exchange. The more people we get into the pool, the lower and more stable our insurance rates. According to our hospitals, they spend, and this is from data that they gave me last year, between $120 and $170 million a year in uncompensated care. A lot of that is because people who don't have health insurance don't get primary care or preventive care. So they get so sick, they finally have to go to the emergency room, which is the most expensive healthcare on the planet. Uncompensated care, as you heard in a briefing earlier this year, affects every one of our premiums because that has to be, they have to find that money someplace. And you've also heard about our emergency room wait times being the highest in the country. We can decrease that some by allowing people to buy insurance to get primary preventive care. There are about 90,000 people in Maryland, this is from 22 data, I believe, who are working on ITINs. It is likely that a good portion of them, if not all of them, do not have legal residency status. Those folks are working, paying taxes in Maryland and the federal taxes, but do not have the benefit of what those taxes buy. I need to tell you two things. You're going to see a revised fiscal note on your floor system. And if you will indulge me, I am going to read to you what this fiscal note says under state effect. MSDE can apply for the waiver and absorb the initial startup costs for the program using budgeted resources. To the extent that state subsidies are approved for the program by the General Assembly, at a future time, expenditures increase by an indeterminate amount. This analysis does not assume federal pass-through funds. That is irrelevant for our purposes. But I want to be clear, this bill in no way encumbers us to do this, to have this decision, or to make this decision about subsidies. And I will remind you that frequently we pass bills which are the first step towards an ultimate goal. And I would suggest to you that this is a first step. In reviewing the bill, I needed to make some amendments. You should have this on your floor system, but I don't promise. But because we wanted to make it particularly clear that people who are buying into the exchange who do not have legal residency status would be paying their full amount of the premium on those exchange plans, then I have amended the bill to say that the qualified resident enrollment program shall allow qualified residents to purchase plans. That's number one change. Number two change says that the health benefit exchange will report, one of the things it will report now is the number of individuals who are anticipated to participate in the program, the amount of premiums expected to be paid by those participants, and if the General Assembly authorizes funding to subsidize premiums under the program, it must determine the parameters of those. This is an important bill for many, many families in our state. It gives them a leg up. It gives them hope. It gives them security for those who can afford to buy it. And We don't have any idea how many people that is. But if it's 10, if it's 20, why would we deny them this opportunity? Why would we deny them the ability to pay for insurance and to be a supported consumer in buying something that is the most complicated healthcare system in the world? So with that, Madam Chair, members of the committee, I ask for your favorable report of House Bill 728. And I'll turn it over to the secretary.
Thank you. Thank you, Delegate.
Thank you, Delegate Cullison. Good afternoon, Madam Chair, Vice
Good
Chair,
afternoon.
and members of the committee. Thank you for the opportunity to testify today. As already said, I'm Laura Herrera Scott, Secretary of Health, as well as the Chair of the Maryland Board of Health Benefit Exchange, here in support of House Bill 728, Access to Care Act. This bill would require the exchange to establish a qualified resident enrollment program and apply for a federal waiver to implement the program, which means that this will allow qualified residents to purchase healthcare coverage on the exchange. Purchasing coverage on the exchange provides many consumer benefits that are not currently available to qualified residents. Delegate Cullison talked a little bit about what it's like to shop on individual, going to, one insurer and then going to another insurer, and how difficult that process is. But this provides for a simplified shopping experience. It allows with the navigators consumer support and translation services. And it also allows for mixed status families. So maybe the children are United States citizens and maybe already getting Medicaid coverage and the parents aren't. But this allows for mixed status families to enroll in the same plan through the exchange, which means the family can go and get their services together. There is ample evidence that lack of healthcare coverage negatively impacts health, and that having health coverage is not only associated with improved access, better health outcomes, but certainly managing overall total cost of care as people allow or are more able to access primary care services to get their chronic diseases managed before they get so sick that they have to use the emergency department. HB 728 will expand access to coverage and improve health in Maryland and can be established within the existing resources, which you heard Delegate Cullison talk about just now. So thank you for your time, and the department urges a favorable report on House Bill 728.
Thank you, Secretary. Madam Secretary, next, please.
Good afternoon, Madam Chair, Madam Vice
afternoon.
Chair. My name is Kathleen Borain. I serve as the Maryland Insurance Commissioner. I also sit as a member of the MHBE Board, and I appreciate the opportunity to speak to you today in support of House Bill 728. I will not repeat what's already been said. I completely agree with the points that Delegate Cullison has made and Secretary Herrera Scott has made, but I will add two more ideas to the conversation. And that is that from our perspective, one of the many things the Maryland Insurance Administration does is it educates consumers, and it also addresses fraud against consumers. And so from our perspective, there are two vital elements in play with regard to the ability of individuals to use the exchange. The first is that the exchange is a source of truth. It is navigators, producers, et cetera, are there. The information is valid, it's clear, and people can trust it. We are constantly engaged in the evaluation, the investigation of individuals who prey on undocumented communities and try to sell them health products as though they were ACA compliant products when they are not. And then these individuals try to use those products and they are useless. We have revoked licenses of individuals on this ground, and we are deeply concerned about the predators that are out there. The ability to get this information on the exchange will help eliminate that. The second point I would make is that we initiated a particular effort to target education in undocumented communities about health products. And what we found, because we attend 650 in-person events a year, we created new literature, we worked with different trusted advisor organizations, including CASA. What we found over and over again was the difficulty and the complexity that if you do not have someone sitting with someone immediately walking them through their options, handing them pieces of paper and telling them that they can go buy insurance somewhere was really not effective. So our own experience has been that the exchange, we need a centralized place that will enable people to understand this information. Thank you. We urge a favorable vote on this bill.
And thank you for your work, Commissioner. We appreciate all your efforts.
Next, please.
Thank you, Chair. Vice Chair, members of the committee. My name is Ben Steffen. I'm the Executive Director of the Maryland Healthcare Commission, as well as a board member on the Maryland Health Benefit Exchange. Might add, I'm the longest serving member of the Maryland Health Benefit Exchange. That's a very good thing in 2024. It wasn't always the case. I'm not going to repeat what has been said already. The Healthcare Commission is strongly in favor of this legislation. But I'd like to begin by saying this. Maryland is a rich state. Maryland is an educated state. Maryland is an inclusive state. Today in Maryland, we have 6.1% of the population uninsured. The research organization at the University of Maryland, funded by the Robert Wood Johnson Foundation, which focuses on access to insurance, estimates of the number that Delegate Cullison referenced, about 350,000. As many as 75% of those are individuals who do not have citizenship status. Many of them have documentation status that is unclear. If we want to move to increase the number of insured, we have to move to address the needs of this population. 6.1% seems good. I challenge you to do better. 6.1% puts us in the second decile group, really the 20th state in terms of insurance coverage. There are 19 other states that have lower uninsured rates than Maryland. We know that Massachusetts is going to be better. We know that the District of Columbia is going to be better. We know that Hawaii is going to be better. But is Iowa better? Is Minnesota better? We can do better. I strongly support the bill and encourage a favorable report. Thank you.
And thank you for your work, Ben. Next, please.
Hello, Madam Chair, Madam Vice Chair, members of the committee. I can't tell you how excited I am to be on this panel today. This is
Can you
really fun
move
for
the
me.
microphone a little
Oh,
closer?
sure.
Thank you.
So this is the first time I'm appearing before you. My name is Debbie Rivkin. I am Director of Government Affairs for the Health Services Cost Review Commission. John Crom was not able to be here today, so I get the opportunity to appear before you on his behalf. The HSCRC supports this bill, and I really think I just want to reiterate some of the things you heard today because I think they're really important. And they're the types of things that when you're looking at all the bills that you hear before you, these are some of the elements that you should always be thinking about whether that bill will actually have a result in 4 different categories. So the bill, as you've heard, is going to reduce the number of uninsured in the state. When you reduce the number of uninsured in the state, you also increase healthcare coverage. It's a necessary part of that of reducing the uninsured. That creates 4 positive results. The first is when you increase access to care, you're increasing the amount of preventative care and primary care. That is such an important component for every individual in this state. Additionally, there will be better management of chronic conditions and disease. Again, that is essential for better population health. When those 2 things happen, what we will ultimately see is a reduction in hospital admissions, readmissions, and emergency room visits. That is essential for us to keep working towards. Thirdly, when you reduce the number of the uninsured and you also reduce uncompensated care. And as you've heard, we all pay for uncompensated care in our insurance premiums. And fourth, if individuals have healthcare coverage, we will reduce the amount of emergency room visits for non-emergency events. And as we all are grappling with emergency room wait time, that is really important. So we request a favorable report on this bill. Thank you.
It is great to see you in the new role. You have
Thank you.
been a
It's great to
friend.
be seen.
You have been a friend, as Senator Benson likes to say, it's great to be seen, not viewed. And that is very true. And you have been a good friend of this committee in your past roles. So congratulations on your new role, and we look forward to working with you.
Thank you.
Thank you. Next, please.
Thank you, Madam Chair, Vice Chair, and members of the committee for the opportunity to testify in support of House Bill 728 today. I'm Johanna Fabian Marks, Director of Policy and Plan Management at the Maryland Health Benefit Exchange. And you've already heard from a number of our board members the advantages that we can offer consumers. I'll just mention and elaborate on a few of them. So first off, we have seen the number of consumers who pay full price for coverage increase over recent years, which I think testifies to the benefits that we offer. They include the simplified, streamlined shopping experience, the fact that Maryland Health Connection is a trusted entity with brand recognition in the state that consumers look to shop for reliable health coverage. We offer tools to help consumers choose the plan that best fits their needs, tools that are unique to the exchange, including the ability to estimate their total annual healthcare costs and compare that across plans, and to check if plans include their providers and prescriptions and compare that as well across insurers. We offer extensive consumer support through our call center, including access in more than 200 languages, and in-person help through our network of navigators and brokers. And although it's been mentioned, I'll repeat that the exchange can apply for the waiver authorized under this legislation and operationalize this program using our existing resources. So as has been said, the bill doesn't subsidize anyone's coverage. It would simply allow individuals who want to take responsibility for their health and finances to purchase insurance plans through the exchange. And it has, benefits that have been enumerated in terms of access to care and the potential to reduce the cost of care. So for these reasons, we ask for a favorable report on House Bill 728.
And thank you for your partnership and your work. It's an amazing exchange. I'm very proud of the work you do. Is Amelia Marcus testifying?
No.
No. So this is actually the first panel that we have, and I'm going to open it up for questions. For the committee's information purposes, there is only one unfavorable, and I'm going to call her next because it wouldn't be right to call 5 panels for our favorable, and then she waits all day, okay? So I like to be fair and balanced. So we're going to open it now for questions. The first one is Delegate Hutchinson.
Thank you, Madam Chair.
My pleasure.
Maybe for the Vice Chair. Regardless of whether I'm a qualified resident or just Tom, the consumer, if I was to go out and find all the different websites for different health plans, would I find the same that I'm finding on a healthcare exchange and same type of plans, same pricing? What I'm sort of getting at is there some other advantage that the exchange provides versus going out to the individual separate plans?
Can you take it? I'm gonna let Ms. Marks take it.
Sure, yes, there are the same plans on and off exchange. So what we offer is that easy comparison and the tools to compare in the consumer support that I mentioned.
I would just also just note that the shopping experience is completely different because there are tools behind what the exchange has that you cannot get on other sites or compare different carriers at the same time to see against your prescriptions and your own, whether your own physicians are in network or not.
Thank you. Any other questions for this panel? Oh, yes. Delegate Rosenberg, Olston, and Bandari.
Thank you, Madam Chair. Mr. Stefan, in your testimony, you distinguished between those states that are doing better than us in terms of coverage, but you didn't say why, the DC and 1 or 2 other states were in one category and the others were in another category. Could you explain that to us?
Sure. Thank you, Delegate. So it's a number of reasons. The top 3, which are Massachusetts, Hawaii, and the district, have nearly full coverage for their populations. They're below, and I haven't checked this number recently, but I think it's below 3%. We're at 6.1%. The other states, which are kind of a mix of states, including some upper Midwestern states, such as Minnesota, Iowa, New York, there's a host of reasons. Generally, the rules in those states for group coverage might be a little better than what's available here in Maryland. That may contribute to that. Now, it's also important to keep in mind that I believe New York is looking at a coverage expansion. They haven't gotten it yet. Another state that has added a coverage expansion that would cover immigrants regardless of documentation status. Washington is about at where Maryland is, around 6%. So I think I couldn't categorize exactly. Clearly, the best thing to do if you want a full coverage is to mandate everyone have insurance coverage. And that's pretty much what Massachusetts and Hawaii have done.
I have next, Delegate Olson was very kind and she asked me to call you Delegate Banderi. So go ahead.
Yeah, thank you, Madam Chair. Secretary Scott, this bill not only affirms the dignity and the humanity of every individual in our state, but also take practical steps towards improving public health outcomes as you highlighted in your testimony. Considering the significant economic contribution of immigrants without current legal residency in 2021, who paid over 93 million in state and local taxes, how can the health department under your leadership can effectively counter misinformation and disinformation and educate the public on the factual contribution, acknowledging their substantial contribution to our economy and challenges faced by these community members, particularly in accessing health benefits and services?
So I can't speak to the health department prior to me taking over the health department, but I think by the fact that I'm sitting here is the first step. And certainly in my role as board chair, we've been working very closely on the education that's happening out in the community through the navigators, and certainly through the work with the Maryland Insurance Administration. So this is not a one department fix. This is multiple departments. And I think it's a testament to the vice chair having all of us at the table that we're all committed to doing exactly what you just described.
Thank you. Delegate Olson, followed by Taveras, followed by Bagnell.
Thank you, Madam Chair. I just want to know, is there any way that this can be done without legislation?
Sure. So we've had extensive conversations with the Centers for Medicare and Medicaid Services, and they've reiterated repeatedly that they strongly believe we should have state legislation in order to apply for the waiver amendment.
Yes. Thank you for the generous follow-up. And then my next question, just so that we're clear, if we don't do this, if you have a number, if not, you can get it back to us. What is the economic harm that we're going to ensue as a state by having so many uninsured people that have to go to the hospital for emergencies and we still have to treat them versus them being able to purchase insurance with their own money, not state subsidized, and go through the insurance process to get their healthcare needs met?
So I don't have a dollar amount for you, but I'll just walk through how difficult it is. So many providers will not even see you for primary care without your insurance card. In fact, they want you to enroll in their practice with your demographic information. But the next question after your name and address is, what's your insurance card? And many will not give you an appointment without that. The federally qualified health centers do, and many of them do have a sliding scale, but they're not all in a place or accessible to some of the families that need the services. So what happens is they go without care. And then they become sick because they haven't gone with care. And then they end up in the emergency room and or admitted for the thing that they sought care for in the emergency room. And it becomes just way more expensive to treat than having had insurance and been able to, get primary and secondary prevention and primary care services.
I have Delegate Taveras, followed by Delegate Bagnell, followed by Delegate Morgan.
Thank you. Even though Delegate Austin took one of my questions, I'll forgive her. No, thank you, everyone. And thank you for this bill. Hold on, I want to hear y'all better. Okay. No, thank you so much. This is a really important bill. I really appreciate Delegate Collison bringing it forward. The question I have is, how often, I know we have an incredible amount of people who are uninsured and undocumented, but how many of those typically end up either going bankrupt or basically are in huge amounts of debt? I know that you were mentioning how many of those folks end up requesting some type of forgiveness from the charity cases, because most people don't even know that they have that option.
So I don't have that data specifically for our qualified residents. I can tell you, compared to states that had Medicaid expansion and didn't have Medicaid expansion, states that didn't have Medicaid expansion have higher rates of bankruptcy related to some catastrophic health event that has caused very high expenses related to addressing that healthcare need. And even in states where we do have expansion, healthcare expenses is still a very high cause for medical bankruptcy, for bankruptcy in general. But I don't have it broken down by US citizen versus undocumented. But healthcare in the US is expensive.
Thank you. Delegate Bagnell, followed by Morgan.
Thank you, Madam Chair, and thank you for this legislation. And I will confess, I got to speak with Michelle Everly last week, and she talked about the multilingual aspect of the tools that you can access through the Maryland Health Benefit Exchange. But my question is for you, Secretary Herrera Scott, because I know that you are a population health expert and you spoke to the outcomes, but would reducing the number of uninsured and actually getting people into care, would that let us be more strategic with our own public health initiatives in the state of Maryland so that we can leverage those dollars better for better health outcomes?
So yes, for sure.
Okay, thank you. Delegate Morgan.
Thank you, Madam Chair.
My pleasure.
I apologize. I missed the first part of your hearing, so you might have went over this, but I just wanted to make sure I caught it. Because the statement's been made a couple times that this won't cost the taxpayers any money. This won't, hurt any subsidies.
Mm-hmm.
But the entire individual market is subsidized by the Maryland taxpayers, their health insurance being taxed, the 1-2% for reinsurance. So I'm just thinking, how can you make that claim when the entire exchange is underwritten by that 1% tax? And I think there's close to $500 million a year goes into, or maybe not a year, but I know what that's the carrying balance is for the Maryland reinsurance program.
So the 1% fee is that's collected with respect to all health insurance premiums across all markets, not just the individual market, is about $115 million per year. The other dollars that you're talking about are actually the monies that we receive from the federal government in federal subsidies, which actually benefits the state. With respect to the individuals who would be purchasing insurance with their own dollars, their premiums would have that 1% assessed as well. So it's the issue here is there's no cost differential. If anything, bringing more people into the insured products has had a tendency to bring costs down overall. And when the state allocates the uncompensated cost of care differentials, the insured market pays a higher rate than other areas. So there is a disproportionate allocation of those uncompensated costs on the insurance market, the commercial market, as opposed to other markets. I hope that helps.
And whatever terminology we're using now, New American, purchase an exchange policy. And let's say they're really sick. And it goes over that threshold that triggers the reinsurance, wherever that cap is nowadays, 100,000, it's like a gap there.
Between 20,000 and 250,000.
Yes. Then they would be receiving the benefit of subsidized health insurance by the American taxpayer? Because I mean, federal taxes are still taxes.
So almost every insurance company that exists, particularly in the property and casualty market, et cetera, buys reinsurance, right? Because that's how they spread their risk. So you can think about this as sort of a mandatory reinsurance program for health insurers because health reinsurance is less available. So what happens here is what happens in every other market, except here we have a statutory structure for it, which is that insurance companies pool their money, right? Because it's their money, and the money goes back to the insurance company, not to the individual. But the insurance company is reimbursed because what they've done is they've pulled their dollars and they've using that reinsurance then to reallocate among the market who's got the higher care costs, right? So we do that in a variety of ways in the health insurance market, but this concept of reinsurance is a concept that exists everywhere else. We just have a specific statutory structure and mandate around it with respect to health insurance, as opposed to every other market, which does it differently, like life insurance and P&C insurance, because it is more readily commercially available in those other markets.
You're welcome, Delegate Delegate Chisholm. Actually, let me, before I get to Delegate Chisholm, Ms. Rifkin, do you have a follow-up to that?
Thank you so much. Delegate Morgan, just one thing for you to consider. Today, an individual who would qualify under this bill can purchase individual insurance off exchange today. With their own funds, they can go and buy it. Anyone who buys insurance off the exchange still is benefiting from the reinsurance dollars. The reinsurance dollars are reducing all rates for all individuals, no matter where they're buying. So this will be irrelevant. This bill doesn't change that. What the bill does is give those individuals, instead of only being able to buy off exchange, to be able to buy on exchange, which allows them to have the language navigators helping them with language and being able to compare. So this today, your question already, individuals are already getting the benefit.
That cap are already, and that may be purchasing insurance off the exchange, are already receiving the benefit of Maryland taxpayers who's being taxed, their insurance is being taxed to provide this subsidy. Is that what you just said?
What I'm telling you is that everyone who purchases insurance in the individual market, regardless of how they purchase it, the reinsurance has reduced the costs of how they will purchase, which has allowed us to increase the number of individuals who've been able to purchase insurance, which gives us all the benefits in the state of having a healthier population.
Okay.
Yes, sir.
Reinsurance has lowered rates in the individual market. We've
Correct.
done considerable. We're all in agreement of that.
Yes.
Would you mind telling everybody how those rates are collected and how that reinsurance is funded? Who pays for the reinsurance fund?
Anyone.
Most
who-
of it is the federal government.
Yes.
So it's coming through
$2 out of
APTC
$3
credits.
federal.
Well, we haven't actually, if this may be the first year we actually tap into the fees that the insurance companies are paying. They're not taxpayers. We're not taking money out of the general fund. It is an assessment. And yes, as with the case with every other, I'll say tax if you like that better, but whatever the dollar amount is that's paid, right? It is factored into the other costs that are factored into rates. There is no question about that. Yeah, but I will agree with the fact that it doesn't matter whether you bought your policy on the exchange or off the exchange, whether the insurance company can make a claim under the reinsurance fund to be reimbursed.
Thank you. Delegate Chisholm.
Thank you, Madam Chair.
You're welcome.
I will say it's nice to have Deb Rifkin back and
Yeah.
liven things up a little bit. I am curious, obviously, we're running models to try to figure out the savings of this, right? So do we have an idea of what the number of uninsured in the state of Maryland is right now, what percentage that is? And if we do put this in, if we pass this, do you have an idea of how many people we expect to purchase a policy on the exchange?
We believe, not believe, we know that about 350,000 Marylanders are not covered right now. That's about 6.5% of our population. We have really no way to anticipate how many people will participate when they're given the option. But I would suggest to you that any number that signs up, any number that is able to pay full price for their premium and cover their family will impact our health economics here in the state, because it pays into our hospital rates, it pays into the ED, the emergency room wait times, the uncompensated care, any number of people. We hope it would be a substantial number. And if our exchange and our insurance administration are masters of information and education. So we would hope that once it becomes available, people will take advantage of it.
It's very basic, is
Right.
to spread out the liability. So the
Right.
more people is better. But I'm just always curious because we keep being told we have X amount of uninsured, but I don't know how we always get this number and where's the, I think in one of the hearings or one of the briefings, they said, well, this number comes from 2021. Well, how do we know we're using a static number, and I don't know where we get this number from, considering, and uncontroversial, that we've had 10 million new people come across the border in the last 3 years. How many have shown up in Maryland? So how do we know what that number is? When we're doing factors and we're doing models, you need actual static data, or at least reliable data. And in the last 3 years, that data has changed, could have changed tremendously. So, and it may work better for your model. We may have more people coming on. I don't know. I'm always curious on where we get these numbers from. And when you have that real number, then you can create an equation to say, if we have 50% of these 350,000 people buy the insurance at full price, then we can figure out the savings. But without those numbers, I don't know how we always come up with this savings, because you can't prove that we have a savings at all, because we don't know if anybody's going to sign up. And what do we expect that total number to be?
You want to speak to it?
I can just speak to the source of the number. So the 350,000 uninsured individuals comes from the American Community Survey, which is run by the US Census. So that's an estimate. The most recent data is from 2022, and they do that annually. There's always a lag, which is why 2022 is the most recent, but it has been very steady for years. We've been at about the 6% uninsured rate. It's about 350,000 uninsured for 4 or 5 years or more.
Thank you. Delegate Hill.
Thank you, Madam Chair.
You're
So
welcome.
the question to whoever feels best suited. So since we're doing hypotheticals, we've hypothetically had the markets with and without this waiver that we're asking this bill to allow you to apply for. And absolutely nobody in Maryland had insurance on the individual market. And at the other extreme, we got the waiver, and everybody who was uninsured got insurance. Is there any way that we have any idea that we save money or not? If we go to the two extremes, that nobody takes advantage of it and nobody's buying insurance versus everybody who could does, doesn't that give us some idea of whether this is a net win based on uncompensated care in the emergency room, uncompensated care that has to be done that's not in the emergency room? Aren't there factors out there that we can look at that tell us whether this is a win or a loss?
Can I want to be clear. In some cases, cost of care would go up, but good cost of care. So kids might get immunizations, or families might get their breast cancer screening, or or they were diagnosed with hypertension and they're taking an antihypertensive that's managing their hypertension, versus not getting their hypertension diagnosed, not taking the medicine, developing high blood pressure that could lead to stroke, could lead to neuropathies, could lead to cardiomyopathies or conditions with your hearts, dialysis, et cetera. So there could be an increase in costs related to healthcare utilization, but it's good healthcare utilization like primary and secondary prevention and primary care versus avoiding complex care in the ED or in the hospital. Any other questions? I have a question for Delegate Collison. So the bill as drafted makes it very clear that this population will not get any subsidies, correct?
The original bill made that clear, I thought, Madam Chair. But yesterday we learned that it was not clear enough, which is why we have the amendments that the committee has before it today, which very explicitly says that if there would only be subsidies if there was funding approved by the General Assembly at some later time.
And that means that there will have to be a bill and we make the decision, correct? Like we
Correct.
do with everything else.
Correct.
So this bill is really about personal responsibility, correct?
Correct.
The person will pay the full price with their hard-earned money, right?
Yes.
And how many other states have been able to get this waiver?
Two are doing and operating it, but I know that several have also applied for it. Colorado and Washington State have done the programs, have gotten the waiver. The federal government has been responsive to these requests for waivers, though, across the country.
Okay. And do you know how much the hospital spent on uncompensated care? For example, last year?
What they told me last year was between 120 and $170 million.
And who pays for that?
Ultimately, it comes to all of us and our insurance premiums.
So is this charity care we're doing here?
I do not believe it is charity care, especially when folks are paying for fully for the premium. There's no charity there. Except the accessibility of service. That's the only thing that they're being given.
Thank you. There are no other questions for this panel. I am going to call the unfavorable right
Thank you,
now.
Madam Chair.
Thank
Madam Chair,
you. And I
can
want to
just
thank
this panel.
Again,
Are they not terrific?
I want to thank all of you for working together. You know, it's interesting to see the Secretary of Health, the Maryland Insurance Administration, to see Ben Steffen, to see the HSCRC, the exchange that are the people that guide us, right? And we know it works because we started with almost 800,000 people uninsured before we expanded Medicaid and created the exchange to now 6.1. So thank you for your hard work for the state of Maryland. We appreciate you. The next person is going to be the only unfavorable we have today, and that is Ms. Mary Fry. Will you please come up? Good afternoon, ma'am.
Good afternoon, Madam Chair. I want to just point out, I have a profound hearing loss, and I asked for an assistive listening device, and I guess you forgot.
Actually,
But I
no,
do want you to
one
know-
second, please. I heard that they have the device for you. Hold on a second, please. 1 minute, please.
I can't
Can
hear
ask
you
Michelle?
anyway. I lip read by hearing.
Okay, so
You want me to?
1 minute, 1 second. Hold on 1 second. We're getting the device.
Yeah.
1 second.
I spoke to Michelle.
She requested it. Hold on 1 second. 1 minute. Thank you. 1 minute.
I don't sign. Wait a minute, okay.
Okay.
Mm-hmm. But I am aware that it takes a week, but this hearing for this particular bill was just scheduled, like.
And sit, I will call you back. Okay?
Thank you.
So what I just told her was that she made a request today for a hearing. It takes a week for us to get it. We are working on it to try to accommodate. It takes the comedy a few days, but we're gonna work on it. I'm gonna call a few more people. And then I asked her to sit, we're gonna work. And I apologize for going over there, but makes it easier. Okay, so I'm gonna call another panel while we try to get this hearing aid, all right? Thank you. So we're going to go to. Where's my list? Okay. All right. The next panel that we're going to call is actually 1 minute. What's my list of the witnesses? Can you give it to me, Rose? The next panel is going to be the health officer from Prince George's County, Mr. Sammy Ariola. Oh, it's here? Okay. All right. All right. And it usually takes a few days because they have to request it, but Michelle made it possible. And I want to ask everyone I want to say thank you for being patient, okay?
Happy now.
You are welcome.
The only disappointment is that when everybody was laughing, I didn't know what you were laughing about.
Okay, well, it was not about you. Yeah, yeah.
I've forgotten. I've done it before. So where did I get this at? Does anyone know how to operate? I mean, it's been a long time. I did testify on House Bill 1230 2 years ago, and it's been a while. Okay.
Okay.
Well, I'm gonna tell you what, I can talk, but if you ask me questions in the end, I won't be able to hear you. You can sit here.
Can you? Let's hear.
I'm just gonna
Hold
go
on a
ahead.
second, 1 minute.
Okay.
We're gonna get it right. Okay.
Okay, so how did it work? I've forgotten.
You just put it on your ear and adjust the volume here.
Okay, look. Okay, okay,
Sorry.
it's okay.
So I need to turn up I need the volume up.
The volume up, please. Okay,
Adjust it yourself because otherwise it's too loud.
Okay,
Not really. I mean,
does that
it's
work?
not working. It's not working for me because I wear a hearing aid and it did
Okay.
not.
Okay.
I mean, yeah, that might work.
Okay, hold on a sec. That's okay.
I
It's
know.
all right.
How are you?
You're welcome. Okay.
I heard you. I can breathe.
Oh, you can read my lips?
Yeah.
Thank you for being patient.
Oh, no problem. I'm very patient.
We
Thank you.
appreciate you, okay?
Oh, I appreciate you guys. Thank you. I
And
just want to say,
when we were laughing earlier,
yeah,
it was
I
not about you.
well,
Not
well,
about you.
you might be laughing about me after
nah.
you're gonna be laughing at me after I get done.
No, you know what? We welcome all opinions.
Okay,
There's no judgment.
good.
Okay?
Well, I just want to say, good afternoon, Madam Chair. Good afternoon, members of the committee. I'm glad to be here. This is what I remember. Okay.
And just the volume yourself, yeah.
So.
Okay, can you get it all the way up? Is that high?
Is it high? Yes.
Now, how did this work? This gotta be, this isn't, well, I'm gonna try it. What the heck? I'm gonna go ahead and talk, so I don't hold you up.
It transmits to you. So try it and let's see if.
Okay.
It's okay?
Okay,
All
Can
right.
you
And
hear
give-
this?
Give me 1 minute
okay.
for me to get to my
Can-
seat. Can you
Can you hear
her?
that? Can you hear this? Is this
No,
coming through?
can you talk louder?
I can talk louder. Is that better?
Maybe a little bit more?
I will have to use my teacher voice if I go any louder.
Say something? This Dominican woman can speak very loud. Okay?
Come on, talk loud.
Can you hear me?
Yeah, thank
Uh,
you.
Thank you. I want to say thank you for your patience
Oh, you're welcome.
and we
Thank-
really appreciate you.
Oh, thank you.
And there's no judgment here.
Oh, well, I'm glad.
All right, so you can get started
Okay,
and we have our full attention.
you what now?
We are paying attention. You can get started.
Okay,
Thank you.
thank you.
You're most welcome.
So I will begin, right?
Yes.
Okay. Well, I'm a state of Maryland retiree. I worked almost 32 years as a social worker, working with children who were victims of abuse and neglect. You took an oath of office to represent your constituents, the people of Maryland. You didn't take an oath of office to represent illegal immigrants. They are not citizens of Maryland. Yet you eliminated the promised RX drug benefit for your very own state retirees. These state retirees, including myself, work for the people of Maryland. We work for the people of Maryland. We fulfilled our job duty to advocate and serve the citizens of this state. State retirees earned and paid for the benefit during their employment with the state. And you took that money from us. That was to support and continue our benefits throughout our retirement. But you want to go out of your way to help illegal immigrants and to make sure they get free health care and drug benefits. This is outrageous. You have broken a promise by throwing the state retirees, the elderly and the disabled, under the bus. The state has a very high job vacancy rate, unable to fill state jobs. And you want to know why? I think I know. because of the way you treat your retiree and not fulfilling your obligation by keeping the promise you made. This bill, House Bill 728, means you are seeking a waiver so you can get federal funding to give illegal immigrants free health care and drug benefits. What about us? We work for you guys. We work for the people of this state. And we were promised that we would have this benefit. And it's just so unfair. I am totally against House Bill 728. Thank you.
Okay, thank you for your testimony.
Thank you.
And thank you for your service to Maryland. Are there
Thanks.
any questions for this witness? Seeing none, thank you so much for coming. You have a blessed day and thank you
Thank
for
you.
being patient with us.
Oh, no problem. Thank you for being patient. Thank you for listening.
Absolutely. Absolutely.
Have a good one.
You too. Take care.
Bye.
Bye-bye. And thank you so much, everyone. Can someone get the equipment from her, please? Thank you very much. And thank you, everyone, for being flexible. And I do appreciate your patience and your humanity. Thank you. Does she? Okay, so you can let her keep it so she can hear it, because otherwise she can't hear it. Oh, she doesn't want to, but thank you for giving her the choice. That was very thoughtful. Thank you very much. So we're going to move on to the next panel. If there are any, I should not, let me lower my voice. If there are any chairs, will you be so kind and please go and occupy the chairs so that there are less people standing and you do not block the doors, please. So now we're going to go to Mr. Larry Sarsecki, Roslyn Berkowitz, Jessica Gorski, Lawrence Diggs. Will you please come up? And also for our team, will you please bring up the virtual oral witness for Ms. Hopkins? Thank you very much. Can you come up, please? Larry, Roslyn, Jessica, Lawrence, can you please come up? And Vincent.
Madam Chair, I apologize. This panel is for House Bill 340.
Yeah. Is it?
I'm sorry.
I was gonna say, those are not necessary.
Oh,
Yeah, here you go. Here you go.
Okay.
Starting here.
Delegate Collison. What is going on, Delegate Collison? She's usually on it. Okay. Oh, it's okay. It's okay. So we have Dr. Ariola. Can you please come up? Miss Allison Taylor. Salian Alborn. Pegeen Townsend, will you please come up? And thank you again for your patience. See, Delegate Collison has us busy today. And who will be the person that would love to honor us with your testimony? Just, will you please get started? Dr. Ariola, I'm going to go ahead and call on you.
Good afternoon, Madam Chair.
How are you?
I'm good. How are you?
I'm doing well. Thank you for asking.
Yeah, and members of the committee, Dr. Somi Ariola. I'm the Deputy Chief Administrative Officer for Health, Human Services and Education for Prince George's County. And I'm here speaking in support of House Bill 728. Our county is growing just like the rest of the state and becoming increasingly diverse. These are valuable attributes that also underscore the need to ensure good health for all of our residents. And we're working diligently to create conditions that will improve the health of our residents. Healthy conditions result in healthy people, which reduce the burden of the disease in the community and the healthcare system, which ultimately saves lives. A healthier state, a healthier county are important to sustaining the economic vitality of our cities. We will attract businesses and families when we are healthier. When we perform well in metrics of population health, families will want to raise their children here, and adults will want to live here. One of the most important things that we can do to create healthy conditions is to ensure that there is better access to healthcare for everyone. To become a healthier community, every resident of all races, gender, age, sexual orientation must have access to good healthcare. Having affordable health coverage, insurance coverage for everyone is the way to ensure that all have access to good healthcare. Affordable health insurance allows preventive care for people to be evaluated and treated by medical professionals at lower cost. It qualifies residents for upstream factors of health, the so-called social determinants of health, rather than wait until they get really, really sick. In our county, about 60,000 residents are without health insurance. These 60,000 people perhaps will put off wellness visits, immunizations, cancer screenings, or even not make any appointment for conditions that, if caught early, could increase the chances of success of treatments and care. When people live conditions like diabetes, high blood pressure, unmanaged because they cannot afford an office visit or the prescription drugs, their health is adversely impacted. When they wait until they must go to emergency rooms, it burdens an already stretched healthcare system. We are healthy when we are all healthy, and that is why we are supporting this bill. Thank you.
And thank you for your service to gorgeous Prince George's County. And since I represent Anne Arundel, I also represent gorgeous Anne Arundel County. Next, please.
Good afternoon. I'm Sally Ann Alborn. I'm the CEO, excuse me, I'm sorry. Good afternoon, Madam Chair. Good afternoon, Madam Co-Chair and the committee. I'm Sally Alborn. I'm the CEO of Maryland Community Health System, a network of 7 federally qualified health centers with 55 care delivery sites throughout the state of Maryland. I'm also a nurse with 60 years of experience in the healthcare environment. As many of you know already, FQHCs provide primary care services regardless of a patient's ability to pay. When a patient is uninsured, however, our staff help that patient explore whether or not they qualify for insurance coverage through a number of options that are available in the state. Medicaid, Medicare, if you're disabled, or private coverage on the exchange or through the individual market. We provide this service because we believe that having insurance coverage provides our patients with access to specialty care, testing, treatment, and other services beyond the primary care that we're able to provide. Provided, by the way, on a sliding fee scale basis, all the way down to 0 practically. As a clinician, though, I will tell you, it is heart-wrenching when our patients do not have access to insurance coverage and therefore cannot afford or have access to the additional care and treatment that they need. Being in an exam room with a patient when you tell them there's nothing you can do is probably one of the worst experiences a clinician ever has. Under the current law, we are not able to offer some patients this option through the exchange because they are undocumented, even though they are working and able to pay for the insurance coverage. House Bill 728 will allow our documented patients to purchase insurance coverage on the exchange at their own expense and at no cost to the state. I respectfully request a favorable report on House Bill 728. Thank you.
Thank you so much for your service to the people in Maryland. It makes a difference. Next, please.
Thank you, Madam Chair, members of the committee. Peggy Townsend on behalf of the Maryland Hospital Association in support of this bill. Broad-based insurance coverage is really integral to hospitals being able to deliver quality of care and as well as to meet the goals of the Maryland Total Cost of Care program. So it does actually impact our ability to do those things. As this committee knows very well, hospital uncompensated care is built into the hospital rates, and it is shared across all payers, including Medicaid and Medicare. In other states, that doesn't occur. So, but what that does is the insurance company has to price that out, how much uncompensated care is going to be built into the rates so they can charge their premiums. So to the extent we can get more people coverage, it reduces the uncompensated care that all of us pay for. With regard to the emergency room, I want to say that unfortunately, these individuals often come to the emergency room much sicker than they would be if they had had primary and preventive care. So not only are they uncompensated care, but they're high cost uncompensated care. So you have two aspects to that. I just want to put this bill in perspective. It actually is a very small bill. It does two things. It allows people that could purchase commercial insurance to purchase it through the exchange. That helps them navigate. This is all you're doing is letting them get to the navigators. You're not paying for the insurance premiums, no subsidies. You give them access to the navigators. And I want to emphasize what the insurance commissioner said. That also helps prevent fraud to often underserved, vulnerable populations where people are out there trying to sell them schlock insurance and take advantage of them. So for those reasons, we support House Bill 728.
Thank you very much, and thank you for your partnership. Next, please.
Good afternoon, Madam Chair and members of the committee. My name is Allison Taylor here on behalf of Kaiser Permanente. Kaiser Permanente has worked closely with CASA and others to provide coverage for over 11,000 undocumented immigrants now. And so from that perspective, I want to say we see a lot of interest in insurance coverage, and I know that there continues to be a lot of pent-up demand for insurance services. So this bill passes. We appreciate that this population can shop around, and just want to make sure everyone's aware that Kaiser is a friendly place on the exchange for undocumented Marylanders.
Thank you, and thank you very much again for your partnership. Are there any questions for this panel? Delegate Lewis.
Thank you, Madam Chair.
You're welcome.
And let me take the opportunity to salute you for your compassion today and helping all of our Marylanders participate in the democratic process. This question might be best for Ms. Townsend, and thank you to everyone on the panel. I've had a few minutes to reflect on some of the information and questions we've received so far. I'm a bit slow on the uptake. This question might have been better for the MIA administrator, but hopefully, Ms. Townsend, you can help. So there's this concept of public goods, and we think of clean air, clean water as public goods that all of us benefit from. And there is a reasonable concept of considering access to healthcare as a public good. When everyone has it, we're all better off. I'm wondering when we think about removing barriers to the purchase of on-exchange insurance plans, are we enabling access to a public good? I think of it as a roadway that we all use. Public dollars pay to keep our roads maintained, paved, repaired. And whether you are a native-born American or Marylander, or someone who was born elsewhere, regardless of your immigration status, you're using the road. Is that an example of a public good in the same way that healthcare is, and we're all paying for it, so we're all benefiting from it? Can you extricate those two ideas?
Let me think about that for a minute. I'm a little confused. You know, to the extent we have broader insurance coverage, it lowers the price for everybody, right? because there's more people in the pool and you really want the healthy people, young people, which I think this may help as well. And we have this debate on healthcare for all. And I think, is that where you're going? Like, we need everybody insured, and we are all paying for it today. It's just through different mechanisms and cost shifting, and things like that.
Okay, I don't see any other questions. I just want to say thank you, Delegate Lewis, for your comments. Like, I'm really blessed to share this committee because all of you are very compassionate, and all of us here, all 23 members. So Delegate Hill is now speaking with a prior witness because she's confused about the bill, and since she couldn't hear, she didn't know what the bill did. So I want to say thank you so much, and Delegate Chisholm's staff as well, for being compassionate and speaking with her offline as well. So thank you for being here and for testifying and for the work that you do. We really appreciate it. We're going to go next to the following panel: Dr. Christy Waterman, Ms. Pam Casemeyer, who has been waiting patiently like everyone else. And thank you everyone for your patience, and Zachary Berger. Actually, Zachary is virtual. Will you be so kind and let him in? Thank you. Good afternoon. Who would like to get started?
Good afternoon, Madam Chair, Madam Co-Chair, and members of this committee. My name is Dr. Christy Simon Waterman, and I'm actually the immediate past president of Maryland Nurses Association. So I'm here representing Maryland Nurses Association. And thank you for allowing us to speak on this very important issue. I am a family nurse practitioner, a registered nurse, a mental health nurse practitioner. And what I want to say is that Maryland Nurses Association strongly support this bill. I'm coming to you today as a nurse and as a provider, and I have taken care of a lot of these patients, clients that we're discussing today. Access to care is an important issue, and people are willing to pay for their health care. They are willing to. I have taken care of these patients, and they're glad to be able to have someone who they could trust to come to get that care, and not go to providers who don't take the insurance or who they are unable to trust. If we have healthy individuals, we have healthy families. When we have healthy families, we have a healthy community. We have a healthy community, we have a healthy state, right? Makes sense, simple sense. So supporting this bill is a win-win situation because we're allowing people to purchase their insurance and have access to simple care, basic need, primary care, which is preventative care, which could prevent chronic illnesses. So I do ask this panel today to look at the simple side. Hear what I'm saying, that being able to allow people to purchase their health insurance and have this access to care would lead to healthy communities and a healthy state. Thank you.
And thank you for your service. Yes.
Hello, Madam Chair, Madam Vice Chair, members of the Health and Government Operations Committee. I'm actually here on behalf of a number of my clients that I'm often before your committee. The Mid-Atlantic Association of Community Health Centers is probably particularly relevant here. They are the primary care organization funded by HRSA that represents all of the federally qualified health centers. We know you heard from Ms. Alburn, and her testimony was great, but there's also other community clinics and others that are members of MAC, but also the Academy of Pediatrics, the OBGYN Society, and the State Medical Society. And not to repeat what you've heard from a lot of people before, and I might even try to finish faster than 2 minutes. This committee has been so committed to addressing so many public health issues. You have so many policies, maternal child health, behavioral health, all of those kinds of services, all of those kinds of health challenges. But all of that you are doing to improve the health and well-being of Maryland citizens, the community we're talking about, if they can't easily and adequately purchase insurance when they can, they may never even be able to take advantage of all of the wonderful policies and programs and benefits that you already are addressing. And so this just allows them to be able to provide that coverage and to purchase that coverage and purchase it in a way that may be more understandable for them to get the right coverage. Like if I have a family with kids, maybe being able to compare who's got which pediatricians or where the clinics are located, all of those issues and the navigator services really help these families so that they also can benefit from all the other good work that you do.
And thank you for your work. I'm going to open it up for questions now. I see Delegate Morgan. My pleasure.
Pam, hey, how are you?
Hey, fine.
You
How are
you represent the physicians and make it
Yes.
correct. I had a little healthcare scare over the summer and I was shocked to see how long it took to get a specialist.
Mhm.
To me, healthcare gets dramatically clearer when you look through the lenses of supply and demand. Do you have any concerns? We just heard testimony that this bill would help a lot of people, 350,000 stated earlier. If a sizable amount of people jumped on the market that were sick, does the organization that you represent, the physicians, do they have any concerns that they can meet the demand?
I appreciate your question, and there is no doubt you all talk about workforce shortages all the time, but this bill doesn't really impact that issue. And the reason is these individuals can purchase insurance now, and many of them are, but it's very complicated for them to do so. They don't have the navigator services. They may not select the correct plan. They don't have anyone to help them know how to buy the best insurance product. So it isn't to say they can't buy one now, they can, but this will help them buy it easier, better, and facilitate picking the most appropriate coverage. The other part of it is ironically, your question about specialists, often because these individuals don't have coverage, they don't end up seeing anybody but a specialist when there's a major disaster health-wise, because they can't really afford all of the primary care to begin with that keeps them from ending up at the specialist. So in some ways, maybe it will help with the access issues for some of our more complex, severe, significant services that are needed if they can do the preventative services on the front end.
Thank you. Any other questions? Delegate Bagnall. Thank you.
Thank you, Madam Chair.
And taking care of me.
Thank
Delegate
you for this
Collison.
panel. I just want to make sure that to your point, Ms. Casemeyer, that we're framing up what this bill does. And I will tell you that I came from an arts background where we couldn't access health insurance before the Affordable Care Act. It simply wasn't available. And I was one of the first 5,000 who jumped on the exchange because I was so excited. And I had that experience of walking through what was available because I really didn't understand it. And I was able to be connected to services. So there was a question earlier about whether or not people would actually participate if we get the waiver, if we make this accessible, if we have those tools to navigate, will we really see a reduction in our uninsured population? And from your experience, what will be the outcome if we make this easier to navigate?
We think it'll be very positive. I think the question isn't even so much, there isn't any way to answer that question. Will there be individuals who are trying to buy it now, get so frustrated and confused they don't buy it, and now they will? There's still going to be individuals who may not be able to afford it, and we still will have challenges. That's a different issue. The population we're going to look to serve long term. But I think the other piece that is likely to happen along this, because you've seen all the dramatic support, some of this is public education as well. We get this waiver and we start this process. Information gets spread amongst the community so they know they have a vehicle to explore where they're not overwhelmed and confused. I mean, personally, I've been doing this work for a long time. I still get overwhelmed and confused about some of this stuff. So I think that it's an avenue where you will have folks who may even begin to try and give up, or they just find it easier to do and can pick the better product.
Thank you. Seeing no other questions, I want to thank you both for your patience and for coming to the committee. All right, we really appreciate it.
Thank you.
Most welcome. Next, we have a virtual witness, Mr. Zachary Berger. Good afternoon, sir, and I think it's Dr. Berger, if I'm not mistaken. Is he on? He's not on? He didn't join? Okay, great. Well, not great, but good. Next, we have Naive Castro, Rafael Lacayo. Are you going to translate?
Yes, ma'am.
Okay, wonderful. Why don't you give us your name for the record?
Good afternoon, Chair and members of the committee. My name is Ninfa Amador, and I'm a policy analyst with CASA.
Wonderful. And who would like to get started?
Buenas tardes, señores delegados.
Buenas tardes. Good afternoon.
Good afternoon, delegates.
Mi nombre es Naive Castro, soy colombiana y vivo en el Distrito 47 actualmente con mi hermosa familia que incluye un niño de 5 años. Soy orgullosamente miembro de CASA, activa, y conozco de primera mano las dificultades que representa no comprar un seguro médico, no poder obtener un seguro médico.
My name is Naive Castro. I am Colombian, and I currently live in District 47 with my beautiful family that includes my 5-year-old grandson.
And if I may, 1 second, just for the committee, I have to be a little flexible with the time because we're translating. So thank you for understanding. I really appreciate it. You may go ahead.
Thank you. I am a proud member of CASA and know firsthand the difficulties of not being able to purchase health insurance.
Estoy aquí para resaltar los beneficios que obtendría un inmigrante como yo al tener la posibilidad de comprar un seguro médico. Es claro que aportamos al desarrollo económico del Estado con nuestras labores. En mi caso, soy profesional con el deseo de poder servir con mis conocimientos en beneficio a la ciudadanía. Y lo he hecho por el último año en el sector de cuidados de niños y en todo este tiempo he estado sin seguridad médica.
I am here to highlight the benefits that an immigrant like myself would obtain by having the possibility of purchasing health insurance. It is clear that we contribute to the economic development of our state. In my case, I am a professional who desires to contribute my knowledge to benefit our society. I have done so for the last year in the child care sector, and all this time I have been without health care.
Tener la protección en la salud permite prevenir enfermedades que a futuro serían costosas para la persona y el Estado. Por ello, tener un control permanente garantiza salud reflejada en productividad para todos.
Having health protections allows you to prevent diseases that would otherwise be costly for the person and for the state in the future. Therefore, having a constant access to care guarantees health reflected in productivity for everyone.
Ante cualquier afectación, nosotros sin seguro médico nos vemos obligados a automedicarnos, ya que no tenemos acceso a cuidado primario ni a un doctor de cabecera que nos examine, dado que no existe el beneficio de comprar un seguro respaldado a través de Maryland Health Connection.
In the event of any illness, we without insurance are forced to self-medicate since we do not have access to primary care or access to a regular doctor, given that we do not benefit from being able to purchase health insurance backed through the Health Maryland Connection.
Como trabajadora del cuidado infantil, estoy en un entorno propenso a gérmenes y enfermedades. Como una mujer, hay muchos exámenes que debería haber tenido pero sin seguro médico el precio es extremadamente inaccesible. Muchas familias en Maryland, como la mía, estarían agradecidos al saber que este proyecto de ley fue propuesto, escuchado y aprobado. Ya saben que ustedes se identifican con las necesidades sociales y la salud de los inmigrantes. Es una de ellas. Gracias a todos por escucharme y por su apoyo para asegurarnos a todos este seguro.
As a childcare worker, I work in an environment where I'm prone to illness and germs. As a woman, there are many tests that I have not had because without insurance, the price is extremely unaffordable. Many families in Maryland, like mine, would be grateful to know that you all took the time to hear this proposed bill and would potentially approve it. They will also know that you identify the social needs and that health insurance for immigrant families is one of them. Thank you for listening to me and thank you for your support in insuring everyone.
El siguiente. Next, please. Gracias. Thank you.
Muy buenos días, miembros del honorable comité. Mi nombre es Rafael Lacayo, soy miembro de casa, vine hace 20 años de mi país, Nicaragua. Soy residente del condado de Montgomery en el distrito 17. Soy un inmigrante y me encuentro hasta la fecha indocumentado y sin ninguna oportunidad de poder comprar mi propio seguro médico. Vengo a testificar que no tengo seguro médico y yo creo que merezco que se me respete la dignidad humana e intrínsecamente mis otros derechos ligados como a la vida, salud, trabajo que tenemos como ser humano.
Good morning, members of the committee. My name is Rafael Lacayo. I am a member of CASA. I've lived here in the United States for 20 years and I'm from Nicaragua. I'm currently living in Montgomery County, District 17. I am an immigrant and to the date, I am undocumented without an opportunity to purchase health insurance on my own. I am here to testify that I do not have health insurance and I believe that my human dignity deserves to be respected, as well as other intrinsic rights linked to life, health, work that we have as human beings.
Y que esta gran nación abandera estos derechos como tal en la Declaración Universal de Derechos Humanos. Vengo hoy día en apoyo a este proyecto de ley que me permitirá a las personas de mi comunidad y a mí mismo a comprar un seguro a través del Affordable Care Act, del cual no somos elegibles en este momento.
And that this great nation champions these rights, such as also in the Universal Declaration of Human Rights. I am here in support of this bill because it will allow people in my community and myself to purchase insurance for which we are currently not eligible for through the Affordable Care Act.
Paso a narrar mi historia al respecto. Tenía un año de haber venido a este gran país de oportunidades y un día en el trabajo me dio una fuerte fiebre. Ese día salí temprano y supe que algo andaba mal en mi salud y como la mayoría de las personas sin seguro, tenía miedo de ir al hospital. Eventualmente, el dolor era más agudo, que no tuve otra opción que ir a una clínica privada. Me hicieron algunas pruebas y vine a saber mi peor pesadilla. Me diagnosticaron una enfermedad renal. Necesitaba varias consultas con el especialista varias veces a la semana y recibir tratamiento.
I will now narrate my story. 1 year into coming to this country, that I came here to work for better opportunities, I came down with a terrible fever at work. That day, I left early and I knew that something was extremely wrong with my health. And like most people without insurance, I was afraid to go to the hospital. Eventually, the pain was so acute that I had no choice but to go to a private clinic. They did some tests on me and I came to know my worst nightmare. I was diagnosed with kidney disease. I needed to see my specialist several times a week to receive treatment.
Dejé mi trabajo a causa de mi enfermedad. Tenía que pagar mi renta, aunque no trabajara, y por supuesto mis alimentos. Por suerte tenía mis ahorros. $50,000 de ahorros se me fueron de mis bolsillos en tratamientos y costos de vida en menos de 8 meses. Luego de un tiempo después, un médico me dijo que tenía un problema renal y tenía otro problema subyacente. En ese momento tuve que considerar suspender el tratamiento por carecer de recursos económicos.
I ended up eventually leaving my job because of my sickness. Luckily, thanks to my saving and other ways I found to pay for my rent and put food on my table. However, in less than 8 months, the $50,000 in savings I had were gone due to having to pay out-of-pocket expenses for my treatments and other needs. After some time, a doctor told me that there were more issues than just my kidney problem, that I had another underlying problem. And at that time, I had to consider stopping treatment due to lack of financial resources.
No me puedo imaginar si hubiera pasado algo peor. Estas situaciones y sufrimientos los vivimos la mayoría de los inmigrantes. Ahora estoy con buena salud y de nuevo en una situación económica estable. Ser indocumentado, eso no debería de ser razón alguna por la cual se nos prohíba comprar una póliza de seguros. Con su apoyo, muchas familias tendrían todo el apoyo necesario a través de Maryland Health Connection para comprar y verificar un plan adecuado con la ayuda de los navegantes en el idioma preferido. También contarán con la tranquilidad de saber que no serán estafados y discriminados por su estatus migratorio.
I can't imagine if something worse would have happened. The majority of immigrants experience these situations and suffer. Now I am in good health and once again in a stable economic condition. Being undocumented should not be a reason that we are prohibited from purchasing health insurance policy, especially if it's coming from our hard-earned pockets. With your support, many families will have the support needed through the Maryland Health Connection to purchase insurance and have access to navigators to allow them to travel the plan through their preferred language. They will also have the peace of mind that knowing that they will not be scammed or discriminated against because of their immigration status.
Les pido que cuando debatan y consideren este proyecto de ley, piensen en mí y en mi comunidad, que somos personas que brindamos todo nuestro trabajo para nuestras familias y que por lo menos deberían tener acceso a comprar un seguro médico. Muchas gracias por su atención.
When you consider this bill, I would like for you to think of me and my community. We are individuals who give it our all for our families, and we would like to have the opportunity to purchase our own health insurance. Thank you for your time.
Thank you for your testimony. Gracias por su testimonio. Are there any questions for these witnesses? Delegate Taveras.
Thank you. I'll translate. Buenas gracias. Yo soy su representante a la señora. Una pregunta, no tienen que revelar todo, pero aproximadamente cuánto ustedes ganan, vamos a decir, mensual para poder pagar su propio seguro médico.
Delegate Taveras, can you say it in English, please? And the translator will translate because we need to have it for the record.
Yeah, no, I'm not about to
No, let her do it, please. Just ask the question in English.
Okay.
Thank you.
So,
Go ahead.
you don't have to reveal all your details, but approximately about how much do you make a month so that you could pay for your own medical insurance?
Es una pregunta y puede responder si quisiera, pero no tiene. Sí, es una pregunta que está haciendo.
Sí, puedo responder.
Yes, I can respond.
En algunos meses pueden ser 600, 700, dependiendo la tarea y que se esté desarrollando. No, mensual.
So depending on the month and the projects that we receive, it could be between 500 and 600.
Thank you.
Bueno,
Ya.
bueno, yo gano aproximadamente semanal unos $2,000 a $3,000.
So I earn approximately 2,000 to
No, mensual, disculpe, mensual.
I will interpret the first part and then the second part. Approximately $2,000 to $3,000 a week. Apologies, that is monthly, not weekly.
Okay. Any other questions? No. Thank you so much for being with us today.
Gracias por estar aquí. Ya terminamos.
Okay. Next, we have Mr. Vincent DeMarco, Lady Garcia, Bridge Dumay, and Reverend Kobe Little. Did I skip?
Madam Vice Chair, members of the committee, and my name is Vinny DeMarco, President of Healthcare for All Coalition. Thank you so much, Delegate Cullison, for putting in this legislation. It is critically needed. I can tell you that we have over 400 faith, community, labor, business, and healthcare groups from across Maryland who strongly support this measure and will work with you. We are proud to have worked with you to reduce Maryland's uninsured rate from 13% to 6%. And as we presented before you in December, that has reduced uncompensated care in Maryland by over $460 million. Over $460 million. We continue to reduce the number of uninsured, will reduce the uncompensated rate care even more, which will help reduce all of our premiums. So the people of Maryland really want this to happen, as is seen by the breadth of our coalition, and all of us will be helped, including the people who you heard from today, but also all of us by reducing uncompensated care. We strongly urge you to enact this very important legislation. Thank you very much.
Wow, Mr. DeMarco. Let's get a minute. That's a first. Go ahead.
Thank you. Thank you, Madam Chair and Co-Chair and members of the committee. My name is Lady Garcia. I'm the Senior Manager for the Navigation of Health and Social Services at CASA. Maryland's largest immigrant organization, CASA is a national powerhouse building power and improving the quality of life in the working class, Black, Latino, Afro-descendant, Indigenous, and immigrant communities. With a membership of over 155,000 members, CASA creates change by its power building model, building and blending human services, community organizing, in order to serve the full spectrum of the needs, dreams, and aspirations of members. And today, on behalf of the members who have made access to care their top legislative priority, I respectfully urge the committee for a favorable report on House Bill 728, the Access to Care Act. On the number of vital services we provide for our community from Prince George County, Montgomery County, and across Central Maryland, including education and employment, financial literacy, and legal services. By far, we touch the largest number of people through our health services. Just in the last year alone, we assisted over 55,000 Maryland residents with a wide array of health services navigation. Why are such services in such a high demand year after year? Our population is largely uninsured and excluded from a formal healthcare system almost completely due to their immigration status. In my 10 years at CASA, providing critically needed health and social services, 2023 was by far the most impactful for not only myself, but for my entire team. With the expansion of healthcare coverage via the Healthy Babies Act, hundreds of CASA members were able to get insured during such a critical time for the first time. This is because even though Maryland has taken great strides in prioritizing health equity and being a leader in embracing reform, little has been done to address the care for the nearly 5% of the population that remain undocumented and underinsured, and who make up about 30% of the uninsured. HB 728 will help correct the injustice and simply allowing the Maryland Health Benefit Exchange to submit the waiver amendment that would allow access to marketplace for all Marylanders, regardless of their immigration status. Thank you.
Next, please.
Good afternoon, Madam Chair. I want to thank you so much for the opportunity to address this committee. Good afternoon, Madam Vice Chair and members of this committee. I am Reverend Kobe Little. I'm president of the Maryland NAACP. I'm delighted to be here today in support of this legislation and in support of CASA and the many allies who've turned out to support this legislation. The NAACP is a democracy organization. And in Maryland, my hope is we hold democracy near and dear. You cannot have democracy without a strong reverence and support for human rights. And healthcare is a human right. Healthcare is a human right. You've heard some concerns that this bill prioritizes paying for healthcare for one group over another group. In fact, this bill only makes access to the marketplace available. We ought to, in this state and in this country, pay for healthcare for everyone who needs their healthcare paid for. But we certainly are falling down on our job if we don't ensure that all people who live in this state have access to buy health insurance. To deny people access to buying health insurance is not only a financially unsound policy, but it is a terrible violation of human rights. We urge a favorable report on this legislation, and we thank the Honorable Chair for this opportunity to address this committee.
And thank you so much for your partnership and your work with the communities, and we really appreciate it. I'm going to open it up for questions now from the committee. The first one is Delegate Morgan.
Thank you, Mr. Chair. Mr. Chair. Thank you, Madam Chair. It's been a long
Thank you,
couple
my
days.
pleasure. It has been. Thank you.
Mr. D'Amato, Vinny.
Hi.
I had a question. You had such a strong answer there talking about uncompensated care. What was that number again that you quoted?
Of over $460 million.
Well, the interesting thing is I remember reading at one time a report back in like 2007 that said that Maryland had uncompensated care of $460 million. And I just looked it up. Uncompensated care last year in the state of Maryland was actually quite high. It was $842 million in 2022. But the uninsured rate has dropped from 13% to 5.5% in that time. So you want to make some comments on how we have 5.5% of the people in our population, but yet uninsured claims, uncompensated care claims have kind of skyrocketed in the last couple of years.
Well, part of that is just a matter of population growth. But the report that I talked about, we presented to this committee, and the guy who wrote it, Steve Ports, presented it and described how over the time period when the uninsured rate went from 13% to 6%, there was a $460 million drop in uncompensated care. And he thinks that's a low estimate. He was trying to be very, very conservative. And we know that that would have gone directly into higher premiums. So, I mean, we know that it's successful. When you increase the number of insured, you decrease how much is happening in uncompensated care. The total number could go up because of population, et cetera. But the uncompensated care will decrease if you increase the number of insured.
Following you on that, so with the uncompensated care at that point, if let's say that goes to zero, which probably mathematically could never happen, but let's just say it did, would the ratepayers experience a decrease in premiums if that was the case?
That's an excellent question. A lot goes into premiums, but one of the things that pushes premiums up is uncompensated care. And insurers have a medical loss ratio that controls how much they put into things that are not healthcare and premium and reducing premiums. So it will, but we don't know how much. And the complicated thing is we don't know how much more premiums would have been if that 460 million uncompensated care had not been reduced. But we do know we all benefit when healthcare is expanded.
My pleasure. Delegate Lewis.
Thank you, Madam Chair.
You're
Thank you to
welcome.
the panel. My question's for Mr. DeMarco. Is it possible that uncompensated care costs increase because there are sicker people seeking care in emergency rooms, people who've not had access to preventive care, and so they end up sicker and then they cost more? Is that possible? Explanation?
It is. I'm actually the wrong person to ask. I wouldn't know how to answer that specifically on what causes uncompensated care to go up, other than people being uninsured, but I do know that when you reduce the number of uninsured, you reduce uncompensated care. That's what the study showed.
Thank you. Delegate Johnson.
Thank you, Madam Chair. Mr.
You're welcome.
DeMarco, I'd like to rephrase Delegate Lewis's question. When people don't have insurance and they do not do preventive care, and then they find out later on they have more advanced illnesses that are more costly to treat, is that a factor in policy?
I absolutely will be, and I'm sorry if I misunderstood exactly what Delegate Lewis was getting at, but absolutely, when people don't have primary care treatment, you heard it from some of the other panelists, that getting people the primary care and preventive care will keep them out of the hospital and keep uncompensated care lower. Absolutely.
You're welcome. I don't see any other any questions, but I do see a witness is signed up, and I call Bridge Dumais. Would you like to give your testimony?
Sure, thank you. Good afternoon, Madam Chair, members of the committee. I apologize. I did not realize there was a delay between the live stream and what was happening in the space. So I will keep it short and sweet today. My name is Bridge Dumais. I'm the political coordinator with 1199 SEIU, United Healthcare Workers East. We're the largest healthcare workers union in the nation, representing 10,000 workers right here in Maryland. I'm also the co-chair of End Medical Debt Maryland, which is a statewide coalition of labor unions, faith leaders, economic justice advocates, and patients' rights proponents. So both of our organizations are strongly supporting this bill. We have a critical short staffing crisis in our healthcare system. We have the longest ER wait times in the country. And we know that getting healthcare in the hospital is the most expensive way to get healthcare. And passing the Access to Care Act is going to help address all of those issues and uplift all Marylanders. We urge a favorable report. Thank you.
Any questions for this witness? Seeing none, thank you so much. For the committee members, the chief clerk is here. Do you have any bills? Remember, the deadline is at 5 o'clock, and she's in the back in my office. If you have any bills, will you be so kind and make sure she gets it? Okay? So that you can file them on time, all right? So thank you very much for your testimony and for your service to the state of Maryland. We appreciate it. Reverend Kobe Little, it was great seeing you. Thank you very much.
Madam Chair, as the next panel comes, as a person with a hearing disability, I just would like to offer to this committee that the captioning that is available on the exterior monitors, it would be very helpful if it's also available on these monitors. So if you'd share that with the House leadership, we'd be grateful.
Yeah, I will share that because we have it on YouTube and it's outside. I'll make sure to tell them about this. Thank you very much. I appreciate the feedback. We appreciate it. So if I may have, please, Mr. Ken Phelps, Stacy Wilson, Lead Hudson. Will you come up, please? And as soon as you sit, will you be so kind and get started? Thank you very much.
You're welcome.
Thank you.
Greetings, Madam Chair, Vice Chair, members of the committee. I'm Reverend Dr. Stacy Cole Wilson, the Executive Minister of the Beloved Community for the Baltimore Washington Conference of the United Methodist Church. The United Methodist Church declares that healthcare is a basic human right, as we've heard. We also believe and have been a strong advocate for a comprehensive healthcare system that includes access for all people, quality care, and effective management of costs. The church also says it is unjust to construct or perpetuate barriers to physical or mental wholeness or full participation in community. And so I am here in support of House Bill 728, as we believe that it will indeed reduce the number of uninsured, increase access to healthcare, and if it could indeed possibly help us to remove barriers to affordable and safe access to healthcare, that we should indeed support it. We know from our earliest days that United Methodists have believed that providing healthcare to others is as an important duty of Christians, and that John Wesley found ways to offer medical services at no cost to the poor, to those who were considered poor. We also understand that we are interconnected and an interrelated people. And the Reverend Dr. King said this best. He said, in a real sense, all life is interrelated. All, and I'll edit here, all humans are caught in an inescapable network of mutuality, tied in a single garment of destiny. Whatever affects one directly affects all indirectly. And I can never be what I ought to be, or we can never be what we ought to be until you are what you are to be, and you can never be what you ought to be until I am what I ought to be. Together we are community, and together truly what impacts one of us impacts all of us, and therefore we should in fact do all that we can to reduce barriers to healthcare.
Thank you very much. Appreciate your testimony. Next, please.
Madam Chair, Madam Co-Chair, and members of the committee. I'm Ken Phelps. I'm the co-director of the Maryland Episcopal Public Policy Network, and I thank you for the opportunity to give you a little sermonette. Yes, I extend greetings from our bishops and from the member congregations of our diocese, but also the Episcopal Church, who also adds their voice to that declaration that healthcare is indeed a basic human right. The sermonette. The founder of our Christian movement and the proponent of this radical idea that we love our neighbors as ourselves, himself described in 2 stories from the Bible as a both immigrant and refugee, actually gave healthcare away freely. The stories about his healing ministry teach us that he also saw it as a universal right. He healed those who were poor and oppressed, also healed the oppressor. He healed those who were his countrymen, who were inside the traditions and customs of the Jewish religion, but also those who, defined by that religion, the ins and outs, were seen as the undocumented in his day. As people of faith, we know that faith is not belief, in a particular system or tradition, but is instead a matter of trust. Trust that doing the loving thing will prove in the end to be the right thing to do. Last year, this committee did the right thing and moved this through the House, where it passed. And humbly, the Diocese of Maryland and the Episcopal Church is just asking you to do that again, to do the right thing. We urge a favorable report.
Thank you very much for being here today. Next, please.
Madam Chair, members of the committee, thank you for generously hearing what we have to say about this bill. My name is Lee Hudson. I'm part of the Evangelical Lutheran Church in America in its Maryland expression. And that generosity, I want to say, goes back decades in my experience, all the way to when this predecessor of this House committee was chaired by the sainted Michael Bush, who did a great deal on this subject. So you have our written testimony. Permit me just to summarize it in this way. Why are we here to urge that those people have access to the Maryland Health Benefit Exchange? Because it is our advocacy that all people should have access to healthcare. Thank you.
Thank you very much for your testimony and for your service to the state of Maryland. Are there any questions from this committee? Seeing none, thank you so much. And everyone that's still waiting, thank you for being patient. We will get to your bill. The next panel is actually Ms. Tricia Swanson, Matthew Chantillano, Frank Patinella, Brian Sims, Nashona Kess, Ms. Kess, Maria Cruz. Okay, Brian Sims. All right, you can get started.
Madam Chair, members of the committee, Matt Celentano here today on behalf of the League of Life and Health Insurers in support of House Bill 728. Since the passage of the Affordable Care Act, we have made tremendous strides in coverage and halved the amount of uninsured Marylanders, which has resulted in a dramatic reduction in uncompensated care costs. This bill would help continue that progress, with hundreds of thousands of Marylanders still without coverage or an opportunity to purchase coverage for themselves and their families for peace of mind. We're missing an opportunity. Simply, Giving everybody the ability to purchase coverage will help bend the cost curve of increasing healthcare premiums. The more that we cover, the better. Please support House Bill 728.
And thank you for your partnership. Next, please.
Madam Chair, Madam Vice Chair, members of the committee, my name is Tricia Swanson, and I'm here on behalf of Care First Blue Cross Blue Shield in strong support of House Bill 728. Care First strongly supports the creation of a qualified resident enrollment program, as we know that those people without insurance coverage have worse access to care than those who are insured. We also know that when people do not have insurance, the cost of care can be debilitating. The qualified program established in the bill would create a life-changing opportunity for many to access health insurance coverage. This program would also improve health equity, as data shows that coverage expansions narrow racial and ethnic health disparities. Part of Care First's mission is to assist and advocate for public and private healthcare initiatives for individuals without health insurance. For that reason, we strongly support House Bill 728 and urge its favorable report. Thank you.
Thank you. Thank you for your partnership.
Good afternoon, Madam Chair, Madam Vice Chair, and members of the committee. Thank you for having me. My name is Brian Sims. I'm the Vice President of Quality and Equity at the Maryland Hospital Association. I'm not going to repeat many of the very comprehensive points you heard today, but I do want to just highlight one, and that is the public health benefit of expanding access to care for those qualified residents. And so, the one point I want to make is that when individuals have access to preventative care, which you've heard quite a bit about today, that treatment and that care can help to mitigate communicable diseases within their communities. And it also helps to protect the overall population from the spread of illness. And so just one point that I wanted to amplify in a little bit of a different way than you may have heard today. And so for that reason and all the reasons you heard this afternoon, we at the Hospital Association on behalf of our members strongly urge a favorable report on HB 728. Thank you.
Thank you so much for your service. Next, please.
Good afternoon, Madam
Good
Chair,
afternoon.
Madam Vice Chair, and members of the committee. My name is Frank Patinella, Senior Policy Advocate for the ACLU of Maryland. As son of immigrant parents, I just want to say us too. So thank you.
Oh, the committee loves that. That's a hint for the rest of you. All right, are there any questions for this panel? Seeing none, on a serious note, thank you so much for being here, okay? Nashona Kess. Maria Cruz. Okay, no, okay. We have a virtual witness. Is she here? Ria, let's bring her. Good afternoon, ma'am. Good afternoon. Ms. Aurora.
Good afternoon.
Hi, how are you? Can you get started?
Hi, yes, that's me.
All right, great. Nice to see you. Good afternoon and welcome to our committee. And will you give us your testimony, please?
Hi, I think there are two voices.
Do you have YouTube?
Oh, I do. I have.
Can you turn it off?
Yes, I'll turn it off.
I'm
Yes,
becoming
I'll turn
very
it off.
technical.
No, I appreciate that.
My son
Thank
will
you.
be very proud of me
No,
because I'm
I
alwaays
appreciate-
calling him. Oh, go ahead.
All right. Yes, I'll begin my testimony now. Good afternoon, Honorable Chair Penny Melnick, Vice Chair, members of the committee. My name is Ria Aurora, and I'm a resident of District 46, and I'm a first-year medical student at the Johns Hopkins University School of Medicine, and I've lived in Maryland for 4 years. I am submitting this testimony in support of House Bill 728, and the views here expressed here are my own and do not necessarily reflect those of Johns Hopkins or the Johns Hopkins health system. Prior to starting medical school, I lived in Maryland for 4 years while attending Johns Hopkins for my undergraduate studies. While at Hopkins, I spent 2 years as a patient advocate at a pediatric clinic, connecting uninsured Latino families to resources related to social determinants of health. Last year, I moved to Washington, D.C. and served as an AmeriCorps Fellow at La Clínica del Pueblo in the Gender and Health Program. I connected Latina women who are survivors of gender-based violence to community-based resources, legal, and medical services. Now, in returning to Hopkins for medical school, I have continued to work with Latinx communities as part of the Refugee Health Program, providing support to asylum seekers in connection with the Asylees Women's Enterprise. This year marks my 4th year supporting Latinx communities in Maryland. House Bill 728 addresses critical health disparities faced by the immigrant community in Maryland by expanding the Affordable Care Act to all Marylanders, regardless of their immigration status. By a simple act of requiring the exchange to request a 1332 waiver to allow Maryland residents, regardless of immigration status, to purchase insurance on the exchange. House Bill 728 represents an important milestone in our journey towards creating a resilient healthcare system. Having worked in Latinx communities for 4 years, I have witnessed these disparities firsthand. As a patient advocate, I remember assisting a 45-year-old uninsured female immigrant when making a dental appointment, having already had several teeth fall out. At La Clinica, I saw those disparities with my clients living in Maryland. I work with a 26-year-old uninsured female immigrant experiencing a high-risk pregnancy. In a call with the hospital, I was told that because she has no health coverage, a surgery she might need would cost $50,000 to $60,000. Now, as a medical student in Maryland, I continue to see these gaps in access to care with the Refugee Health Partnership. I urge a favorable report of House Bill 728. As a medical student and future physician, I want to practice in a world where patients do not have to sacrifice their right to healthcare to maintain their quality of life. Thank you for your consideration and for your leadership.
And thank you for your patience because you waited a while. Are there any questions for this future doctor? Seeing none, good luck with your studies and thank you for choosing a career of service, okay? We really appreciate your testimony.
Thank you.
And thank you. Take care. Is there someone here who didn't get called and signed up for this bill? Can you please come up? And I apologize. You give us your name. You have been so patient.
Yes. Good afternoon, Madam Chair, Vice Chair, members of the committee. My name is Joe Nguyen. I'm the Executive Director of the Maryland MCO Association. I'm here today to support House Bill 728. I won't repeat everything that's been said. The bill gives people an opportunity to buy products on the exchange. The association supports opportunities like this. It expands access to care, provides coverage options, right care, right place, appropriate care, appropriate setting. Preventative care keeps people out of the ER, so we think it's good public policy and urge a favorable report. I have very brief remarks. I know I'm the last witness, and thank you for hearing
Well,
me
we
testify.
love that. Great way to end the hearing today. Are there any questions for this witness? And thank you, Joe, for your partnership. I love seeing you in that role. Congratulations.
Thank you.
You're welcome. This actually ends and concludes the hearing on House Bill 728. I want to thank everyone for being so patient as we encounter not just technical difficulty, but other barriers that, we have to learn from it, right? As a committee, and we promise to improve and work on it, right? And we are very grateful that you're so patient with us. We are now going to go to House Bill 628, Delegate Johnson, who is right here and ready to go, and everyone else that is waiting for we only have 2 more bills after his. Thank you for being patient. So Delegate Johnson, you have Armanda Darnley, Viviana Azar, Jennifer Fang Brand, and Robin Elliott on your panel. Can you ladies please come up, and gentlemen? Thank you. And you may get started. Good afternoon.
Thank you, Madam Chair. Well, after that marathon bill, this is going to seem like a sprint.
I love that. Let's do it.
Thank you. Good afternoon, Madam Chair, Vice Chair, and members of the Health and Government Operations Committee. I'm Delegate Steve Johnson, here to present House Bill 628, Health Occupations, Clinical Marriage, and Family Therapist, Reciprocal Licensure Requirements. This legislation would streamline the license process for marriage and family therapists, MTFs, for out-of-state applicants. The bill would result in increasing flexibility for Maryland behavioral health applicants. The bill would Maryland behavioral health programs to recruit and retain MFTs from out of state. These MFTs could provide either in-person services or telehealth services. I'm introducing this bill because Maryland needs to use every option to increase the number of qualified behavioral health providers serving Maryland residents. We are in the midst of a severe behavioral health provider shortage in nearly every jurisdiction in our state. MFTs are licensed in all 50 states, and those states have very similar, I want to repeat that, very similar licensure requirements for education, exams, and supervised hours for new entrants into the profession. However, unlike other health professions, a licensure compact is not a workable solution to address licensure portability for MFTs. Over half of the MFTs in the United States live in California, which is a state that does not join compacts. A compact only works if you can achieve a critical mass of licensees covered by a compact, which is not the case with MFTs. The American Association of Maryland and Family Therapists, who are here on my panel today, spent several years studying other reciprocity options. Since licensure requirements are so similar across the states, they developed a proposal that would allow states to license applicants from out of state more quickly and make the application process as seamless as possible. You have the proposal in front of you today in House Bill 628. There are at least 10 states, including our neighbor state of Virginia, considering similar proposals this year. The following are practical aspects of how House Bill 628 would work. The MFTs are licensed by the Board of Professional Counselors and Therapists. If the board receives an application from an out-of-state practitioner, the board would check if the applicant's out-of-state license was in good standing. If so, the board would ask the applicant to complete two Maryland-specific requirements: a criminal history records check and the Maryland exam on state jurisprudence exam. This process would be much faster than the current one. Right now, the board must conduct a detailed review of the applicant's education, exam, and supervised hours, even if they have a license in another state. In essence, our board has to duplicate the work already done by a board in another state. This duplicative process increases length of time to process the applicant and delays the applicant's entry into practice. This process also significantly increases the administrative resources needed to process the applications, and I believe those resources could be better deployed elsewhere. There are about 300 MTFs in Maryland, but there are more than 70,000 MTFs nationwide. If we can streamline the Maryland process, we will increase the likelihood that our outpatient mental health centers, federally qualified health centers, and other behavioral health providers can recruit and retain MTFs who live outside the state of Maryland. The board would retain complete regulatory authority, and you all that know me know that's important to me, over an out-of-state MFT because the practitioner would have a Maryland license. This arrangement is a little different than in a compact where discipline is a shared responsibility between the board in the provider's home state and the board in the state where the patient lives. Lastly, I want to mention a development that is particularly important to me. In 2023, Congress enacted legislation that allows MFTs to bill Medicare. This legislation can be a game changer for access to behavioral health services for older residents in Maryland. If we can attract more MFTs to practice in Maryland, we could expand access significantly for our older adult communities. And I want to repeat, the requirements are very similar across the United States, with Maryland being about in the middle. I also want to point out that our Maryland board, their job is to protect the citizens, and they have approved this bill. They endorsed this bill. And one more quick thing, as we were hearing a bill the other day, I was looking up some information on the internet, and I happened to run across a statement that was regarding to marriage family therapists from another state. And it said that most states will license on a reciprocity basis if your state has similar standards. Most states will even grant some sort of temporary license if the state's requirements are similar and there is an emergency need. And with that, I'd like to turn it over to my panel.
Thank you, Delegate. Good afternoon.
Good afternoon, Madam Chair, members of the committee. My name is Amanda Darnley. I represent the American Association of Marriage and Family Therapy, and I thank you for hearing us for testimony today on House Bill 628. Maryland is in a severe mental health provider shortage. There are 330 citizens to every one mental health provider in this state. Obviously, COVID created quite a crisis that has led to long wait times for our Maryland residents and to clinicians who are not able to refer to other clinicians because there is a lack of availability between their work. AMFT, my organization, spent the last 2 years researching state licensure laws amongst the 50 states, discussing these issues with regulatory boards and MFTs across many states. We are here today to ask you to help us to eliminate unnecessary barriers to licensure for MFTs and to expand access to care for Marylanders. This is possible because the regulations state to state for MFTs are very uniform. We are currently proposing this legislation in 10 states, as Delegate Johnson mentioned, and we are pleased to report that it has passed the Georgia Senate and the Virginia House in the last 2 weeks with unanimous support. I also would like to reiterate the unique aspect of our bill as compared to other portability bills in respect to the Maryland's regulatory board's oversight of an LMFT providing services to a resident. They also would be people who take advantage of this would be under the jurisdiction of the board to set continuing education requirements that may be unique to Maryland as well. Thank you for the time today.
Thank you for your work in Maryland. Who is next, please?
Thank you, Madam Chair and Madam Vice
You're
Chair
welcome.
and members of the committee for the time to testify today. My name is Jennifer Fong Brem, and I serve on the Board of Directors as the President for Metro Marriage and Family Therapists. We represent the Professional Membership Association for Marriage and Family Therapists in Maryland, Washington, D.C. metropolitan area, and Northern Virginia. We favorably support House Bill 628 because it benefits both marriage and family therapists as well as consumer client families. We believe that licensure reciprocity and portability will help us to streamline the licensure process across the states, removing barriers that create undue burden for independently licensed marriage and family therapists who wish to practice in Maryland, and thereby reciprocity for us to practice in other states. We also believe that licensure reciprocity and portability will provide access and continuity of care for our clients, for our consumers who live and work across different neighboring states or districts who would like to access telehealth from a different state as their therapist is physically located. Thank you for your time.
Thank you for your service. Who's next?
Hello, my name is Viviana Zar, and I'm a licensed clinical marriage and family therapist. I'm the advocacy officer for Metro Marriage and Family Therapists. Madam Chair, members of the committee, thank you very much for giving me the opportunity to testify in support of House Bill 628 for licensing portability for out-of-states marriage and family therapists. I'm going to address the issue of workforce shortage as I work in the public mental health system. And as you all know or heard, there has been a workforce shortage. It's very hard to hire mental health professionals, and particularly those who are who have the knowledge and experience of working with children and families. And I think licensed marriage and family therapists are needed in the state. And I have heard from colleagues and in my own experience, we had experience of interviewing candidates who had the expertise, who were licensed in other states, but due to the cumbersome process and the requirements for licensing by endorsements, sometimes they declined offers because of the difficulty in obtaining the license. In some situations, they were hired by their practice, but they were not seeing Maryland residents. It took months for them to start seeing Maryland residents. For that, I urge you to support House Bill 628. This bill will break down the barriers to obtaining a license when a marriage and family therapist is already clinically licensed in another state, and it will decrease the administrative load for the board while maintaining high standards for all licensed clinical marriage and family therapists across states. Thank you very much. And
You did well.
thank
for
you.
coming.
You
We
tell I was
appreciate it.
nervous.
It's okay. You know, it takes a lot to come here, right? And come in front of strangers and pour your heart out. So we really appreciate it, okay?
Thank you.
Next, please.
Good afternoon, Robin Elliott. I'm here today on behalf of the American Association of Marriage and Family Therapists. I am mostly Me Too. I just wanted to provide 3 key points. First, there are about 300 marriage and family therapists here in Maryland, but there are 72,000 of them nationwide. So essentially what this bill does is offer an avenue to pull in some of those 72,000 marriage and family therapists into Maryland. The second thing I wanted to note is you also have a letter of support in the bill file from the Maryland Healthcare Commission, which did a study on licensure reciprocity and portability related to telehealth at the request of this committee. And then the third thing is this bill is a little bit different than the reciprocity bill that you heard last week. In that bill, the other state would have to adopt a very similar arrangement in order for their licensees to be able to practice in Maryland. With our shortage, so desperate for behavioral health providers, if we have somebody who is qualified from another state and wishes to practice in Maryland, we don't think it necessarily matters whether or not they let our practitioners in. We want all the practitioners we can get to come to the state of Maryland. So this bill really opens the door and would appreciate the committee's consideration. Thank you.
And thank you, Robin, for all your work that you do with all of us here and on this committee, okay? Who's next? I think that's it. So why don't we open it up for questions now? Are there any questions for the delegate and his panel? Well, delegate, you were very clear. There you go. No questions for you. All
Teamwork.
right, don't get used to it. Okay. Next, we have Delegate Allison Taylor. I don't know that you want to be delegate, but. Oh, and Sika and Cillian Alborn. Will you be so kind and come up, ladies? Thank you so much. And will you get started, Allison?
Good afternoon, Madam Chair and members of the committee. Allison Taylor on behalf of Kaiser Permanente, Me Too.
Oh, beautiful. Next, please.
Good afternoon. I'm Ann Seacott with Public Policy Partners, today representing the Maryland Association of Youth Service Bureaus. Youth Service Bureaus provide a range of counseling and other wraparound services to young people and their families. They hire psychologists, social workers, and marriage and family therapists, and they are in full support of this bill to help with recruitment and employment. Thank you.
Thank you for the work you do. Next, please.
Good afternoon again, Madam Chair, Madam Vice Chair, Sally Alborn from Maryland Community Health System. We are in full support of House Bill 628 and encourage a favorable report. Almost every jurisdiction in Maryland is a federally recognized health professional shortage area for behavioral health providers. And our health centers are located in areas with the most severe shortages of behavioral health providers and struggling to meet the growing demand for the needs of our patients. We support this legislation as it will streamline the licensure process for MFTs from other states. For our health centers, it will open up a potential pool of qualified applicants for the growing vacant positions for behavioral health providers. We thank you very much and ask a favorable report for House Bill 628. Thank you.
And thank you for being here today. We appreciate you. Are there any questions for this panel? Seeing none, thank you so much. This actually concludes the bill hearing on House Bill 628. Next, we're going to go to House Bill 400, Delegate Woods, Maryland Medical Assistance Program and Health Insurance, Annual Behavioral Health Wellness Visits, Coverage and Reimbursement. Will you be so kind and bring up your panel? And I believe that on your panel, you have Nsika, Abigail Snyder, Morgan Mills, and Jake Whitaker. Will you please come up and sit with a delegate? And delegate, you may start when you are ready. Okay.
Thank you,
Jake,
Madam Chair,
one
Madam
second.
Vice.
Jake, can you bring a chair from the end and put it over here next to Nsika, please?
Absolutely.
Thank you.
Yep.
Closer to you.
Thank you, Madam Chair, Madam Vice Chair, and members of this illustrious Health and Government Operations Committee. For the record, I am Delegate Jamila Woods here to present House Bill 400. House Bill 400 requires Medicaid and commercial carriers to provide coverage and reimbursement for annual clinical behavioral health wellness visits from a behavioral health provider without the requirement of a behavioral health diagnosis. This service provided by the behavioral health provider is not the same as an extremely limited screening by a primary care provider who simply asks 3 or 4 questions about how you drink, how you sleep, or if you're feeling sad. This is a full psychosocial evaluation. That's what we're asking for, conducted by a trained clinician. HB 400 addresses prevention while eliminating the stigma surrounding mental health and mental illness. Presently, a patient who seeks to be assessed by a primary care physician or behavioral health provider must be diagnosed with a mental illness for their insurance to cover the cost. And interestingly, that initial diagnosis may not be an accurate diagnosis or the diagnosis, if any, provided by a trained mental health clinician. Nevertheless, that diagnosis, and did I mention solely provided so the insurance carrier covers the cost, also inappropriately follows the patient. This is not the same for somatic healthcare providers like your primary care physicians, dentists, optometrists, gynecologists, and more. My doctor shouldn't diagnose me with cancer before the appropriate screening by a specialist to be compensated for his services. Currently, a primary care physician can provide a routine checkup with no actual condition that rises to the level of a formal diagnosis. Insurance covers the cost, and providers are reimbursed for the service. Unfortunately, this is not true for behavioral health care, and this really should be addressed as an ethical issue for both primary care physicians and for therapists as it relates to healthcare parity, as a physical and mental health, albeit both fall equally under the umbrella of health, but both requiring accurate and specific assessments to assure the appropriate preventative healthcare needs of patients are met. Current law excludes behavioral health providers from offering appropriately assessed preventative healthcare without first providing an initial diagnosis. Current law should also exclude a primary care physician from diagnosing a behavioral health condition without the completion of a full psychosocial evaluation. I reiterate my concerns that this is an ethical issue because this should not be permitted, providing a premature or otherwise inaccurate diagnosis in order to be reimbursed. The Maryland Healthcare Commission commissioned a study last year to determine the cost of annual behavioral health wellness visits from a behavioral health provider in the commercial market. That study found the mandate is expected to increase premiums by just 37 cents per member per month. They predict a 2% annual increase in the percentage of patients receiving treatment because of the mandate and a medical savings of 2.5% of total cost for each new patient. This bill advances how we approach behavioral health in Maryland. We destigmatize the interaction between clinician and patient, and we increase our ability to identify issues early and prevent more costly services and normalize mental health clinical and normalize mental health clinical assessments while also reducing financial strains that clients might experience. And for this reason, I am asking and urging a favorable response for HB 400. Thank you.
Thank you, Delegate, for your work. Who would you like to go next?
We're going to
Sika?
start with Ann.
Okay, great.
Thank you.
You're welcome. Good afternoon, Ms. Sika. How are you?
Good afternoon. I'm well. I hope all of you are doing well. I'm Ann Seacott with Public Policy Partners. And for this bill, we actually have several clients that have submitted testimony in favor of this wonderful bill that Delegate Woods, we're very pleased to have you supporting. You know, we get a lot of questions about this bill, about what, you know, can't you already do this? You know, aren't these screenings that happen from, you know, at your doctor's office, isn't that enough? And I want to step back and say, think about your annual physical and think about how you get to go. You can only go once a year. Your insurance company will make sure of that. And you are gone over head to toe. And if you leave that office visit without a diagnosis, without something new wrong, that is great. That is what we all would want. And that primary care provider can get reimbursed for that hour, 45 minutes hour that they spent with you. The same is not true with a behavioral health visit, a real true, as the sponsor said, psychosocial assessment of your behavioral, of your mental health, of any potential substance use problems, things like that. That's what we're looking for. But right now, if I were to do that, I would have to get a diagnosis in order for my provider to get paid. That's what we're talking about. We know that this is important in terms of prevention. We also know that this is about stigma, because there are plenty of people who are like, well, wait a minute, nothing's really wrong with me, but I need a diagnosis. Or if you go to a therapist who knows what they're doing, they're going to tell you up front, you know, even if there's no real diagnosis, even if you're not clinically depressed, you know, I'm still going to have to do that in order to get paid. That can scare people away as well because of the stigma that exists. So we really do believe that this is time to happen. And there's some testimony from a group called Inseparable, and it lists the states, I just don't have it in front of me, that have already passed this. And it's something like 7 or 8 states have already done this. So with that, we ask for your favorable report.
Thank you.
Good afternoon, Madam Chair. I have to say, this is the first time I've testified in this committee, and I've sat in here all afternoon, and it's literally the nicest group of people. So thank you. For the record, Abby Snyder, Director of Government Relations for the Baltimore Jewish Council, here in support of HB 400. The Baltimore Jewish Council represents the Associated Jewish Federation of Baltimore and all of its agencies, and this includes Jewish Community Services, which provides therapy and medication management to a large population of clients with both commercial and public insurance. Those behavioral health intervention services are incredibly helpful for patient well-being. During 2023, JCS performed 225 annual behavioral health wellness visits. And if we could have known that all of those would be covered without having to worry about a diagnosis, imagine how much more comfortable people would be coming to have those appointments and how many more people our social services would have been able to serve. As mental health and behavioral health continue to be at the forefront of our state's focus, it's really important that everyone feels comfortable receiving care. And I will say, as a personal aside, as someone with a mental health diagnosis, I can't imagine if I was worried about going to get assessed just to make sure that I had a diagnosis so that it would be covered and my provider could be paid. So for these reasons, we support a favorable report on this bill and happy to answer any questions. Thank you.
Thank you very much. Thanks for your patience too today. But you learned a lot, right?
For sure, so much. You guys learn about fascinating things in here.
Really? Thank you. Please go on.
Awesome. Thank you. Good afternoon, Vice Chair and distinguished members of this committee. My name is Morgan Mills. I'm here today on behalf of NAMI Maryland, and I'm pleased to offer our support for House Bill 400. This bill is bringing parity to existing practice. So many health insurers already cover annual health checkups. You know, you go to the doctor, you get your yearly physical, and that's covered by insurance. It's preventative care. This bill is requiring insurance companies to cover that same preventative health care as it pertains to behavioral health conditions. NAMI Maryland advocates for effective prevention, diagnosis, treatment, and support for people of all ages that are affected by mental illness. But in order for someone to be treated for mental illness, they must first be made aware of its existence. Conditions that go undiagnosed are left untreated, and people with mental illness deserve to be diagnosed, treated, and offered services that they need to achieve and maintain their recovery. 1 in 5 U.S. adults experience mental illness each year. 1 in 6 U.S. youth experience a mental health disorder every year. There are warning signs of mental illness that people commonly miss, ignore, or attribute to other factors in their lives, meaning there are people who are needlessly suffering because they aren't able to or don't speak with a professional about their problem. By requiring insurers to cover this annual wellness visit, not only are we helping people to get diagnosed, but we're helping to erase the stigma that surrounds mental health conditions. We're helping to break the barrier and encourage Marylanders to seek help now with the knowledge that their insurance can help cover this. This bill not only brings insurance companies into parity by covering behavioral health the same way they would physical health, it allows Marylanders the opportunity to have open discussions with their providers, get diagnosed, get treatment, and live more fulfilling lives. And for those reasons, we urge a favorable report. Thank you.
Thank you. Mr. Whitaker.
Great. Thank you, Madam Vice Chair and members of the committee. I'm Jake Whitaker. I'm Director of Government Affairs at the Maryland Hospital Association, here to testify in support of House Bill 400. House Bill 400 would increase access to critical behavioral health services at a time where they're needed the most. More than 200,000 patients enter Maryland emergency departments, regardless of their seeking behavioral health services each year. Maryland hospitals treat those patients regardless of their ability to pay. That said, too many individuals enter EDs seeking treatment, often in crisis, simply because they couldn't get the services they need in the community. The ongoing behavioral health crisis and lack of services in the community contributes to avoidable ED admissions. The increase in avoidable ED admissions adds to lengths of stay and makes worse hospital discharge and throughput challenges. This bill will increase insurance coverage for and access to critical behavioral health services in the community, which will help folks get the behavioral health services early, avoid being in crisis, and avoid unnecessary admissions to the EDs. So for the aforementioned reasons, we respectfully request a favorable report on House Bill 400, and I'm happy to answer any questions. Thank you.
Thank you. Thank you to the panel. Are there questions for this panel? Delegate Alston? Still thinking?
I know the time is late, but I just wanted to thank the good delegate and her panel for such a wonderful bill hearing. And thank you for helping me fulfill a campaign promise with this bill. I look forward to voting for it.
Thank you. Any other questions? Seeing none, you did a great job of conveying the information, Delegate. Thank you. We're now going to go to an unfavorable panel, and I'd like to call up Tricia Swanson, Matthew Celentano, Allison Taylor, who all have something in common.
Madam Vice Chair, members of the committee, again, Tricia Swanson on behalf of Care First Blue Cross Blue Shield. I'm here truly in respectful opposition to House Bill 400. I was able to have a great conversation with the sponsor of the bill a couple of weeks ago, and there is no doubt that we all agree on the outcome of what the intent of this bill is, to make sure that there are mental health services for those who really need it. We have concerns because best practice is to not separate the mind from the body when you're treating a person. It is best practice, as was mentioned, to have your PCP do that initial mental health screening check. Just a couple of weeks ago, I had my annual visit and I got quasi-lectured by my doctor about my stress levels. But she did a follow-up and made sure I was doing okay and asked if I thought I needed to see someone. And we had a conversation about stress and was I handling everything okay? And in a situation where I might not be, the best practice is for her to then do a warm handoff to a behavioral health specialist. So that's best practice. And I understand the sponsor's concerns that that conversation might not be happening in all PCP annual visits. And so we look forward to talking with her a little bit more after this bill hearing to see if there's something we can improve in that visit itself, to see if we can improve that handoff process. Because again, we don't believe it's best practice to separate the mental health from the physical health. The only other thing that I'll add is, as we're looking at shortages in the behavioral health specialists, CareFirst has some concerns that this might potentially exacerbate those shortages if a lot of people go out to get these annual mental health screenings, that might keep care away from those that need the much more comprehensive behavioral health services. I think that's all. The only other thing I'll add is this could potentially be something that the commission looks at, that you all passed last year, the Behavioral Health Commission, really looking at how we can improve that continuum of care to make sure that Marylanders are accessing mental health services. Thank you.
Great, thank you. Mr. Celentano?
Matt Celentano, thank you for the opportunity here today on behalf of the League of Life and Health Insurers in opposition to House Bill 400. Like my colleague Tricia said, conceptually, we're very supportive of this effort, as we obviously want beneficiaries to receive behavioral health services, but in a lot of ways, we feel like this is already happening. It's our understanding that MDH has said that the MCOs are already in compliance with how this bill is drafted. Medicare beneficiaries have a screening incorporated into their primary care visit, and Marylanders going to their no-cost annual wellness check are already being screened for behavioral health challenges. We'd like to see that continue, and we'd like to see that in a more robust fashion. If you're identified to have been having a potential red flag in your behavioral health screening, you're immediately referred to a specialist, which we think is the appropriate way to continue the way that the health insurance is currently set up. Well, we've spoken for years about removing stigma around behavioral health, and to separate the screening in the legislation is a backward step for having your primary care visit cover your whole self. This concern was raised by the MHCC when they analyzed this bill this past interim, and the commissioners, including the chairman, expressed their concerns with the approach of this bill and recommended not moving forward with the legislation as was drafted, as it would sort of break away from the sort of approach that we've been trying to focus on in primary care visits. Like Ms. Swanson had said, our other hesitancy on this bill, this committee obviously knows that we have a tremendous behavioral health provider shortage. And if we're going to have a separate behavioral health visit, an annual visit, there's going to be an influx of patients, we believe, looking for care and we're concerned we won't be able to find a provider to see them. Further reason that we think that we should ensure that there is a robust BH screening process at your primary care visit within the structure we already have. So thank you for the opportunity to chime in, and we urge an unfavorable report on House Bill 400.
Thank you, Matt. Allison?
Good afternoon, Madam Vice Chair, members of the committee. My name is Allison Taylor on behalf of Kaiser Permanente. Nothing further to add from what my colleague said, other than to reiterate that preventative behavioral health services is important. So happy to continue working on this and work.
Thank you. Questions for this panel? Delegate Bagnall.
Thank you, Madam Chair, and thank you for this presentation. As you know, I'm a big proponent of coordination of care and the warm handoff. And I was the sponsor of the collaborative care model, which I think Ms. Taylor has referenced in your written testimony. So my question is two parts. One, are PCPs behavioral health specialists? And two, is every PCP already participating in collaborative care model?
I don't think all PCPs are participating in the collaborative care model. And I think if I remember correctly, it took effect in the fall. And so it's probably still in the early stages.
Sure.
So there is a time lag that we anticipate, because involving yourself with the collaborative care model takes buy-in from the primary care provider. So do you see this bill as potentially filling that gap till we have a greater coordination of care? Because obviously we don't want to lose people in the interim as we're building out our preventative and maintenance behavioral health system.
I think our concerns still resonate with the shortages that we're facing in the behavioral health provider space, and potentially opening it up to anyone that wanted to go might keep services away from those that really need to access it. But I fully understand your concerns and your questions regarding that's best practice and we're kind of moving in that direction, but there is kind of a time period in the middle. But certainly willing to talk about it and figure out maybe some other ways that we can look at filling that in the meantime.
Thank you. Other questions of this panel? Delegate Johnson.
Thank you, Madam Chair, and thank you for coming to testify. And this question is for Ms. Swanson. Since you said that you just recently got a checkup and your doctor was talking to you about stress and asked you if you wanted to go see somebody. And if this is too personal of a question, by all means, just say so. I'm trying to get a perspective from the patient's point of view, since we're talking about collaborative care. So when you were asked, did you want to go see someone? Did it make you feel stigmatized or like, no, I don't want to see anybody. There's nothing wrong with me. So
No, not at all, but
point of view.
I will say, and I was talking to the sponsor about this, I have a fantastic PCP that I've been seeing for, I think, 15 years at this point. And so she knows me, she's seen me go through multiple iterations of going to school and taking on jobs like this. And so I never feel stigmatized by her, but I do acknowledge that somebody that doesn't know their PCP as well as I know mine and mine knows me might have that issue. And so what I can do, there's an assessment that PCPs use, and there's like a best practices guideline. I'm happy to send that information to the committee so we can take a look at that a little more. And there might be recommendations as to make sure that you're not stigmatizing a patient by asking those questions.
Was stigmatizing. The other was, is the collaborative care working? Do people feel more do they feel comfortable saying, yes, I would like to talk to somebody, to their primary care physician? So, okay.
I think what you could, I think if you or tell your PCP, yeah, I am really stressed. I think then there's some follow-up questions that your PCP then asks to really kind of figure out the right next step for you. Is it, talking about potential medications for you to go on to manage anxiety or depression? Have you thought about talking to a behavioral health specialist? Is that something that you're amenable to? We have different ways that you can access it now. You can do a telehealth visit. You can go in and see someone. And so I think it kind of facilitates that conversation with the PCP so they can figure out the best fit moving forward for their patient.
Thank you for.
Of course.
Thank you, Delegate. Delegate Austin.
Thank you. Just curious, maybe you all notice, or maybe I need to talk to some primary care providers, but I know when I go in for my annual physical, the amount of time that I spend with the actual doctor is not enough time to truly diagnose a mental health problem or disorder. You're in there for like 15, maybe 20 minutes after they do all of the tests. That's not enough time to do a true legitimate valid screening. And with all of the other demands of a primary care physician, I'm just wondering, how are we supposed to expect quality screenings, not just checking off the box? How often do you drink? How much do you work? How stressed are you? And doing a Richter scale to see where someone is. I'm talking about actually a quality screening from a mental health professional. And I don't see how a primary care can do that in 15 minutes. It's just, we might be borderline malpractice to expect them to. And I'm just wondering what your thoughts are with the amount of time that they have going from patient to patient to do that.
I'll double check this, but I believe that the screening, it's an initial kind of check with the patient. And if that individual if they're like, yes, I'm really stressed, I don't know how I'm managing all of this, there might be a follow-up appointment with the PCP, or she or he might recommend someone for them to talk to. But it's kind of that initial catch while you're looking at the whole person. I don't know
Okay. Do you want to follow up, Delegate? Okay, go for it.
I was not going to ask them, so I appreciate that.
Since no one else is asking.
Okay, so the only concern I have is when you're dealing with highly intelligent people, they know when they're being screened. And if they're in a career path that they know that if I say I drink socially and I go out every day when I drink, like I go out every night for dinner and I drink every night when I go out. They're not going to say that. They're going to say they're a social drinker. Therefore, they avoid the possible stigma of alcoholism. So so they know how to answer these questions when they are highly intelligent. They might be really stressed or even really depressed, but they know exactly what the question is getting at. So they answer it in such a way to get through the screening, but they're not truly talking to someone about what's going on in their head and all of the stresses of their life, and they could truly be suffering. And I just would hate to miss the opportunity to give these people the quality care that they need because these doctors don't have enough time to do a full-scale screening.
Delegate Alston, I don't, I'm not sure exactly how to answer your question, except that all of you are way highly intelligent and you're stressing me out. But I will say, I don't know how we are going to solve the problem of patients not giving the truth to their provider, if it's a primary care provider, it's a specialist or behavioral health provider. I feel like those kinds of issues are going to be prevalent with all kinds of providers, not just a primary care provider. If folks don't want to tell the truth about their issue to get to the bottom of it, I'm not sure how we legislate that.
So I have a question. This legislation would not mandate the individual to attend an annual visit, but it would rather say that if the person chose to go and do this annual visit, the carrier would pay for it. Is that correct? Am I reading that correctly?
That's correct.
Yes.
Okay. All right. Thank you. Any other questions? Seeing none, we do have some virtual witnesses. There are 3. I've got Ashley Towler, Aaron Davis, and Bob McCullough. These are all favorable. Virtual witnesses. There are 3. There we go. Ms. Towler, you want to start? Ashley Towler. Let's wait until we get everyone on, I think. So there's not that. There we go. And Aaron Davis? She's not on. Okay, so then we'll go with these 2. Ms. Towler, would you like to start?
Hello, Madam Chair and members of the committee. My name is Ashley Taller, Policy and Advocacy Associate with Maryland Coalition of Families. We are testifying today in support of House Bill 400. Submitted is also our written testimony. I have a few examples that I would like to provide. A mother had contacted our services for support. We were her first contact she had ever reached out for her son's behavior issues, such as destruction of property, aggression towards others, siblings and parents, and substance use. An annual behavioral health wellness visit may have been beneficial for this family in getting the services they needed sooner without the fear of receiving a mental health diagnosis at the original visit. Lastly, a mother who has a mental health condition, along with her son, expressed how an annual behavioral health wellness visit would have been beneficial in early detection of her mental illness, as her family was unaware of what signs to look for when it came to her mental health. A qualified mental health physician who would provide these services is trained and educated to recognize signs of mental health and substance use disorder, and would be able to provide early detection and intervention, as well as connecting individuals to resources they may need. An annual behavioral health wellness visit can help to normalize behavioral health wellness and bring more awareness to the importance of taking care of your mental health like you would your physical health annually. I urge the committee for a favorable vote, and thank you for letting me testify today. That is all.
Thank you, and thank you for your patience this afternoon. Mr. McCullough?
Thank you. Good afternoon, Madam Chair, members of the Health and Government Operations Committee. My name is Bob McCullough. I serve as Vice President of Clinical Strategy for CUTH, and I'm a licensed clinician with more than 30 years of clinical experience. I am here this afternoon to testify in support of House Bill 400, which would require the Maryland Medical Assistance Program and other health insurers to provide coverage for annual behavioral health wellness visits. With more than 20 years of experience in the digital behavioral health space, CUTH's digital platform is available to more than 20 million youth and young people throughout the states of Pennsylvania, Kentucky, and California, as well as throughout the United Kingdom. Through our many years in the youth behavioral health space, we know that early identification and intervention is a key to supporting youth with the right services at the right time. By providing annual behavioral health wellness visits, supports can be provided regardless of acuity and meet youth where they are on their journey. These supports can include digital self-guided paths, moderated peer communities, and quick access to licensed clinicians throughout chat sessions. We believe the bill before you today is a solid foundation to promote behavioral health. Thank you for your time and attention today. Happy to stand for any questions at the appropriate time.
Thank you very much. Are there questions of these witnesses? Seeing none, thank you for your time, your testimony, and your patience this afternoon. I really appreciate it. If I were channeling my chair, who will be back momentarily, I'd be saying to the insurance carriers and to the good delegate to get together and see if there's a path forward here in terms of, how do we make sure we get the services and at, all together, working collaboratively. So thank you. And that concludes the hearing for House Bill 400. And we will move to the last bill of the day, but let's not get too excited because it's likely to be a little long. And that is House Bill 340, which is Delegate Jennifer White, Holland, and Delegate Bonnie Collison. So.
And I brought my honey because I heard my name. Oh. All right. If you could bring your panel, that would be great. Oh, you know what, Delegate Collison? I will not name the people that are saying this, but they say you owe us dinner for late night. Okay, and maybe chicken and pizza would be great.
Chair,
yeah,
I was going to make that offer as my first statement.
Oh,
so we will pick a good time to have dinner and celebrate.
We have a rule here that if your bills make us go late, you have to pay for dinner one of the days. So the night, well, we do have dinner.
Just think if we don't have any questions, it'll go faster.
Good luck with that, Delegate.
Oh, well, it was a good try, wasn't it?
You can get started.
I am going to ask my colleague in this endeavor on House Bill 340 to begin. So Delegate White Holland.
Thank you, Madam Vice Chair, and a good afternoon or evening, Madam Chair and fellow colleagues of the House Health and Government Operations Committee. For the record, I am Delegate Jennifer White Holland and appreciate the opportunity to present HB 340 for your consideration. I am pleased to stand in support of HB 340 and would like to thank and acknowledge Madam Chair for championing HB 768, which established the first in the nation prescription drug affordability board back in 2019. Because of the outstanding leadership of this body and Vice Chair Collison, together we are taking action and building on the foundation to allow the board to determine fair, affordable rates for high-cost medications for all Maryland purchasers and payers. And as a proud member of the Legislative Black Caucus of Maryland, the largest in the nation, the Legislative Black Caucus of Maryland is pleased to stand in full support of HB 340, and it is one of our priority bills of the 2024 legislative agenda. HB 340 will take a critical next step and expand the authority of our Prescription Drug Affordability Board to set upper payment limits on drugs for all Marylanders. The rising cost of prescription drugs is impossible to ignore, which forces Maryland patients to make decisions between medications they need and meeting basic necessities like rent and food. Beyond the pharmacy counter, the impacts of rising drug costs strain state and local government budgets, drive up insurance premiums, and threaten our public health, impacting us all where we are all paying a high price. More importantly, expanding the authority of the Prescription Drug Affordability Board is a tool that will help us address racial health disparities, which is why the Legislative Black Caucus of Maryland stands in support of this legislation, as African Americans are at a higher risk for chronic conditions like hypertension and diabetes. Although diabetes and other chronic diseases are manageable, the high cost of maintenance medications can be disproportionately burdensome of Black Marylanders, which may lead to poor health outcomes. When we look at diseases that disproportionately affect Black communities like sickle cell disease, there are limited treatment options available on the market. The treatment options that are available are extremely expensive, where lifetime medical costs for those with this disease are estimated at 1.2 million. And while we have made progress over the last 2 decades, only 2 new drugs have come to market, which suggests that there is little free market will to contain costs. So overall, we have an opportunity here in our state to expand the authority of the board to set upper payment limits for everyone, allowing us to address the rising costs of prescription drugs in our state and continue leading the way in the nation, while other states like Colorado, Minnesota, and Washington have taken additional steps through the passage of this bill. It will pave the way for other states to learn from our process and our model. And so this is truly our opportunity to impact our health and well-being for all Marylanders. And so, colleagues, I respectfully request a favorable report. Thank you for your consideration.
Thank you for your testimony.
Thank you, Madam Chair. I would ask you to refer to the testimony of County Executive Stuart Pittman and the Executive Director of the Maryland Health Benefit Exchange on your floor systems. They were not able to be here this evening, and they are providing some important information. I am going to take up where the good delegate left off, and you've heard me say many, many times how complicated that the drug pricing network is, and how many different elements there are in that chain. But I think if I'm reading this correctly, and I'm reading the witness list correctly, it is the manufacturers who are most vociferously opposed to this bill. And so I'm going to put a spotlight on them for a little while, and just try to anticipate and set a context for what you will hear from them a little later. All companies have the right to make a profit in this country, and on healthcare, as a society, we've made policies that assure that the profit is not at the expense of consumer health. Carriers have medical loss ratios. You just heard about that a little while ago. They are required to spend 85% of every premium dollar on patient care, not administrative costs and other things. And hospitals in Maryland are highly regulated, with their prices set by the HSCRC. Healthcare providers fall under a variety of rules set by boards. Recently, we've created more regulations on pharmacy benefit managers, more needed, but we have started that. So I think it's fair to say that the healthcare industry is one of the most regulated industries in the country, except for one stakeholder. And I think we have to ask ourselves, why have prescription drug manufacturing companies been almost completely exempt from these kinds of regulations and accountability to consumers? You have my written testimony, which is probably longer than I've ever written a testimony, and with a lot of references to different studies that sort of back up what I'm going to say today. So I would refer you, if you need some nighttime reading, please go for it. One of the things that you will hear from the opposition is that regulation of any kind will inhibit innovation, and that pharmaceutical manufacturers use the money for research and development, and any reduction will threaten their ability to create these new drugs. So I'm thinking, in response, we need to find out how to use the money that they're getting, and that whether how much of it is actually going into research and development. So studies show us they're spending billions of dollars on stock buybacks, executive compensation, and advertising, don't get me started, than they do on research and development. In 2022 alone, they spent $370 million lobbying against policies like this. Increased drug spending is largely due to price hikes on existing medications rather than the introduction of innovative products. And maybe even more interesting, federal taxpayer dollars, your dollars, above and beyond your healthcare premiums, which you are also paying, already subsidize research and development. In fact, NIH is the largest public funder of biomedical research and development, contributing billions, $97 billion for basic research, $28 billion for clinical trials, $9 billion for workforce development between 2017 and 2021. Every single new prescription drug that came to the market between 2010 and 2020 had origin in publicly funded research. They're also going to say it threatens the future development of orphan drugs, which should be exempted from examination by the Prescription Drug Affordability Review process. I understand orphan drugs are those that are designed to meet a very small group, the needs of a very small group of patients. But in fact, what is happening recently is those drugs are being used now for many different things. They're no longer just for the orphan. So that makes them liable or something that we need to keep looking at. They're worried that manufacturers will leave Maryland if the UPL, the upper payment limit, is enacted. So many drug manufacturers, and I'm fortunate to live in Montgomery County where there are several, they come to Maryland for a number of reasons. It's NIH and the FDA right there in Montgomery County, two governmental entities that support their work. They also, think about this, have companies or based companies in countries that have upper payment limits, and that what their governments will pay, and they haven't chosen to relocate their corporations. They will say it's not the manufacturers, it's the other parts of the supply chain that are the problem. They're the ones that are beefing up the cost. I believe that was one of the major reasons we created the Prescription Drug Affordability Board, was to bring some transparency and some light into that pricing chain and all of the different elements. And so the manufacturers are just a major part of that chain. And you've heard the reports from Executive Director York about how they are looking at all the different elements and where the profit is going. This one we hear all the time, right? If we have upper payment limits, then the manufacturers won't sell to Maryland. Again, I'm going to remind you, they're already selling their drugs in lots of first world countries where there are upper payment limits. So that didn't happen. And we, an existing market in Maryland, you heard someone say, Maryland is a fairly rich state and it is a big market. I mean, it seems unlikely that they're going to say, oh, I don't need that market at all, as opposed to keeping the market at a slightly lower price. These right now, again, this is something, an economist probably knows more about, but the companies operate under a high cost, low utilization model, economic model, leaving lots of Marylanders and Americans without the drugs they need. The upper payment limit could help them adopt a high use, lower cost model as instead, and then they would see, the manufacturers would actually see similar profits to what they're making now. Those of you who were here in 2019 when we created the board, one of the things we added was if you won't sell in Maryland, you can't advertise in Maryland. It's very difficult for a large corporation, a national corporation, to not advertise in the Washington, D.C. Marketing. And as I said, let's not talk about those commercials. And I'm not saying anything in front of them that I haven't said to them before. So one of the questions that we've also heard many times is, how does this really help the consumer? Right? Who cares what the upper payment limit is? Well, right now, 1/3 of every premium dollar is going to prescription drugs. If less than 1/3 of every premium dollar was going to prescription drugs, then the premiums would go down. And so I think we would see, that's where we would see the difference. We could potentially also see the difference in the point of sale when you're paying a co-insurance based on the price of the drug. So my last question, why now? Why not wait? We know, we just heard from Dr. York just 2 weeks ago that they're still working on the process. And how do we do do we want to expand it when we haven't gotten all the way there yet? I'll tell you what made me decide to do this bill. The legislative process, I've learned over the last 14 years, can take a little time. And you have to build on things. And if we were able to pass this bill now with the recognition that nothing would move forward without a review by the Legislative Policy Committee, then so it couldn't happen without that committee reviewing and giving approval for it to move forward. If we had this tool ready in the toolbox, and the LPC and the Prescription Drug Affordability Board said, now's the time, we've seen it's working, we can move forward, then we would be ready to roll as soon as that decision was made. If we wait, we would wait at least another year before it could happen. So with that long testimony, I am grateful for your indulgence. To all of you, Madam Chair, thank you, and I for your consideration, and I ask you for favorable support. I am going to tell you that Dr. York is here for questions only. He is not testifying, and Jane Horvath will have some remarks, and will also be here for questions.
Delegate Chisholm, were you looking at my fingers doing like this to wrap it up? No, Chisholm, we looked at each other. I wonder if he was looking at my finger. When I do this? Okay, go ahead.
You're good.
So, okay.
Yeah.
So thank you, Madam Chair and members of the committee, for an opportunity to talk to you about HB 340. And specifically, I'm going to talk about the statewide upper payment limit, which is the sort of the guts of this bill. I'm Jane Horvath of Horvath Health Policy, and I consult with state policymakers and consumer organizations around the country on prescription drug cost containment, with a real focus on upper payment limit rate setting. So there are many benefits to having a statewide upper payment limits. These upper payment limits are fundamentally healthcare rate setting, which happens everywhere all the time. And it is like our statewide all-payer hospital rate setting system that this committee and others put together years ago now, actually. So these UPLs would consolidate our healthcare market. All pharmacies, insurers, providers, all transactions around a UPL product would occur at the UPL. The UPL is a public number, so everyone would know what they should not be paying more for. And a drug maker, as the delegate had said, is not going to walk away from our market. This process happens in Japan and China, EU, UK, Canada, and they don't walk away. And they pay, their prices there are much less than what we're talking about here. UPLs are going to improve the market function. Manufacturers are going to have better access to our market for their product, and patients are going to have better access to that product as well. Patient costs are going to be based on the UPL in the deductible period and in co-insurance. And if you're uninsured, those are the direct benefits to consumers.
UPLs are basically a reset for the market to protect consumers from some of the anti-consumer behavior that we see in the struggle between manufacturers and PBM.
You could take 30 seconds to wrap it up.
I just wanted to say that in terms of access to drugs, if there's a UPL, if a manufacturer were not to sell here, that would simply be a boycott and potentially an exercise of monopoly power if they were to choose to do that. And I'd also want to say that in terms of rare diseases and drug developments, patients are very concerned about a boycott again. And again, that is using monopoly power in a market to maintain price. And that there's no reason for a manufacturer not to continue to produce orphan drugs. The orphan business model, there's less expensive clinical trials, less financial risk, faster approval, and higher probability of getting your drug approved by the FDA than non-orphan products. And I'll leave it at that.
Thank you. Thank you so much. I'm going to open it up for questions now. Go ahead, Delegate Morgan.
Thank you, Madam Chair. You know, the last time I remember we had this bill in 2019, the hearing was like 9:30 at night. So Delegate Colson is way ahead of that schedule. But so far, yes. But I remember we left that hearing that night, and I've never been a big fan of this bill because you know, when it comes down to it, I just don't think it works. And I remember leaving the hearing that night. We went to this bar out Main Street, and it was late. And I said, "Look, I'll prove to you this bill doesn't work." I went up to the bartender and I said, "Well, how much is a beer?" And he said, $7. I said, "Well, I'll give you $4 for it." I can't sell it to you for $4. I said, "Well, why not? That's my upper pay limit. That's what I'm willing to pay." And the bartender goes, "Look, if I sell you this beer for $4, I have to sell it for everybody here in the bar for $4. And that made a lot of sense to me. So anybody here tonight, I wish you would try that. But my actual question is,
You don't have the right smile.
there's probably some truth to that.
I have gotten it for that price. No,
But you said it, you're going to look at the supply chain, and you know, where some cost savings could be made. And really I thought it was always the job of the PBM to look at that kind of stuff. And what I guess I'm really concerned about is government coercion. So maybe can you tell me what tools would be available to the Prescription Drug Affordability Board and what you're willing to do if a manufacturer said no? No, we're not dropping the price.
Who's the best person
I can
to
speak
answer
our
the question? Now that you're the
current
best person. Go ahead.
legislation, is there seems to be enforcement authority by the Office of the Attorney General, excuse me. So under the current legislation, there's enforcement authority under the Office of the Attorney General.
General would sue the manufacturer if they weren't willing to drop the price?
I don't think that's been fleshed out yet. I think that would.
But that's the tool that would most likely be used.
I think that's the tool in the legislation. I think there's other things that a board could do to try to make the money flow as planned.
Okay, thank you. Thank you for that information.
Thank you. Thank you so much. We have Delegate Shalega, followed by Bagnell.
Thank you, Madam
You're
Chair. Thank you all for being here. And, you know, I think we all have agreement that what we want to do is bring down the cost of drugs for people. And, you know, that's a universal desire here. I guess the question is this the right vehicle to do that? So I guess, Mr. York, I'll ask you, since you're sitting at the table, did the board discuss this bill at your board meeting in January? And if so, did you take a position on it?
We did not discuss the bill during the board meeting, and they have not taken a position.
So you're just here for information. You're not here in support of the bill,
No,
even
I'm
though
here
you're
to
on the sponsor panel.
Answer any questions that you have. about our
Okay,
current board.
good. Thanks for clarifying. And then I'll just say, you know, price hikes, you know, we're all worried about that. I looked at you know, you said profit and how much drug makers, you know, manufacturers make. But of course, we all look at the PBM. Do they make a drug? Do they ever touch a drug, a PBM? So they're the middleman that's making billions of dollars, and we're not looking at price setting them. We're looking at pharmaceuticals that actually manufacture the drugs.
actually they would be affected by the upper payment limit because the payment is coming from the price that we would be willing to pay would be from the manufacturer. So whatever that price is would go down to the PBM.
You don't
And
think they'd squeeze it there? You're very trusting. I have one final question. Thank you, Madam Chair, for the indulgence. So the original charge of this bill was to review and set price limits.
Not price limits, upper
Upper-
payment limits.
Upper-
Very important difference.
All right,
Okay.
upper payment. So review, set upper payment limits. Is the review done and have you set a limit for anything?
The answer is no and no. I'll take that. Not yet. And as Andy reported, I think it was last week or the week before, they are in the final stages of the process. The reason we're doing the bill now, as I said, is that if it works, if it doesn't work, well, we're back to the drawing board. But if it works, let's be ready to go to the commercial market as soon as we recognize that.
But we could potentially wait and not, because nothing has been accomplished and a couple million, few $1 million have been spent, some tax dollars, some fees, and we haven't accomplished anything. So I would say if we haven't, why wouldn't we wait and let this roll out and then say, good job, this is what we wanted. Let's expand. Why are we expanding before we've accomplished anything?
I appreciate the question. And the answer is, if we wait, then we will wait an extra year at least in order for there to be legislation beyond the point at which they see that it works. So we would actually be delaying the process by a minimum of 2 years, if not more. And if we waited to have this tool in our toolbox.
Yeah, you couldn't come back next year with emergency legislation.
I could potentially do that.
Thank you.
Okay, thank you.
Delegate, I have the list. Delegate Bagnall, followed by Hutchinson, followed by Taveras, and then Chisholm.
Thank you, Madam Chair, and thank you for this bill. I had the good fortune of putting my name on the bill in 2019. It was one of the first bills I was able to put my name on as a freshman. And we hear in this committee all the time that one of the biggest drivers of healthcare costs is prescription drugs. I did listen to the hearing yesterday because my senator is the Senate sponsor. So I was proud to listen to that. But I just want to make sure I understand what we're looking at right now. Because we had I know it can feel a little like Groundhog Day. In 2019, we had the bill, then we did the funding, then we had to do the funding again because it was withheld. And we were looking at those upper payment limits, but within the Medicaid and the state employee space. And I don't know about anyone else, but I was hearing from my constituents, well, what about us? I'm not in that. I'm in the commercial space. So we're now expanding that to look statewide. Because in the Medicaid and state employee space, since the co-pays are capped, the savings are more on the state and local governments, so we can put money back into public health. But in the commercial market, do we anticipate that the savings will be actually at the point of sale?
Only to the extent that I was explaining around the co-insurance, where I would see it is in the premium reduction. And again, if the companies are going to be competitive, that's one of the things they're going to look at. I would add one thing to your timeline though. It took the previous governor 2.5 years to appoint the stakeholder advisory committee. They couldn't start their work until that stakeholder committee had been appointed.
Just clarify one thing. You're welcome. I have Delegate Hutchinson, followed by Taveras, then Chisholm.
Thank you, Madam Chair. My question's for Mr. York. I did notice in the testimony that you didn't have anything favorable in there. There was information only. You're on the favorable panel, but for questions only. So Delegate Shalega, answered that question. But I was surprised that the board didn't have an opinion on this or hadn't been presented to the board. Like, as a delegation chair, I have to have approval from my county to bring something forward. Could you explain why?
Yes, the board has no position. I think just as an agency, we try to be responsive to bills that are relevant to our work. So I'm here to answer any technical questions that you have, but the board did not discuss and did not take a position.
But it had never been discussed with the board, never brought up to the board?
Not during an open meeting, no. So it was not discussed by the board. So, yeah. So the board, obviously, we provide legislative updates. So the boards have seen this bill, but they did not discuss it as a board or take a position.
Madam Chair, if I might clarify that I requested that Dr. York be here because he's the most knowledgeable about the work of the board. That's why I prefaced my testimony with, he is here for information only and not representing the board, not representing a position of the board.
Thank you. Delegate Taveras, followed by Chisholm, followed by Riley.
Thank you, Madam Chair. I see that the United States invests a significant amount of R&D dollars in pharmaceutical companies. And I think that my concern is, they do drive a monopoly. So what's the possibility that if R&D is covered by the US government, why are we not allowed, and this may be off, and why can we not buy the patents?
You're going above my pay grade, Delegate. I know the Senator Van Hollen has been considering legislation at the federal level. I think it's called We Already Paid. So that the prices of drugs that the government paid for innovation and creation would be, that would be factored into the price of the drugs. But as far as I know, like everything else in the federal government, it hasn't moved yet. So we'll be waiting for that.
Delegate Chisholm, followed by Riley.
Thank you, Madam Chair. And since we're talking about research and development, does it give you any pause or any deep concern that, I just kind of looked up, we have like 9,235 orphan diseases, which you kind of talked about earlier, with only 700 cures. And given that only 12% of all drugs that ever go into the pipeline ever even make it out to the market, and it takes up to 10 years to develop some of these drugs. So if we start to cut into the finances of a lot of these prescription drug manufacturers, that they then start to cut back on research. So we stop our progression forward of innovation and be able to cure, because unfortunately throughout mankind, we've had new diseases that continue to come on, and they're heartbreaking to hear about some of these very rare diseases, but the pharmaceutical company is incentivized to continue to look for breakthroughs and to look for cures through prescriptions. And my concern is, look, all businesses run off of margins, and eventually they'll say, well, we'll cut here. My concern is we start to cut back on research and development, therefore eliminating the chance to produce new drugs that have life-saving qualities to them. And the prescription drug manufacturers then just still make the same money, but stop producing innovation and new drugs. Does that give you any pause or concern, or do you have a thought on that?
As I said in my testimony, that certainly is something that we need to look at, but I would ask that, or I would suggest that there are other pots of money that these manufacturers could be tapping into. And in terms of the research and development around the orphan drugs, again, I'm going to go back to the federal government is contributing great sums of money to those, to that research and development. And then there's other pots, please take the advertisements away. I mean, that alone would probably create the solutions for the other 8,000 orphan drugs. So that's what I would say. I'm not worried about that. And the other reason I'm not worried about it is the board that we put together and in a very strategic way, are health economists and have a background in the relationship between the finances of all the different parts of the chain. And I believe that this is one of the most responsible boards of that we have here in the state, in terms of they're not going to do anything rash. They haven't done anything rash. If they were going to be rash, they would have done it. They would have done something already. They're taking their time to make sure that the process they use, the review process, which is, very comprehensive and includes that stakeholder advisory committee, is very thoughtful and strategic. So I honestly don't share the concern that we'll limit research and development.
Follow up with something.
Sure.
And I'm just going to push back a little bit on the federal government and relying on the federal government. And I think everybody in this room knows this. And I know the chair has sat in meetings where said, look, the money's not coming from the federal government anymore. Our federal debt is huge. It's almost unsustainable at this point. And at some point, the federal government's got to make some serious cuts. And the grants then dry up, just like the money into the state of Maryland dried up very quickly. And I think that if we continue to rely on the federal government to continue to pay for a lot of this research and development, it's a foolish place to be. And it does scare me about the innovation of some of these drugs. That's just my point of fact. And I appreciate, your look at it.
Thank you.
You're welcome. Delegate Riley.
Thank you, Madam Chair. So I was looking through some of the opposition letters and one caught me. It's PIPC. Never heard of them. Don't know of them. And I don't think they're coming today, but they gave written testimony. Looks like they're out of Washington, DC. The name stands for, Partnership to Improve Patient Care. I kind of like that. So it kind of, struck my eye. So they were talking about, in their oppositions, they're talking about a program or a measure that they're afraid that our drug affordability board will use. And it's something called QALY, or similar measures in considering, lower cost of healthcare and lower cost of prescriptions. State of Maryland, we have not banned using these measures, the QALYs or any similar measure. Because if we don't, and the board does, the state doesn't address it and make it illegal or ban it, then the board can use this to determine rates. And if we do that, they're saying that it's against the disability and civil rights of the federal government. So I was just a little concerned about that. And, their main focus and the people that they target and they're looking at are those, with disabilities, chronic illnesses, and older adults. So there were some concerns there. So my question is, do we know if our board uses that, or they intend to use that particular method to, figure out the lower costs of prescriptions? Is that something that, or are you not familiar with it?
Yes, I mean, we're familiar with the metric. I would say that it's not in any of our plans for the purposes of setting an upper payment limit. We're still publishing the upper payment limit action plan, but that hasn't been discussed as part of that plan. So I would say there's not going to be any direct reliance on that.
I'm sorry, Madam Chair, follow up.
It's okay, go ahead.
Would you consider, in the bill, putting the amendment in there that, they cannot use this particular measure? Because, I know that the sponsor of the bill is very concerned about those, she's had several bills already with, the disability. So we're really concerned with, and, elderly folks, I'm getting old. So, would it hurt to maybe put something in the bill to say, hey, the affordability board could not use this measure?
Since it's a follow-up question, I'll answer.
Sure.
The other states that have prescription drug affordability boards have all banned those measures. They say that they're not appropriate. So I would
you
not
would do
imagine that our board, again, because I trust that our board is using best practices and thoughtfulness as it, examines and analyzes. They wouldn't be using measures that clearly other have, that share our commitment to the process wouldn't use.
Thank you very much.
Delegate Johnson.
Thank you, Madam Chair, and
You're
thank you
welcome.
for bringing the bill. My question is, do you think with the manufacturers putting out over $150 billion annually in discounts and rebates, that almost none of that gets to the patient at the pharmacy counter? You mentioned advertising, and with that $150+ billion per year, do you feel that they have plenty of wiggle room if certain drugs had caps on them to still make money and survive just fine in the market?
I do believe that there is enough, as you say, wiggle room in there. And, you know, to be fair, when I have spoken with manufacturers about you could reduce the price of drugs simply by, eliminating the rebates. And what I'm told, and I believe this, is because of the chain and the fact that we have this middleman, in order to be competitive and be on everyone's formulary, they have to do the rebates. I'd suggest that look at other ways to lower the cost and still be competitive. I mean, I look at you all have heard about the reverse auction or competitive marketplace, and the way that works is the PBMs are actually competing against each other. In a real competitive market, you're going to get the lowest price. What I'm suggesting to you is that at the patient level, it's not a competitive market. The prescription drug affordability prices are not competitive.
You're welcome. Any other questions for this panel? Seeing none, I have just for Dr. York, I have a couple of questions for you. Just as a follow-up. Can you tell me who's on the board? What is the composition of the board? Can you refresh our memory?
We have a 5-member board appointed from, I guess, 4 different sources. Excuse me, thank you. We have a 5-member board. The chair is appointed by the President of the Senate and the Speaker of the House. That's Van Mitchell, previous health secretary and also a member of this body. We have Dr. Joe Levy, appointed by the governor's office, who is a nationally renowned health economist and expert in drug pricing out of Johns Hopkins University. The Attorney General appointed Dr. Jerry Anderson, also out of Johns Hopkins, also a nationally renowned drug pricing expert. The speaker appointed Dr. Abiria Nukuga, who is a health economist out of the University of Maryland School of Pharmacy, also a recognized expert in the space. And then the Office of the President appointed Dr. Stephen Rockhauer, physician.
Thank you. And can you please let us know since you have been working, right? Because you were delayed for a while because you were not funded. But since you have been funded, what work have you done?
A lot of our initial work for the first couple of years was the work of standing up an agency from scratch. So a lot of it was, just making sure that all the piping flowed and we had the right budget accounts and budget codes and bank accounts. Then we spent a lot of time setting up our fee assessment. We are self-funded through a special fund. And that process was very time intensive to set up, but I think it's kind of moving smoothly now. And then we also just had to set our kind of baseline regulations. Over the past year, we created our primary work, which is the cost review. So that process we developed over the past year. Those regulations for that process were finalized in December of 2023, and we hope to have our first cost reviews done, middle to end of this year. And then also we're working on our upper payment limit action plan, hoping to publish this year, that would then go before the Legislative Policy Committee for approval.
And do you do that work on your own or do you have an advisory board?
We have a 26-member stakeholder council.
And who's on that advisory council? All 26.
Yeah, so it's representing all the different members of the stakeholders in the supply chain, excuse me. I think we have 2 spots for brand name manufacturers, one for the biotech industry. We have a number of different practitioners, physicians, dentists, pharmacists. I think maybe nurses. Yes, we do have a nurse on there. We have 3 public members. We have pharmacy benefit managers represented, nonprofit insurers, for-profit insurers. I think there's other ones in
So
there.
you have the whole supply chain.
There are a few stakeholders have reached out to us and said that it may be appropriate for them to have seats on the council.
Yes.
Yeah.
Okay, wonderful. Thank you very much. You know, we passed the bill and you forget, right? I know I did, right? So don't even ask me tomorrow what these bills today were. You know, so anyway, thank you so much. Really appreciate you being here for questions and thank you for the panel. We're gonna go on next to Ms. Barbara Levin. Is she here? She is? Okay. Actually, I'm gonna call both of you. Is that okay? You're welcome and thank you for being patient. I know you have been waiting all day and we really appreciate your patience.
Well,
Everyone in here, thank you.
well, it's a pleasure. I thank you, Madam Chairman and Vice Chairman, and it's great to see my old friend Delegate Rosenberg. I'm testifying from the totally opposite end on this legislation, from the consumer, and which hopefully if you pass this bill, it will get there, okay? I live in Leisure World of Maryland, which is in Silver Spring, which from the last census had over 9,000 residents. And I'm a member of the Democratic Club of Leisure World, which has over 500 members. And so I'm speaking on their behalf for the end product that if you pass this bill, hopefully prescription drug prices will come down, okay? Which is a huge burden for people in my community. I cannot believe, first of all, everybody in our community, they must be at least 55 years old. I am sure that at least every one of them is on at least one prescription drug, okay? A lot of people have to determine when they get a prescription whether they can afford to get that prescription or they need it for food or rent, okay? So if you expand this board to look at pricing, lowering the price of prescription drugs, it helps the consumer down the line tremendously. And I'm sure all of you have constituents who are paying high prices for prescription drugs. So I'm speaking on behalf of a lot of consumers who don't even know me.
Well, I just want to say on behalf of the committee, thank you for being here and for really participating in a democratic process, okay?
Well, thank you. And please give this bill a favorable report.
Thank you. Let's see if there are questions for you. Are there any questions? Delegate Vice Chair Collison.
First of all, I want to say thank you for being here and thank you for waiting. So how long do you think it'll take you to get home, which is about a mile from my house?
Well, I've come with 2 friends and we're going out to dinner before we go.
Thank you. Well, you enjoy your dinner.
Thank
Have a blessed
you.
evening, okay?
Thank you.
You're welcome. We have Larry, who's been waiting patiently, Rosalind Berkowitz, Jessica Gorski, Lawrence Diggs, and Jody Hopkins. Will you be so kind and come up, please? Thank you. And again, thank you everyone for your patience. And as soon as you sit, will you be so kind and start your testimony? Thank you very much.
You're welcome. Good afternoon, Madam Chair, Madam Vice Chair, and members of the committee. My name is Rosalind Berkowitz. I am the Vice Chair of the Baltimore County Commission for Women, and I'm a retired nurse. Being able to afford their medications that are prescribed to them is a real struggle for many residents in Maryland. My daughter has severe ADHD,
She's been off her Adderall for over a year now. She has tried the available generics with no relief, so she stopped taking her medication. Even her psychiatrist agrees that the generics do not have the same effect. To buy the brand medication would cost $700 a month, and that's even if it's available, which is another problem. She's unable to work and has become a recluse. No parent should ever have to watch their child suffer like this. During the 16 years I worked in the ICU and the emergency room, I cared for many patients who came to the hospital with very elevated blood sugars. Many were repeat customers. And upon sitting down and speaking with them about their diabetes, I was often told that they were rationing their insulin because they couldn't afford it. I am aware that the cost of insulin has come down. However, there are many other medications that are important to diabetics. Farxiga, a medication that protects the kidneys of diabetics and can prevent future hospitalizations, is around $500 a month. Trulicity, a non-insulin medication that improves blood sugar control and reduces the risk of major adverse cardiovascular events in diabetics. Last month, this cost me $466 for a 1-month supply. How is it possible for retirees to afford to pay for their health care, for their medication, and for their food or for their heat? I want to strongly urge a favorable report for House Bill 340.
Thank you.
Thank
and
you.
You're welcome, and thank you for being here, and I'm sorry about your daughter's
Thank you.
illness.
Thank
For
you.
the people that signed up on favorable, hang in there tightly, because I'm gonna finish this panel and I'm gonna go to you so that you don't wait all night, and then I'll go back to a favorable, okay? So just wait for me. Next, please.
Madam Chair, Madam Vice Chair, members of the committee, my name is Jessica Gorski, and I'm a member of several advocacy groups, but today I speak to you as a patient and for my family. I was here 5 years ago and got to celebrate the passing of this bill, Sign and Die. And while I'm still celebrating that, I ask you now to finish the job. My husband has cardiac sarcoidosis. My eldest daughter has neurofibromatosis 1, and the cost of their medication and care completely changed the trajectory of our lives. And while I would pay it again and again to keep them alive, I'm here 5 years later asking you to help me and other Marylanders not be continually sidelined by the cost of prescription medications. You know, I completely understand and support the importance of innovation, but stock buybacks and marketing campaigns are not in innovation. You know, some of the delegates asked, where could these costs come? Could they come from PBMs? Do you know that AbbVie spent $71,913,444 million on 6 executives in 2022? And that Pfizer spent $107,228,894 million on 6 executives in 2022. Possibly that could be used for innovation. And think of all of the other reps and other people that are here today and all of the drug reps who are doing all of the marketing. And let's add up all of that money. And, you know, for all of us who are here as far as patient advocates and for our family, I paid to be here. I took my day off. This is costing me money. The prescriptions are costing me money, and I greatly appreciate everything that's been done so far, but I'm asking you to finish the job and let Maryland citizens like myself start to see that relief. And so I ask for a favorable passing of this bill.
Thank you. And again, thank you for your advocacy, and sorry about what you're going through in your family. Next, please.
Good afternoon, Madam Chair,
Afternoon.
Vice Chair, Committee. My name's Larry Zarzaki. Some of you know me, some of you don't. I've been around since 2017. I have a neurodegenerative disease. There is no cure for it. We can control it with medication, but it's the comorbidities that are killing me. This neurodegenerative disease totally destroyed not only a family that I thought was unshakable, but I lost my home. An IRA, which that add salt to the open wound. I had to pay taxes on the early withdrawal to pay for the medication. So, yeah, delegate, I would much rather sell 4 beers at $4 than 2 beers at $6. I look around the room and I see many of us are wearing glasses. I don't have my glasses on now, and I'm going to try to speed this up. I want everybody to take a look at this little bottle. This is number 13 of my medications. That's 1/4 of an ounce. There's no insurance company that covers that. I did get a 10% discount ticket, which brought my surprise to $786.37. I put that on my credit card at 19% interest. I can't afford to buy that anymore. So please take into consideration that, and the 45% of people, Marylanders out there, who are struggling for their medications. Thank you, and please consider a favorable report for untying the hands of the Prescription Affordability Board. Thank you.
Thank you. Thank you, Larry. And I call you Larry because we known each other for many years, for being here and using your voice. We really appreciate it. I know it's not easy to get here, and I appreciate you, okay?
Thank you, Madam Chair.
You're welcome. Delegate Shalega.
Thank you, Madam Chair. I just wanted to thank you all for being here, and you made a good point, the woman in the middle, I'm sorry, I couldn't recall your name, but
Jessica.
Jessica, yes, you took the day off of work, and here it is, almost 6 o'clock. Probably childcare may be part of that equation, and we do appreciate it, and we're here listening to you, and we're sorry. We're trying to, together solve these problems of how we can deliver reasonably priced prescriptions to everybody across our state. But thanks especially for coming.
Thank you.
Thank you. Thank you, Delegate. Delegate Riley.
Chair. Thank you, Madam Chair. And yes, thank you all. And I understand those little bottles my mom takes, and it's smaller than that. And it's several couple $100, and insurance don't pay very much. But anyway, so all of you have, a huge confidence, and it seems like all 3 of you had mentioned name brand prescription drugs, and said how you really like the name brand prescription drugs. Weren't the young lady sitting closest to me, wasn't real fond of the generic. So I would like to know how you have the confidence that you have that this particular bill in front of us will actually bring down the cost of name brand prescription drugs, and you won't be forced to always get the generic.
So I always get the generic. The problem is the generic for the Adderall, there are 2 of them. They don't have the same effect. And even her psychiatrist says that it is true. And she has heard that from many patients. So I don't understand how the FDA, and this is off topic, approves drugs that do not have the same effect as the brand. And that's why she stopped taking it, because there was no use in taking them. They weren't working.
Sure.
So your goal and, in coming here today and testifying on this bill is that, they really focus on the name brand prescriptions and not say, well, we can get you a cheaper product by using the generic.
Yes, only for that one. I use generics anytime that I can. Mine are generic, but the problem is some of the medications, like the Trulicities, and I think the Farxigas as well, I don't think they come in generic yet. Yeah.
So, okay. Thank you very much.
You're welcome.
If I may just take 1 second,
Larry,
please.
we usually don't, Larry, but I know how hard it is for you to get here. So go ahead.
No,
go ahead, Larry.
I just wanted to say, nobody is opposed to generic drugs. we need pharma. We truly do. But also we need to be able to have a budget. And we don't go to a grocery store without a budget. We don't buy clothes without a budget. And I think the trickle down effect will make it to us. And this board isn't the model for many other boards, including the national board, for no reason. Thank you.
You're welcome. Well, thank you for coming and we really appreciate it. Okay, I know it's been a long day. We have next, Lawrence Diggs. Lawrence Diggs is not here. Okay, how about Jody Hopkins? Is she virtually, is she there? Will you bring her up, please? Ms. Hopkins, how are you? Thank you for waiting. Will you be so kind and start your testimony? Ms. Hopkins, will you be so kind and unmute yourself? Ms. Hopkins. Is she there? She is. Ms. Hopkins, will you be so kind and unmute yourself? Ms. Hopkins. Well, we're gonna go on to another panel. If she is there, we'll call on her later. So we'll do that later. I'm going to now, instead of going to the third panel, going to go to an unfavorable panel, okay? Because you have been waiting patiently as well. May I please have Josh White? May I have Laura? And I'm sorry if I'm not gonna pronounce your name correctly. You can correct me. Tell me how you pronounce your last name. Terepnit? Great. Thank you for being kind. Cherise Richer and Kelly Schultz. May I also have Kelly Memphis? Can you bring her up, please? She's virtual, but she's unfavorable. Okay, and I think that will be all the unfavorable so that they don't wait there all night. Good afternoon. How are you? Nice to see you, Ms. Schultz, and all of you.
As well, Madam Chair.
Great. And who will be so kind and get started?
I'll go
All right. What happened to the leg there?
I broke my ankle,
Really?
truly.
I'm really sorry.
If I'll take any sympathy points.
Yeah. What did you hit?
I'd like to have a good story, but I don't. I just slipped on the ice.
I'm so sorry.
So it wasn't on state property, so don't worry.
I hope you recovered quickly.
Well, thank you, Madam Chair, Madam Vice Chair, and members of the committee. My name is Josh White from KO Public Affairs on behalf of Pharma. This hearing has presented an enormous amount of information, much of which we disagree with, and from pharmaceutical company expenditure numbers to misunderstanding of the federal role in research, to the impact of the supply chain and what patients pay at the pharmacy counter, and what people will really expect to happen from a UPL. I've heard all kinds of things, miracle work that's going to happen. Moreover, many of these issues that you've heard today are actually insurance issues and insurance problems, yet there's been very little discussion about the role of insurers and PBMs. Moreover, many in the industry itself, the pharmaceutical industry itself has been working since the PDAB has begun to figure out how to reduce out-of-pocket expenses. Because in the end, that's what really it is all about. It's about figuring out how to reduce it at the pharmacy counter. And we urge the committee to work on two bills that are actually going to be before you on this session that will provide immediate relief for Marylanders. We also ask you to listen to the patient groups that are sending in letters. We haven't seen most of them, but we understand that there's quite a few, and that really does have an impact. And you will see in Colorado, many of your colleagues there have had buyer's remorse about how it's going about. And much of that is because the patient groups have come and said, wait a minute, slow down, let's see what's happening. And we urge you to do the same. Thank you.
Thank you. Next, please. You don't have to touch it. I
That
know
is
you
why
feel
there's a
like it,
black
right?
thing. Yeah, and it says do not touch. Sorry, am I?
But you know what? It's been a long night, right? So
Just some blindness there with the rules. Apologies. Okay. Hello, my name is Sharice Richard. I'm a senior director of state policy for PhRMA. PhRMA recognizes the board's ongoing efforts to implement the Prescription Drug Affordability Board statute from 2019, but continues to have concerns regarding the establishment and application of upper payment limits, or UPLs, by the board and how this will hinder access to the medication for patients. Since the inception of the PDAB, the industry has maintained consistent dialogue with the board and staff. UPLs focus on the list price of a medication and neglects investigation into the full supply chain and those that directly impact how much a patient pays at the pharmacy counter. It is the insurer and their PBMs that dictate how much a medication will cost a patient, not the manufacturer. It is the insurer and their PBMs that decide copay amounts, drug coverages, and out-of-pocket costs for patients, not the manufacturer. I'd also like to mention that prescription costs are just 14% of the total US healthcare spend. I know that was a topic of conversation earlier. It is also important to note that no state with UPL authority has successfully established and implemented this government cap. And as we have been seeing in Colorado, there's significant patient concern regarding the process unfairly targeting rare disease patients and their access to their medications. Additionally, the Maryland PDAB recently received letters from patient groups expressing their concerns, with AI arthritis encouraging the board to consider common insurance practices such as step therapy, copay accumulator adjustment programs, and maximizer programs when attempting to address affordability issues. Further, the Maryland PDAB is still working to develop a UPL action plan for their current patient pool. And with insurance design concerns and patient groups' calls for caution, now is not the time to expand an untested and rather narrow approach to patient affordability. We urge you to vote no on the proposal for expansion. Thank you.
thank you. Next, please.
Hi, good evening. My name is Kelly Schultz, and I'm the CEO of the Maryland Tech Council. And I'm very grateful to you, Madam Chair, and to the Vice Chair for the many conversations that we've had on this particular issue. The Tech Council is Maryland's largest association of technology companies and nearly 800 member organizations. Our life science and technology members are at the forefront of innovations and discoveries that are saving lives, keeping us secure, and improving quality of life. We support the intent of this bill, which is to ensure that Maryland patients and families have access to affordable medication. Maryland is one of the leading states in the nation for the concentration of life science companies, with 54,000 life science jobs, 2,700 life science and biotech companies, world-class universities, and government agencies. Core to our mission is promoting policies that will continue to position Maryland as one of the top destinations in the country for innovation. We are concerned that the proposed expansion of the PDAB's authority runs counter to that goal and sends the wrong message to the life science industry. I currently serve as a representative, to your point, Madam Chair, on the PDAB Stakeholder Council. Throughout the last year, we have been engaged in conversations with PDAB members and staff about the implementations of the program established by the General Assembly in 2019. Although the work has been hampered at times by funding issues and COVID-related disruptions, the PDAB is poised in 2024 to select drugs for cost reviews that may present affordability challenges. It is premature to expand PDAB's authority to the full commercial market just as the initial set of drugs are being selected for cost reviews. We should take some time to learn from the process and evaluate whether the PDAB's actions are having the intended effect of lowering out-of-pocket costs for patients. We urge lawmakers to take cautious approach to PDABs in general and to think about unintended consequences and other strategies to lower costs for those patients. And in the amount of time, I will leave it at that and urge an unfavorable vote on House Bill 340. Thank you.
Great timing. You must be an experienced legislator.
I have a very nice clock in front of me.
Go ahead.
All right. Good evening, Madam Chairwoman, and members of the committee and Vice Chairwoman, and thank you for asking how to say my name. I appreciate that. It's a complicated one. I'm Laura Srebnick. I'm with the Biotechnology Innovation Organization, otherwise known as BIO, and we represent the biotech manufacturers. A lot of our companies are on the more smaller emerging side, as well as some of the more well-established companies that you may have heard of. We also, as Kelly has said, we have an affiliate, MTC, right here in Maryland. And I know she already talked about the thriving biotech industry right here in Maryland. But I did want to note that since 2018, the state's bioscience employment has increased by 14%. And these are great jobs, well-paying jobs in the biotech sector. This well outpaces the national average. So that's awesome here in Maryland. But I am here to testify in opposition to House Bill 340, respectfully. And this is because this bill would expand the Prescription Drug Affordability Board's authority out to all payers, like Kelly has said a bit preemptively. Additionally, this legislation, even in the current form of state and local as well as Medicaid, will not just pass down savings down to the patient. And I think to understand this, and I know I've had conversations with many of you about the supply chain, and it's been talked about previously, so I'll try to be brief, but there's nothing in this bill that forces rebates, that billions of dollars of rebates that manufacturers give to the PBMs to get on formularies. On the PBMs negotiate on behalf of the insurers. There's nothing forcing that to go down to the patient. There's also nothing forcing the co-insurance to be lowered, or anything that would reduce the out-of-pocket costs for the patient. And so for those reasons, Bio respectfully opposes this legislation. Thank you for your time.
Thank you for being here. I'm going to open it up now for questions from the committee. Delegate Chisholm, followed by Delegate Lewis.
Thank you, Madam Chair. And Mr. White, you'd said something that kind of caught my interest. So I want to ask you, if we were to take a sample size of, let's say, 50 to 100 drugs that have been around for 10 years, how much is the price point of that drug change from the manufacturer's standpoint? Meaning, has the price of the drugs increased exponentially, or given inflation? If you have one drug, or if somebody else wants to answer, whatever drugs we're looking at, sample size, has it gone up, 10%, 15%, 30%, because obviously the healthcare costs, we're seeing these huge increases to out-of-pocket one and to what people are paying for prescription drugs. How much of that is correlated with the actual manufacturer's cost of the drug?
Madam Chair, I'm going to have Sharice answer that question.
That's okay. Thank you.
Excellent question. Actually, for brand prescription drug prices have actually either stayed flat or below inflation for the past 5 years. And then also in 2022, net prices for brand medications were on average 50% lower than the list price due to the rebates and other price concessions that are negotiated.
You're welcome. Delegate Lewis, followed by Delegate Kaiser, followed by Delegate Kipke.
Thank you, Madam Chair, and thank you to the panel. You have been super patient. I'm going to ask a question that might not feel as friendly as the expression on my face.
It happens.
It does. And it's not because I'm, tired and grumpy, but because I really want to understand there are multiple entities on the playing field when it comes to the delivery of pharmaceutical medications in our healthcare system. And in the 4 or 5 years I've been on this committee, I've heard all of those entities come before us and blame the other entity, which is a lot of fun. I mean, I look forward every year to that. It makes it difficult for us because we're sent here by our constituents to understand as much as we can and then make the best decision on their behalf. And I also get to sit here with my colleagues every year and absorb stories, some of them painful, about our constituents, fellow Marylanders, who are harmed by high prescription drug prices. And sometimes, we cry in this room, and we feel the pain of our constituents like it's our own. That said, I think I'll direct the question to Ms. Richard. And by the way, that is a beautiful French name. And So I'm expecting a really classy response.
I'll elevate my pinky while I answer.
You notice that I'm allowing this whole conversation. Because it's letting everybody is
It's
sort
just
of,
like
might as well just do
giddy,
it.
giddy. Thank you, Madam Chair, for your
You're welcome.
indulgence. But I know that pharmaceutical manufacturers deliver amazing innovations in life-saving drugs. But I also hear the pain of my constituents like Mr. Zarzecki. And I learn about other implications of pharmaceutical companies, great profits like the disconnection CEO compensation. And I know that pharmaceutical companies use their profits to do things that I also personally feel can be harmful. For example, after the January 6, 2021 event at the Capitol of the US, a lot of corporate donors, corporate PACs across the country promised not to donate their billions and billions in profits to elected individuals who denied the legitimacy of the 2020 election, and pharma was one of those. And I'm just curious how you can explain to Mr. Zarzecki and others like him, how you can explain to us how we should respond to an industry declaring financial constraints at the same time that CEOs and corporate leaders make billions, and a promise was broken to hold faith with our democracy and constitution. How can you help us understand that?
So I'll do my best to answer the question more succinctly. So doing what you're doing now, having open dialogue with industry is an excellent step. The healthcare system, and most especially the pharmaceutical supply chain, is a very complex system. And with that, there are a lot of players. Biopharmaceutical manufacturers produce life-saving treatments and medications. They also offer cost assistance to patients that are perhaps underinsured or not insured. Many of the issues that you've been discussing or hearing today are insurance benefit design issues. These insurers and their PBMs are deciding what drugs are going to be offered to their patients and at what cost. Now, bringing them to the table as well as far as transparency and what it is they're going to do to make a change is also something we would suggest that you continue to do. As Josh mentioned, there are two bills that are going to be before this committee that address those concerns, those direct out-of-pocket costs for patients tomorrow. If you pass it today, it'll help them tomorrow. With that being said, continuing the dialogue to understand the pharmaceutical supply chain and how impactful manufacturers are to the out-of-pocket costs for patients is also very, very important. We cannot dictate how much they will end up paying at the end of the day. But there are mechanisms in place like the rebates and the price discounts, the coupon cards, the cost assistance that manufacturers are making a concerted effort to get their treatments to those that need it.
Yes. Okay, you will. I have Delegate Kaiser, followed by Delegate Kipke.
Thank you, Madam Chair. Good afternoon to everyone. Ms. Schultz, my question isn't for you, but hello, good to see you. Mr. White, I have a question. At some point during your testimony, you had said, I didn't get your words exactly. I wrote down a note here, something about the misunderstanding of the dollars or the misunderstanding of the reports we've received about that the money in a lot of cases isn't necessarily plowed back into R&D, but is put a lot into marketing, executive bonuses and the like. So I'd like to, outside of you simply saying the numbers aren't real, where are your numbers to demonstrate that it's not?
Madam Chair, I can ask a little bit of that, but I know Sharice is particularly expert in it. But I will say that there's a lot of information out there about how things are calculated and what money is actually being spent. We hear a lot about that. Number one, you hear a lot about that premiums are 40%. 40% of premiums are due to the price of drugs. Well, there are plenty of other studies that say it's much less than that, maybe 22% or 14% or whatever the case is. That's part of our dialogue. We hear a lot of things like those kinds of numbers, and we just know they're not true. And number two, when it comes to a lot of these studies on, or supposed studies that are coming out from like public interest and others who are saying that too much money is being spent on salaries and advertising and all those kinds of things. And we think there's a lot of information that that is, could be counter to that, but it's really focusing on what is actually being spent. And it's a fact that the pharmaceutical industry spends an enormous amount of money on developing drugs. I think that's been, that's widely known. It could be billions and billions of dollars over 12 years, and only 12% of those medicines are ever actually approved by the FDA for sale. So we hear, that's why I meant by my comments at the beginning, is that there is enormous amount of information that's flying around that we think it would be better in a dialogue rather than almost like a campaign of saying that everything the companies are doing is terrible, when in fact, there's a lot of information that can counter that.
Absolutely.
So my question was, can we get the information? And all I got back was a 2 or 3 minute answer with none of the information and no promise of getting us the information. That's what I was asking for. So I was just saying, other people have sent us the information. Could you share with us anything outside of simply saying it's not true? And all you came back with is saying it's not true. So could you share that with us?
And I understand this, it's hard to have like a long debates in our short testimony. So we look forward to actually sending you as much information as you like to demonstrate that, a lot of that stuff we don't believe is accurate.
Okay. Delegate Kipke.
Thank you, Madam Chairman.
You're welcome.
There was a panel before you with, it was 3 people with very sympathetic stories as it relates to the costs and affordability of their prescriptions. And I'm of the belief that this bill doesn't help them really at all. So if you could expand upon why this bill might not help them, that would be appreciated. And I've been told that California is further out in testing the waters on this. And I heard you, I think it was Josh, talk about how some advocacy for certain illnesses, certain groups have raised concerns about it. And you said the legislators there have some regret. If you could expand on that, I'd appreciate it. Whoever's in the best position or has the most knowledge related to the subject. Thank you.
Yes, thank you. I was just gonna say, it was Colorado. There's an op-ed that a legislator there put out with their concerns about how it's impacting their rural community and the outspoken concerns from the patient groups there, specifically cystic fibrosis and their access to Trikafta. And as far as the stories I heard previously, as far as being given a generic versus a brand medication, that again is a decision that the PBM and the insurer are doing. I mean, that happens to me when I go to the pharmacy. They try to give me the generic over the brand because it is more cost effective for them. There's similar active ingredients with different inactive ingredients. And again, that's a decision that's made on the insurance and pharmacy benefit level, not on whether or not the manufacturer was allowing that patient to have their medication or not. And similar to the other problems and obstacles that I heard with the other gentleman, although I can quite empathize, I chose this industry from a personal place. I was the advocate for my grandmother with Alzheimer's dementia since I was 13, going to the pharmacy and asking why the insurance wasn't covering it, and working tutoring and babysitting jobs to help with the cost. So I intimately understand the challenges that the patients are advocating for, but this tactic isn't the way. And also, currently, it's still being developed, and we just encourage that you give the board and their staff the time to really truly see what we're talking about and then expand upon that at perhaps another date.
Okay. Vice Chair Collison and then Delegate Bagno.
Thank you, Madam Chair. Can you tell me a little more about the patient groups that you're hearing from in Colorado? I mean, are they limited? Are they expansive? Are they a coalition of 350 different entities and organizations? Or is it, I mean, I know trifecta was an issue. And just to be clear, Colorado did not move forward with it because of the concern that they heard. So give me a sense of really how big this outcry was.
So these were public op-eds and testimonies published on the Colorado, PDAB website, as well as articles that were written. This is from foundations like Arthritis, AI Arthritis, which is a international community. They also, I believe, submitted comments for the PDAB on January 29th. As you know, so it is a breadth of rare diseases and other communities that are asking for caution, and that they do feel unfairly targeted because their medications are focused on the list price rather than if they're affording their copays or their coinsurance costs.
So I can find these by going to different websites, and
I can also forward them to you if you would
terrific.
like.
Thank you very much. Thank you.
Thank you. And thank you for your patience as we answer these questions. We really appreciate it, okay? Delegate Bagno, followed by Delegate Shalega.
Thank you, Madam Chair, and thank you again for being here tonight. I'm going to push back a little bit on something you said, Mr. White, but it's also couched in a compliment, which is that you talked about that we were under the impression that things were magically going to happen, that miraculously prices were going to come down. And I'm going to push back because much like research and development of really good pharmaceuticals, really good effective policy is not magic. It's the result of research and hard work and trial and error and looking at what has come before. And when I was doing a little bit of research, I saw that about 90% of the drugs that go to clinical trial do not actually make it to the market. Now, we were talking yesterday about the bills that you are supporting, and I asked the question, do you see these bills in conflict with the PDAB bill? And the answer was no. So my question is, why not both? Why is it either or? Why wouldn't we try everything at our disposal to bring the costs down for our constituents, especially given your role as stakeholders on the work group that is tasked with doing this work?
Well, I think there's a couple things. One, we do believe that the bills before you are we've been waiting 5 years for the PDAB to actually do its work, and there's lots of reasons why it's taken a long time. Many of them are very legitimate, but at the same time, we feel that a lot of things have been ignored about what we can be doing immediately, and quite frankly, a lot of those things are insurance-related issues, and we believe that we've waited too long on some of these things. Maybe there's been almost like a moratorium on wait for the PDAB to kind of do its work. So we're pretty excited by those things because it does demonstrate that things can be done immediately to help. As far as the expansion goes, we do think that caution is a very important point when it comes to policy and everything else. When we set out the bill in 2019, it was agreed that we would keep it to the state and to Medicaid. And there was a lot of discussion about, well, let's see how it goes. It's kind of like research too. Let's see how it goes and make sure we're not going to make any problems. But also too, it does send a signal that to the pharmaceutical industry that, we're not waiting to see whether or not this works. We're just going to go after you again. And we're going to try to figure that out. And we think that does send a signal around the country that isn't very healthy for the industry in Maryland. But also too, it's that, it's not just us, it's a lot of groups that are coming out and saying, wait, let's have caution. Let's figure it out. I mean, there's not many parts of the supply chain who are even saying like, let's go do this. There is a wait and see aspect to this. And we're just as curious as anybody else about how this is going to work and whether or not it will actually deliver on the promises that it's going to happen. I did use the word magic because in some ways, a lot of people have way high expectations about what this is all going to do. And there's a lot of people who are saying, well, it will bring down premiums. It will do this. It will do that. And we just don't know.
Yes.
Just a follow-up to that, because you are correct that we started this process in 2019, and it was a very different landscape. Since we passed the Prescription Drug Affordability Board, to your point, we have had delays, but we have also had 2 other states that have implemented PDABs and 10 other states that are working on it. So wouldn't you agree that we do actually have more information than we had when we initially were only looking at the Medicaid and the state employees market?
I'm gonna have Kelly answer that.
I know that that question was for him, but
The best person.
yeah,
One person.
so I just want to create a little bit of context to that answer because I have traveled across the country in my current position, listening to other states and what they are doing. There is, quite frankly, a lot of congratulatory responses to Maryland because Maryland, the board, has been deliberate in taking their time. And in those other states like Colorado that have just recently passed their bills and have recently started to implement some of their UPLs, they are seeing that regret. So when I travel around and I sit on panels in other states with other states at the table, they look to Maryland as being a leader in the topic because we have taken this long and deliberation. And I give credit to the board for taking that amount of time to continue to ask the questions. And as a stakeholder member and not a board member, I have the ability to watch that, but also to ask the questions. And I also see the board continuing to ask additional questions, which are not related to UPLs. So when they're talking about price affordability, the board, in my opinion, from what I have seen in monitoring, have looked at the issue and said, maybe UPLs are not exactly the whole solution to the patient's problem with affordability. And I think that they're starting to explore that more. And I think that that's a healthy exploration because we all agree that we want the cost of those drugs to the end user, to that patient, to be as low as it possibly can. I hope that answered your question.
I have Shalega next, followed by White Holland, followed by Delegate Kerr, followed by Johnson. And then we have Ms. Memphis. We called you many times, but we'll try to let you testify, okay, when we're finished. And I know I have a question, but I have to step out to see someone, but I'll be right back. Delegate Shalega, you can go ahead.
Thank you, Madam Chair.
Thank you
all.
for being patient.
Thank you. So as I'm reading through the testimony, I see TEDCO's testimony talks about the companies in the life science industry believe that if they're negatively impacted by the PDAB imposed price controls, it may jeopardize their ability to continue investing resources into research. So I'm hoping you can elaborate on that. I'm thinking what that means is if a UPL came out and then investors would say, we're going to slow down on our research, we're going to slow down on our ability to attract money, which, could obviously jeopardize a company or a drug or outcomes that could be great. So whatever, I had never thought of that, whatever you can do to expand.
Delegate Schlega, are you asking me that question or just to anybody on the panel? Okay. So good partners at TEDCO, right? And so they really understand that investment part of what happens with the initial investments for the research, right? And so to some of the points about the sellback of the stocks and, you know, the buybacks and however that works, a lot of those are initial investors that have invested specifically into that research and development, which they're getting that back and reinvesting it in the production of additional research medications for different treatments of different illnesses, right? So the world of investment is critically important to research. Contrary to popular belief, not all of the research dollars comes from the government. A lot of that money, somebody may have a percentage on that, but it comes from the private sector and it comes from the reinvestment of those people that were maybe involved. We said, you know, maybe 12% of the prescription drugs that go through research actually come out to do commercialization. Just because that drug is not out for commercialization, it hasn't gone through the FDA, it hasn't passed, whatever that is, there was still a cost to go through years of types of research that did not actually lead to development. So those investors, we have to give them some type of incentive to want to keep investing in the research, because eventually that research is going to lead to possibly a rare disease cure, one of those orphan drugs that we hear about, right? And that's going to come from the continuous investment in a world that relies on that for all of the patients and for what you've heard from them today in order to be able to cure some of those.
Okay. Delegate White Holland.
Thank you, Madam Chair. I want to go back to something, and I heard this theme around insurance, right? And so I think it's important to know here that the insurance rates are set by the Maryland Insurance Administration with actuarial justification based on the medical loss ratio. And so how is it that that is what is driving the large increases here? Can you expound upon that?
Which large increases are you referring to?
Well,
because I had mentioned previously, sorry, I don't want to interrupt you.
No, please. I just think that when we're talking about, you know, the drivers of costs here, you're looking at the entire system. And so I believe you had mentioned that it's around looking at insurance. And so I just wanted to kind of get a better understanding, if you can unpack that a little bit more, if MIA is using these actuarial justifications, how is that driving the cost?
Sure. So previously when I talked about the price of brand medications, that's at inflation or below inflation for the past 5 years. So the list price of our medications are not increasing at a rapid pace. And that was sort of what I was referring to earlier. And then as far as the healthcare spend, the overall healthcare spend on prescription drugs, and this number that I mentioned earlier does include generic plus brand, although I am here representing the brand manufacturers, is 14% of the overall fund. As far as what it is in Maryland specifically, I would have to get back to you on that portion. But that being said, it is the insurers and the plan sponsors that decide what is going to be available on their particular formularies. So if the state does not utilize a PBM, then it would be, I'm assuming, then the mechanism you're referring to. So it is my understanding from the Senate hearing yesterday that the co-pays are rather affordable for the state employees, but many of the testimonies today and what we're referring to specifically today is that expansion to the entire commercial market within the state. And that's where we're saying that insurers and pharmacy benefit managers have a direct impact on how much that cost that cost is going to be for patients. They set those premiums. They also set most specifically the formularies, the drug coverages, the tiering, as well as the copay amounts, deductibles, in coordination with their PBMs and then any plan sponsors.
Delegate Kerr.
Thank you, Madam Chair. Ms. Richard, do you have anything to add to Mr. White's response to Delegate Kaiser's question regarding money spent on marketing and executive bonuses?
Yes, actually, I would just like to note that, we are going to provide additional data and reports to the committee in hopes of showing a more balanced report. So I think it's the public citizens report that was mentioned earlier, going over the CEO and advertising numbers is also only focused on one portion of the supply chain. When it comes to a Washington Journal data report from 2021, they go over that the top biopharmaceutical CEOs are on average with other Fortune 500 companies. That being said, it takes 10 to 15 years and $2.6 billion to bring one medication to market with, as my colleagues mentioned, with a less than 12% approval rating. So that investment is done over and over and over again. When you combine and consider the high risk and the capital investment to develop these medicines, biopharmaceutical profits are on average with other industries.
Thank you, Delegate. Delegate Johnson.
Thank you, Madam Chair, and thank you for answering our questions at this late hour. But my question is, as I look at our federal investment in research and development, and then I look at the cost of drugs in this country versus some of the other places around the world, I'd like to know if our investment is letting the drugs come out of your manufacturing doors at the same cost for the US market as it does in some of the other countries that are selling drugs much cheaper. Sometimes, and we're going to talk brand drugs, more than 2 to 4 times cheaper. For instance, Australia, Canada, France, to name a few. Can you help us understand that?
So I'm happy to provide specific data and reports to you, but in a general attempt to answer your question, for European countries like the ones you're mentioning and Canada, et cetera, those are single payer systems, which are different than the complex healthcare system here in the US. And so that is something that needs to be taken into consideration. A PDAB and UPL is not, it does not equate a single payer system. Also, it's important to note that in comparison to 85%, so the US patients have access to 85% of new medications that come to market versus European countries have around 40%. And that also comes with long delays and step therapies and other decisions made by their single payer systems. So as far as access to medications, the US has the most access and opportunity in comparison to those other state or other countries.
Well, I thank you for that answer, but it really didn't get to my question of you sell the same medications worldwide. And does the medication leave your doors for the US market at the same price that it goes to other countries?
So I
But
can't
what
give you
happens after it leaves your door is irrelevant. It's what the manufacturers price when it leaves the door for the US market versus some of the other countries.
Right. So again, the comparison is not apples to apples. So in the US system, manufacturers are selling to wholesalers, which then are then it goes into the rest of the supply chain. When manufacturers are negotiating and working with those other countries, because they're single payer systems, they're working with one particular body. So the mechanism is very different, and I'm happy to provide a more comprehensive explanation for that. So I don't have a simple answer for you today.
Committee, please.
Yes, sir.
Seeing no other questions, but since I'm sitting in the seat, I'm going to take another bite at the apple here. So I want to follow up on Delegate Johnson's question. So theoretically, competition manages prices. What you just said is when you go to a country that doesn't have competition, you have lower prices. So help me understand, why isn't it lower here in the United States when there's a competitive market?
there is still a competitive market with those others. He was asking about like a particular medication that is leaving versus another. But as far as global reach, our industry does distribute and the drugs are accessible to some degree globally. But that being said, as far as competition, the pharmaceutical industry is extremely competitive in comparison to PBMs, where the top 3 PBMs control 80% of the claims in the US. So
I still think, again, I'm going to go back to the price is set when it comes out of the door, and it's not going up. There may be, so it's not going up from your end, it's going up from at the pharmacy end and the PBM end, but the degree to which it goes up begins at the starting point. And, because, and the other thing I would say is, in the context of pharmaceutical companies being in the same level as all other kinds of Fortune 500 companies, not all Fortune 500 companies have in their hands the quality of life and living, and pharmaceutical companies do, which I think puts a bigger burden on pharmaceutical companies to make sure that these are accessible. So that's my editorialism, and I apologize for that. So you guys need to stay there because the chair has questions for you, but I want to call on Kelly Memphis, please, who's been waiting so extremely patiently. Thank you so much.
Yes, no.
On the screen though.
Can everyone hear me and see me?
Yes,
Okay,
we can.
a little delay joining earlier, but thank you, Madam Chair, Madam Vice Chair, and members of the committee. I appreciate the chance to speak at this late hour in the evening. I will try to be quick. My name is Kelly Memphis. I am with the Healthcare Distribution Alliance. We are the trade association that represents the nation's wholesale pharmaceutical distributors. Wholesale distributors are a unique entity in the supply chain. We don't, research, develop, or market drugs. We do not set list prices or determine what patients pay at the counter. Rather, distributors are the logistical backbone of the physical supply chain, and our members ensure that 10 million pharmaceutical products reach 360,000 sites of care every day. In Maryland, we serve 4,600 sites of care, pharmacies and hospitals. I'll be short because I know it's been a long day. We are concerned with state level UPLs is that they do not adequately reflect the fact that pharmaceuticals are bought and sold on a national level. So we do have concerns that a UPL, if it is inadequately applied, could create disruption to the supply chain. So our perspective on this bill, we appreciate the intent and all the great comments that were shared today, but our perspective is that it would be best for the stability of the supply chain in Maryland if the current work of the board was finished, if it was fully implemented and then evaluated before any steps were taken to expand the work of the board. So that's just our perspective. We do oppose the bill at this time for that point. I would just add one other thing based on a question earlier about the stakeholder council. We do think we're a valuable part of the physical supply chain, and I would mention that we are not on the stakeholder council. However, we do engage a lot in the public comment process that the board sets up, and I've really appreciated, Andy and the staff and the board being receptive to us sharing our insights or concerns when it comes to keeping shelves in Maryland stocked. Okay, with 15 seconds, I will stop. Thank you again so much for this chance to share our view.
Thank you very much, Ms. Memphis. I appreciate your compassion and your patience. Are there any questions of this new player in the drug pricing train? Seeing none, thank you very much for your patience and your time. So I am going to ask you all, if you don't mind, to just sit back in that first row. And when the chair comes back, you'll be able to come up when she's able to ask her questions. And so I'm
sorry,
going to
Madam Co-Chair, would you like for me to hop off or should I?
That's fine.
Okay, thank you so much.
Thanks. I'm going to call Vinnie DeMarco, Stephen Buckingham, Ken Phelps, Lee Hudson, James Gutman, Nashona Cass. It's a big group, so just sit tightly together. Bridge DeMay, Crystal Parker, Paul Schwartz, Rachel Rachel Cohen, and Virginia Crespo. Almost everybody else who's here today. So Vinny, we're going to start with you.
Thank you, Vinny DeMarco, President Maryland Healthcare for All Coalition. Thank you, Madam Vice Chair and Delegate White Holland for putting in this bill. We love it. And I just want to make one point that the pharma between 2019 and 2022 spent $266 million funding the kind of patient advocacy groups that they've been talking about, putting in all these comments everywhere. I think you should consider that. And I just want to say we have over 450 faith, community, labor, business, and healthcare groups who support this. And I want to say that all of them and our whole coalition loves the Health and Government Operations Committee. You all are great. That's all I have to say.
Okay, thank you. We'll go to your left, I guess.
Okay. Good evening, Vice Chair Collison, members of the committee. I'm Jim Gutman. I'm lead healthcare advocacy volunteer for AARP Maryland. I'm also a member of the Stakeholder Council of the PDAB, representing the public. But today I'm here representing AARP Maryland and it's over 850,000 members. We are in strong support of the bill. We thank Delegate Collison for introducing it. This is the right time to do it. And in the interest of time, I'll say me too for the rest of it. Thank you.
Thank you, Mr. Gutman. Paul?
I'm Paul Schwartz with National Active and Retired Federal Employees. And we strongly support HB 340 because we would support any bill that gives a government entity the authority to oversee the fair market value pricing and reasonable profit margins to go towards the goal of getting pricing down for consumers. I do want to point out that you have to, if you want data, Delegate Kaiser, if you want data, you got to read this. It's the Profits Over Patients issued in January of 2024 by Protect Our Care. And then one of the things that came to my mind was that, and I quote, in 2022, manufacturers of the 10 drugs with the highest expenditures by Maryland payers, including Medicare, Medicaid, and certain commercial insurance plans, pharmaceutical companies spent $9 billion more on stock buybacks, dividends, and executive compensation than research and development. So that's the sticking point of why we don't move forward. It's not about impeding research and development. It's about getting a body that could oversee all the different elements of costs and make sure that you end up with a fair market value. Thank you.
Thank you.
Good evening, Madam Vice Chair, Madam Chair, wherever you are, and members of the committee. My name is Bridge Dumais. I'm the political coordinator with 1199 SEIU, United Healthcare Workers East, the largest healthcare workers union in the nation. You heard powerful testimony earlier this evening from a retired RN about patients rationing their insulin. So to that, I'll say me too. I'm also the co-chair of End Medical Debt Maryland, which is a statewide coalition of over 60 organizations. You heard very powerful testimony from a patient who is paying absurd amounts of money for life-saving prescription medication. To that, we say me too, and both organizations urge a favorable report on this bill. Thank you.
Thank you. Is Mr. Phelps still here? No. Mr. Hudson?
That's me. You heard from me.
Hudson.
Oh, Hudson. Okay, sorry.
Nashona Kess had to leave. Okay. Crystal Parker. Okay. Rochelle Cohen. Okay. Virginia Crespo. Okay. Questions for this panel? Any questions? Seeing none, I think you were very effective. Thank you.
Thank you.
I do have two favorable with amendment. A panel of two. Nora Hoban, are you still here? And Allison Taylor, I know you're here.
Hope this is saving the best for last.
Indeed.
Good evening, Madam Chair and Vice Chair and committee members. I am Nora Hoban, the CEO of the Mid-Atlantic Association of Community Health Centers.
I ask the committee to support House Bill 340 with amendments to keep the 340B, I know there's 340s too much, the 340B drug pricing program intact. The association supports Maryland's 16 federally qualified health centers as they deliver comprehensive primary health care to more than 340,000 Marylanders residing in all counties and jurisdictions of Maryland. 87% of patients live at or below 200% of the federal poverty level, and more than, I lost my place. Oh, and more than 2/3 are from historically marginalized racial and ethnic groups. Health centers are not free clinics, but we do accept all patients regardless of their ability to pay. As nonprofit organizations, centers must balance different revenue streams while remaining financially stable, and resources drive what services we can offer. The 340B program is an essential part of this balance. MAC supports the goals of House Bill 340, recognizing that prescription drug affordability is an issue impacting people statewide. However, it is imperative that the bill language has no unintended consequences and will protect Marylanders' existing access to discounted medications and expanded wraparound services through the 340B program. Such services address barriers to care regardless of race, ethnicity, education, or income. The suggested amendment would ensure community health center patients aren't compromised and can continue to receive needed wraparound services and access to discounted medications. The amendment would signal that health equity matters and should be considered in all legislation. Thank you for taking the time to listen.
Thank you. Thank you for waiting today. Allison?
Good afternoon, Madam Vice Chair and members of the committee. For the record, my name is Allison Taylor here on behalf of Kaiser Permanente. Kaiser is looking for some clarification about how enforcement would work under this law. So Delegate Morgan, appreciate the discussion you had earlier. Our proposed amendment would clarify that in any transaction of prescription drugs, whether it, any transaction would involve both a seller and a purchaser, and that in those instances, it's the seller that's responsible for adhering to the upper payment limit, since it's a seller who sets the price. So this, would go downstream, would apply between a manufacturer and a health plan, for example, but then if a health plan like Kaiser or someone else was selling drugs to a pharmacy or patient or physician or whoever, it would also apply in that scenario to the health plan. So thanks for your consideration.
Thank you. And you went already?
I did.
Are there any questions for this panel? Okay, seeing none, thank you so much. All right, who's next?
Everybody's
She
been done.
went?
Everybody's done. Just Jody.
Jody Hopkins, please. Where are we?
That's it.
And then all the favorables were done?
Yeah.
Wow, okay.
There's one.
There's
virtual-
one virtual witness left, I've been told, on this bill.
Okay, he's on.
Yes. Miss Jody Hopkins, will you be so kind and unmute yourself? We are waiting for your testimony. Miss Jody Hopkins? And you said she's there, right? Miss Hopkins, please unmute yourself so that we can hear your thoughts on this bill. Miss Jody Hopkins. All right, let her wait. May I ask the panel to come back, please? And thank you for being flexible. Kelly had to leave, that's okay. And thank you for coming back, I appreciate it. Because I know you are doing me a favor. I had to go meet with one of the secretaries, so thank you. So I know, I think that we on this committee have been trying to find a solution, right? To the cost of drugs. And I know that just today there was a hearing in Congress, where the top, I believe, 3 or 4 CEOs of the top companies were testifying in front of a committee, a bipartisan committee. And it was interesting because the members all felt the same with a lot of their questions. And what came out was that in 2022, prices for brand name drugs in the US were at least 3 times higher than in 33 other wealthy countries, 3 times higher. And I want to just tell you why it is that we are trying to find a solution, right? Because it's not 1 time, twice, it's 3 times higher. So why is the US subsidizing a lot of these countries, right? And why is it so expensive here? And an example what is of a drug that is Bristol Myers Squibb makes a drug. It's called, it's for, it says, for instance, Bristol Myers Squibb charges patients $7,100 per year for blood clot drug. Is it Eliquis? It's called Eliquis, Eliquis in the US, while the same product of Eliquis can be purchased for $900 in Canada and $650 in France. Okay. They also came out during the hearing today in Congress, bipartisan hearing, that in 2022, Johnson & Johnson prioritized shareholders' return over drug development. The company spent a combined $17 billion on stock buybacks and dividends compared to $14 billion on research and development. And I can give you more examples of the prices and things that came up. That being said, this is the reason why we're here. It's not that we don't want you to make a profit, the companies, but something reasonable and where the patient can see some of those savings, right? Especially when it's so much cheaper in other countries, in many, many, many other countries. That being said, I hope that you could sit down with the sponsor and that we can find some type of compromise and solution, okay? And I know that we have done it in the past. And I want to do it again because you're here and you're sitting here with us at 6:54 in the evening. And you have to also care. And I believe in that. I really do. Okay?
Okay.
So if you can reach out and sit down, I will be extremely grateful. All right? And thank you for your generosity of allowing me to bring you back. Okay? And I hope you have a blessed evening.
Thank you. My husband
so
has
much.
promised fillets and wine at home, so.
Excuse me?
I just said my husband has promised fillets and red wine as my, in recognition of my efforts, so thank you.
Well, I think you got it. You tell him that he should deliver, and if not, 23 people will come after him. Okay.
He's an excellent cook, thank you.
You tell him that. Thank you so much. I'm
Thank
going to
you.
call the last witness. Let me
Thank
give
you.
her another chance because she's been waiting all night, okay? So please be patient. And what is her name? Ms. Hopkins? Jody Hopkins. Is she there? She's muted. Are you able? You can unmute her. You did. Ms. Hopkins, can you unmute yourself, please? Is that he? Mr. Hopkins? All right, well, I am so sorry. We let the record reflect that we called the name like 10 times, okay? Maybe 7, but we called it a few times. So we are going to, actually, this ends the hearing on House Bill 340. I want to thank everyone who stayed with us. It's been a long night. And those that are watching at home. And for the committee, can you stay seated for 1 second? And staff, thank you very much. Bring us down, please. It's still on. Have a blessed evening, everyone. Thank you. Feel better, Josh.
He'll be dancing soon.
Thanks. Okay, so for the committee, thank you so much for being so patient and for your questions, okay? And for doing it in such a respectful way, regardless of how we feel personally. I am really grateful, okay? Also tonight, there is a dinner, and they are waiting for us at the Maryland Inn. So really, it's really close to walk. For those walkers that one day I will join your walking group. And